assembly. I'm Dr. Manal Halwani. I will be a moderator in the first session. So the first session will be the challenges with the utilization simulation during COVID-19. So the first lecture will be presented. I'm glad to present Dr. Amira Kalantan. The lecture will be about upskilling provider during pandemic through the healthcare and healthcare simulation. So Dr. Amira Kalantan is the Executive Director of Curriculum and Training in the Health Academy, Saudi Commission for Health Specialty in Riyadh, Saudi Arabia. She is emergency consultant. She did her medical fellowship in Stratus Simulation Center in Harvard University in Boston, and she did her master degree in health profession, healthcare simulation. Welcome to Dr. Amira Kalantan.
Thank you, Dr. Manal. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Wa salatu wassalamu ala Rasulillah. Good morning, everyone. I'm really happy and delighted to be with everyone here today and to kick off our third Society of Simulation Scientific Assembly of 2021. I'm honored to start our talk today, and first of all, I would like to thank the organizing committee and the scientific committee for all their amazing work and preparation for this assembly. So to start off, during the last couple of years, these symbols have become something that everyone familiarized themselves with. It became some of our norm, daily life, to see these symbols and to act according to them. COVID-19 had a great impact worldwide. It impacted everyone around the globe, and everyone on a personal level as well, I'm sure, had their own experiences during the pandemic. However, focusing on how the healthcare providers and what they went through during this pandemic will be some of the focus of my talk today. I will be going back to the beginnings when it started and where there was actual need to prepare the workforce, especially the frontliners, to be able to fight this pandemic and be ready to accept a surge of patients within the hospitals and healthcare facilities. So today I will be talking about upskilling healthcare providers during the pandemic through education and simulation. There was a national movement within the kingdom, knowing that as the pandemic hit in the beginning of early 2020, there was definitely a need to prepare all healthcare providers and upskill certain people, personnel, to be able to fight the pandemic. So my talk today will be covering three aspects. First of all, I'll be talking about the educational response for the workforce upskilling, and then we'll be shedding more focus on our local experience in training and how we did this training for the upskilling of healthcare providers. And finally, I will touch on how we utilize simulation within this program. I would like to acknowledge first that the work that I will be talking about today, actually there was a huge team responsible and behind it. And I'm very honored to be the person to share this information with everyone. I know a lot of the people who are with me, involved in designing these programs are with us today, and I just want to make sure to acknowledge everyone's work within the kingdom for this huge project. So first of all, talking about the educational response. So because of the beginning of the pandemic, there were a lot of information and knowledge that needed to be every healthcare provider aware about. And from that, to upskill all the healthcare providers, we felt that they needed some educational training to prepare them to work within the front lines. So a knowledge and skills gap or areas to enforce within their knowledge were identified. And it's kind of mainly focused in 4 aspects, which is the personal protective equipment, infectious disease, knowing more about the illness itself and disease, the pandemic that is spreading, knowing how to deal with it within emergency and critical situations, dealing with critically ill patients, and dealing with a crisis and disaster. As they're knowing there will be a huge surge capacity of patients coming to other hospitals, and want to make sure that everyone is prepared to deal with that. Thinking about the targeted audience and who will be involved within this training, it was identified that we might have non-healthcare providers that will be volunteering and helping. There might be healthcare providers that they are not specialized with either critical care, emergency care, infectious diseases, or even respiratory disease. So there was a need to identify their specific needs, and there were also specialized healthcare providers where the areas that they needed to be enhanced within their knowledge to prepare them and upskill the workforce to face this pandemic. Thinking a bit about it in a bigger way, the team decided to make sure we focus on the knowledge, skills, and attitude, and making sure that we go focus we approach this in a focused way to make sure we cover all the aspects. Knowledge about, which is the basic information that is needed. There are also skills, clinical skills that are needed to work within the front lines. However, attitude was also very important, dealing with crisis, with teams, and communicating in that difficult time and situation that was there. That said, amongst the discussions the team had, and when we were designing this, we also identified that there was an important aspect we definitely did not want to neglect, which was the wellness of all the healthcare providers. And that was identified that how important it was to make sure that every healthcare provider, it's very important to take care of their own wellness, physical and mental, and how that contributes to the well-being of the workplace. Wanted to make sure everyone is able to support each other during these difficult times. A basic educational approach was utilized. Current 6-step of curriculum design was development. Were also the methodology that was used to make sure that we focus on each area and aspects for this national program to be done, and making sure that we cover each aspect in designing it. So we a little bit talked about the problem identifications and the educational needs assessment. There was very specific, clear, targeted goals and learnings. But when it came to the educational strategies, and here we wanted to think about more innovative because it was some lockdown situation during that time. So what was the best methodologies that you can utilize in delivering this education? So it was decided that it will be an online asynchronous self-paced, so everyone can log in on online educational content and finish it on their own time, knowing that a lot of healthcare providers were actually working and they might have not had enough time to leave or go attend anything, specific lectures. So it was designed as an interactive, that there was more interactive aspect of this online course rather than making it a one-way. There were videos, animations, recorded lectures, and we want to make sure there is some assessment and knowledge checkpoints within it, and some webinars. However, we did talk that we wanted to make sure there are also some practical skills training. So for that, an educational methodology of a flipped classroom was adapted, utilizing some videos to people to prepare them to look and understand more specific skills. And then simulations were implemented, and I will talk about it later in my talk today, along with a competency checklist to make sure that everyone achieves what is expected from them to become competent from certain skills. So that was the general approach that we had in thinking about this from an educational perspective. So more in details about our local experience and what we did for this training. Actually, 3 programs were designed and launched. The first one was the medical volunteer training program, and that was aimed for non-healthcare providers who wanted to volunteer and work within some facilities. I will be not focusing on that today. I'll be focusing more on the other 2 programs, which were the COVID-19 critical care crash course, the essentials for non-critical care physicians, and the COVID-19 Critical Care Advanced course, which was designed for specialized people who work within the critical care. About our COVID-19 critical care crash course, or what we called the 5C program, its aim was to provide basic knowledge and skills to successfully manage critically ill patients who are suspected or confirmed to have COVID-19 infection, specifically in the critical care settings. The targeted audience who were physicians who did not receive prior formal critical care training, and it was part of the national preparedness plan within the kingdom. The impact of this program was expected to increase the patient-physician ratio, hence increasing the healthcare institution capacity to manage increasing numbers of critical ill patients who are expected to come during that time within the pandemic. So the program was comprised of two major components. There was the online part that I talked about and the practical hands-on training. Everyone needed to complete the online part successfully in order to proceed to the practical hands-on training. We kind of divided it to three major milestones. The milestone initial was in online self-directed learning that needs to be finished. Then they moved to the webinars and online lectures, and then they moved to the practical simulation. A little bit more information about the online material that was provided. There were like 4 lessons that covered critical care elements, basic airway management, and general infection prevention and management of infectious disease. And that were the basic information that were needed for anyone who worked within the area. The virtual didactics or lectures, there were 4 focused lectures on, first one was on infection prevention and control measures. The second was the essentials of critical intensive care for non-intensivists. And then we started to make sure that we focus on the non-technical skills, including the risk communication and interprofessional practice and working within teams, especially in critical times and critical situations. And the most important lecture that we really believed we wanted the investment was in taking care of you and making sure of the physician and healthcare provider wellness and how they can cope within this situation of the pandemic and the overwhelming number of sick patients. So that was the first course. The second was the COVID-19 Critical Care Advanced course. And in this advanced course, the aim was to provide practical approaches on managing critically ill patients who had suspected or confirmed COVID-19. And when we designed this course, it was actually after there were a lot of updates and guidelines that were published on a regular basis, almost on a daily basis, that were either shared through the WHO or locally within the Ministry of Health. And it was a lot of overwhelming updates and information. And we wanted to collect that all in one place for people who work within the critical care area, so could they go and get updated and get all the knowledge that it needed from one place. So the target were physicians who work within the critical care areas, and the impact that we wanted from this program was to increase the awareness of the current guidelines and updates on COVID-19 critical care management. And also we wanted to focus again on ways to stay safe and well during the work in critical care areas. This course it was an online course as well. It included 2 interactive case simulations for all the participants to be engaged in, and they actually had to manage some sick patients who were suspected to have COVID-19. And there were online 2 learning modules that was COVID-19 ICU management and also staying safe during COVID-19. So this is just a screenshot of what was on the online course that talked about their simulation, the videos that they needed. We made sure there was a related resource like library area on the website so everyone can just log in every time, and we make sure we updated that on a regular basis with the latest guidelines that were published. Again, there were 4 modules, 2 simulations, which was, you can see here, it was Ali and Dalal. There were our 2 computer-based simulations, and that ICU management and staying safe. So those were the 2 courses that were done locally and were available for all the healthcare providers to take for free, and it was available for everyone. So we'll move forward towards the simulation utilization for how is simulation used within these 2 programs to upskill the workforce during the pandemic. So there were actually 3 major methodologies that were used to integrate simulation through this educational training. First of all, well, videos, but these videos were utilizing simulation and how to make sure that everyone stays safe. These videos were done in simulation centers, and we thank everyone who was helped and volunteered in directing and getting these videos done. The second was computer-based simulation, and the third we're actually using the simulation, which were task trainers and high-fidelity simulation, and that was the most challenging part. So just quickly going through the videos. So the way the education was designed, we wanted everyone to watch these videos that utilize simulation on basic skills, either clinical skills utilizing task trainers. So those were phase one of that. They need to watch all the videos that include procedural skills training. The phase two included videos on non-technical training, which is simulation cases, and mostly focused on crisis resource management and how to deal with crisis within a team and in an emergency situation. So a full video utilizing a simulation scenario was designed and developed with correct actions and how to improve it during the training. After that, they were allowed to go to do the practical trainings. So these are just screenshots on the online learning platform with the videos. And you can see that there were some skill videos and specific ways on utilizing some how to do procedures or utilizing certain equipment and machines. And the fourth video was basically a video on a simulation scenario on crisis resource management. After each video, there was a small assessment quiz, making sure that the major takeaway home messages were actually provided, and the learners and participants got the appropriate knowledge and information that are needed. So I'll talk a little bit about the computer-based simulation that was designed, and we're happy that we were able to collaborate with a specialized team in designing these computer-based simulation in a gamification methodology of education as well. And actually within also the computer-based simulation, a lot of rules were we made sure that they were provided, and instructions on how to play the simulation online, and we wanted to make sure everyone got engaged and dealt with these scenarios as real patients. As they went through each step during those computer-based simulation scenarios, they had a lot of questions that they had to enter, and they got different answers, and it was mostly a little bit adaptive. So depending on your answer, the patient either deteriorates or responds. So this is our first patient, which was Ali, who was presented to the emergency department with unstable, very sick. And as you can see, there are monitors, and as they proceed within the scenario, they get different information. Our second case was about Dalal, who had deteriorated within the ward and needed to be shifted to the critical care area. And it was a lot of interactive and want to make sure that it also had the local aspect and culture-wise and the system that we work in within the kingdom. So last but not least, and this is the most difficult part, is actually doing some practical training utilizing task trainers. And this was done all over the kingdom and a lot of cities within the kingdom. And it needed a thorough planning and collaboration with everyone. And it was an amazing experience, as everyone within each city made sure that they participated and were very keen on making sure the workforce within those cities were ready and trained within certain aspects. So to enable the team to do that, there were a lot of meetings done. And in each meeting, we sat down with the team, explaining with them there was an introductory meeting, understanding the overall program, the expectation, what needs to be done. The other meeting was the implementation plan, how it's expected to them, what they need to prepare. And the third meeting were with the specialized trainers who were actually going to conduct the sessions. And we provided everyone with checklists and information to make sure that they are able to provide the practical training as expected. This just shows us a flow chart on how it was done. We did an introductory meeting, and it was all online, by the way, just to make sure during that time it was a lockdown, and there were a lot of social distances and restrictions. So it was all virtual meetings done, and everyone collaborated on that. The formation of in each region and city of a group that was responsible of this training. A follow-up means things were done until the launching of the practical component. We made sure that there was a good support for each area, and if there's any challenges that rise, we see immediately how can we help in providing that. So in the next couple of slides, I'll be sharing some pictures from each region that participated in that. We had a lot of pictures, so this is just selective. I was not able to put it all during to the time, but I do not own these pictures of myself. I'd like to thank everyone who shared this, and a lot of them, I'm sure they are here with us today. And they're very, very proud of how everyone was able to conduct these sessions, complying to the restrictions and social distancing as well, and making sure that everyone got appropriate training through that. These are some pictures from Jazan region, Medina al-Munawwara, Jeddah, Mecca Mukarrama, from Tabuk, Al-Qurayat, from Al-Ahsa. A lot of pictures from the eastern region as well. Hafr al-Batin. We have Najran, the northern borders. Al-Tayyib, also from Al-Qunfuda, Qasim region, Hayil, and last but not least, Al-Baha. And these are just selected pictures, and it was very amazing how everyone's response and their contribution and collaboration in making this training happen and complying to the restrictions as well. These two program training were able to be done over 20 cities within the kingdom. Over 4,000 healthcare providers were trained for the 5C program, and over 3,000 were able to participate within the advanced course as well. The target was actually achieved over 161% of the expected training physicians to upskill these healthcare providers and prepare them to face this pandemic. I'm very proud to be part of this team, and again, it was an amazing collaboration with a lot of experts all within the kingdom who were able to design this and prepare this and upskill all the workforce and prepare them utilizing education and simulation. It is said the future depends on what we do in the present, and during that time, I believe this was one of the amazing responses towards the pandemic, utilizing education and simulation, and that helped a lot to where we are here today within being able to have less restrictions, even though there are some talks of some new variants appearing, but making sure that we have a lot of lessons learned and how to utilize that information and making sure we build on it. And we're being very proud to be able to respond in this way and utilizing education and simulation, and how important it is to be part of the planning within disasters, pandemics, and crisis situations. Thank you all for your time. If you have any questions, I'll be more happy to respond.
Our next lecture will be a tele-interprofessional in healthcare initiation and limitation during COVID-19. Ms. Uhood Al-Utaibi is the speaker. She is the supervisor of the interprofessional educational unit, and she is the nursing specialist with the 9 years of experience in education. She is the BLS instructor and national speaker in clinical teaching and training. Welcome to Ms. Uhood Al-Utaibi.
My presentation. I couldn't find it. Yes. يس طلع بس انه ما اقدر احركه. Clicker, yes. It's not working. Still is not working. Can I start? Should I start? Good morning, everyone. Thank you for having me. It's a pleasure to be with you all today. I'd like to thank Dr. Amani for this opportunity and for this invitation. And I'm impressed with all the effort that the scientific committee and organization committee put in to create this assembly. And this is Uhud Al-Utaybi, Supervisor of Interprofessional Education Unit in the Simulation and Skills Development Center at Princess Noura bint Abdurrahman University. The topic of my talk today is Tele-Interprofessional Education Initiation and Limitation during COVID-19. First, the outlines are Tele-Interprofessional Education Concept, initiate tele-interprofessional education learning experiences, limitation of tele-interprofessional education applications during COVID-19, tips for successful interprofessional education learning experience. At the end of this lecture, I'm expecting from the participants to be able to define tele-interprofessional education as pedagogical approach, understand the importance of interprofessional education and its core competencies, identify the initiation process of tele-interprofessional education learning experiences, identify ways to overcome challenges in tele-interprofessional education. Firstly, from where did we get the idea of interprofessional education? We got the idea from the WHO Framework for Action on Interprofessional Education and Collaborative Practice. The WHO recognized this framework as innovative strategy to improve the intercollaborative or the interprofessional collaborative practice in the healthcare settings. Basically, they said we need first to assess the local health needs and develop the interprofessional educational programs in our formal education, in our undergraduate study as curriculum, courses, sessions. Then from these programs, we will have collaborative practice-ready healthcare providers. What does that mean? Or what does collaborate for practice-ready healthcare workers or practitioners? They said these practitioners know how to work in an interprofessional team and competent to do so. So now, what does interprofessional education means? Briefly, interprofessional education refers to occasion when students from two or more professions and health and social care learn together during all or part of their professional training with an object of cultivating collaborative practice for providing patient-centered care. Mainly, let students from different professions, nursing, pharmacists, physician, PT, RTs, more than two professions to learn and have their training and learning together. This is what does interprofessional education means. What does intercollaborative or interprofessional collaborative practice means? This intercollaborative practice A course when multiple health workers from different interprofessional backgrounds provide comprehensive services by working with patients, their families, carriers, and community to deliver highest quality of care across settings. And I think you cannot see the slides. Is that right? Okay, so hear me. I think I have a great voice, so just hear me. Okay. The mode of delivery we have used when we from our experience with interprofessional education, we use the tele-interprofessional education. So can I? No? Okay. So what the mode of delivery we have chosen when we decide to develop interprofessional education, we chosen a tele-IPE during the COVID-19, just to let our courses go on during the pandemic. Can I share the slides now? Okay. At least I can see my slides. Okay. So we use of electronic information and telecommunication technologies to support long-distance learning, which enables 2 or more students from different professions to engage in a simulation-based experience. So it was a simulation-based experience. We want to deliver it online on an online platform to achieve shared or linked objectives and outcomes. This was our experience with the tele-interprofessional education. So if you want to develop interprofessional education programs, curriculum, sessions in your education, you have to be aware of IPE core competencies. And the first steps needed to implement the core competency is to ensure that faculty, educators, students, and practitioners are all aware of these competencies. These competencies are value, ethics for interprofessional practice, roles and responsibilities of other healthcare professionals, interprofessional communication, team, and teamwork. I'm 100% sure that all of us were well aware of these competencies, but we don't recognize them as interprofessional education core competencies, and each one of these competencies has sub-competencies as well. So if you want to develop your interprofessional education, you need to be aware with the competency and its sub-competencies. Okay, so why the WHO recommend and encouraged us to develop interprofessional education on your programs or in your curriculum or in your education? Because evidence-based says interprofessional education and interprofessional collaborative practice can close the communication gaps, enable comprehensive patient care, minimize readmission rates, promote patient-centered care, prevent medication errors. And we know that the medication order go through more than one healthcare profession. So if nurses, physicians, pharmacists have their learning together or have their training together, that will prevent medication errors based on the evidence base. Okay. If I want to plan or initiate a tele-interprofessional education and let the students from different professions get their learning and training together, what should I keep in mind first to initiate that or develop that program? First, I need to do self-reflection, learning needs assessment, self-reflection for my status as educator or as educational institution in terms of interprofessional education. I'm aware of these competencies and I'm really implementing this in our education. And at the same time, I need to assess the students' needs, learning needs assessment. Some of the educators thought that I'm experienced and I know my students well and I don't need to do learning assessment. I know them better than themselves. No, I'm saying this to you. No, don't do this, please. Please always go for learning needs assessment. You need to ask your students about their learning needs. Then build foundational knowledge, get familiar with core competencies. You have to be aware with the competencies and how to implement these competencies, how to use them appropriately. Use the power of a practice experience. Now it's your turn. You are the expert, you are the healthcare provider, you have the experience, so you can match the learning needs assessment with your experience in the health setting, and you can find the perfect situations and conditions that the students need to be trained on together. Resource and technology or online connection, you need to choose the appropriate platform if you want to broadcast it online, and I'll talk about this in details later on. Systematic assessment, if you want to assess your students or participants through the tele-IP, you have to have a well-tested and validated tools. And the most important thing is to find an IPE champion in different profession. If you have IPE champion with different professions, that will make your educational content stronger and comprehensive. Okay, what we faced in our experience with tele-IPE, the common barriers or challenges that we have faced, we decided to record 2 simulation scenarios and broadcast them online. We will do the live streaming of briefing orientation, then we will broadcast the 2 simulation scenarios online, 2 rooms, and then a switch. So at the end of the day, each group will have 2 simulation scenarios, then we will do the debriefing, live streaming debriefing. The first challenge that we faced during that time, or during the COVID-19, the scheduling and online lectures. Too much online lectures on the students' schedule. The students are from different professions, different faculties. We couldn't get them available at the same time. We postponed that session or the training experience or learning experience 3 times till now. We couldn't conduct it because of the scheduling and online lecture. And that also because the lack of a perceived value of IPE. Some of the faculty not valuing interprofessional education, some of the students as well, because they are not aware of the importance of interprofessional education, how it's important to learn and get your learning and training together as different or a multidisciplinary team. That was one of the challenges. The third one was logistical and resources issue. When we decided to record the videos, we didn't choose the appropriate platform. The videos were too big on our online platform and we couldn't upload it on this. When we changed the platform, we found some of the platforms we don't have access, students don't have access as well, some of them not available, some of them need budgeting, we need to cut off some of our videos and the learning objectives will be affected. So please, if you are planning a tele-education or tele-interprofessional education, you need to match your educational material with your online platform. Okay, how to overcome these barriers? I think this is the time of having IPE curriculum with IPE simulation scenario and the undergraduates curriculum to integrate IPE curriculum in the healthcare curriculum. If it's integrated, if we have IPE curriculum integrated in undergraduate curriculum, that will facilitate our work and we will have a schedule session, available time for students to be learned and get their training together. Appropriate online platform and technology availability and access. Always match your online platform with your educational materials and have shared mental model. We need to raise the awareness of the importance of interprofessional education among the faculty members, the colleges and the students themselves. Okay, the last thing I want to share with you is some of the tips for successful interprofessional education learning experience. Step 1 is start networking. You need to have an IPE champion in different professions. That will make your educational material comprehensive and strong. Tip 2, pick a topic that different professionals engage in together in the real world, and cross-curriculum topic that more than one profession can participate in. Don't try to include every profession, and this mistakes what the most of educators when they developing and designing interprofessional education fall in. Don't try to include every profession. If your education material or simulation scenario needs physician, nurses, pharmacists, keep it at it is. Don't try to add extra a profession to make the scenario or to make your educational material comprehensive or attractive. Don't make this. That will take the educational material away of the learning objectives. Consider the timing and the time needed for technology availability and access. The end. Manage your professional identity appropriately. And this is linked with start networking. If you have a multidisciplinary team with you when developing interprofessional education, that will make your education material comprehensive and protecting the identities appropriately. And as a nurse, I can know where I start, where I stop, and the physician can add where his role start, where his role stop. If I will write the whole scenario, I will be there will be a bias when you are creating the roles. I will make the nurses the most important one in the simulation scenario. So you need to manage your professional identity appropriately and define the role and responsibility equally in your education material. That was the end of the lecture. Thank you so much for your attention and listening. Thank you.
Hospital. Dr. Jalil has spoke at various clinical simulation-related courses and conferences.
How will I get my presentation? Okay. Well, thank you very much for all the organizers, scientific committee of Saudi Simulation Society for setting the scene to run this wonderful conference assembly. And thank you very much for giving me this opportunity to talk about on the human factors, especially in context of the COVID-19. And as you could see, the human factors are playing the role here as well today. So technology is a man-made human factor, which at the moment we're struggling. No presentation, no. Use the clicker. Clicker to click what? There is no presentation. Okay, okay. And the second safety issue which I faced here is the wire. So I already tripped myself once and managed to undo this laptop wire. So we'll just wait till they have my presentation and then we can start, inshallah. Okay. Okay, so Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyid al-Anbiya wal Mursaleen. And thanks again for Saudi Society for giving me this opportunity. I'm Saeed Jamil. I'm a pediatric consultant here. And welcome to our institute. So we are the host as well. I work here in this institute as a consultant pediatrician, and I have a strong interest in simulation as well. So today, my talk will be divided into two halves. So in the first half, I will briefly recap the concept of the human factors. And in the second half, I will discuss how the human factors has played a role in COVID-19 pandemic. Those who know me, this is my area of interest, and I have been talking on the human factors a few times before. So I'm going to go very briefly on some of the element of the human factors. So we'll start with the definition. So human factor involve all aspects of the way humans relate to the world around them, with aim of improving operational performance and the safety. There's a multiple definition, and I think this picture, if you could see, is nicely explain the human factor interaction with the environment, people, systems, tools. So everything we interact in our work could affect in terms of the human factors. Now, when it comes to the patient safety and errors, and again, I have presented this slide, so some of you might have recognized that. Most of the error which has been reported, either UK data or the US data, is mainly related to the human factors, which I will be talking a little bit more detail in the next few slides, communication and the situational awareness and task completion and all these things. But actually, I will show you the next slide, which is the most recent data by Stephanie and colleagues from the US, just published this year, where they look on all the children's hospital in the United States, and they look on the top 3 reasons for the mistakes, and again, they were the human factors. So the first one was the failure to recognize or lack of situational awareness, and the second was a process failure, and third was the communication. So again, I mean, this is not something new. We know this, and there's a literature full with these evidence that most of the time we as a health professional do mistakes, or actually in some terminology slips. Then it mainly the human factor, not the equipment, and not the knowledge, put it this way. And again, I'm sure you have seen the Swiss cheese model. Some of you might have fed up with seeing this model, but it's very important. It's keep reminding us that the mistake does not happen with one single event or one single mistake. It's a cascade of the disaster. And as you could see in the Swiss cheese model, it is a mixed messages, incomplete procedure, inadequate training, and on other level, institute, organization, team, individual, multiple level. When the problem happened, multiple level, then a serious incident happened. So the solution is improving the human factors, and through the training, through education, through simulation. That's what our aim is. And as I mentioned before, I have talked about these models before in the previous presentation, so I'm not going to go in much detail about these models. But as you could see that, I think she's flipping too quickly. So yeah, as you could see, the crisis resource management, which is the common model, lot of ICU consultant or emergency medicine consultants knows about it. We have a Teams model, we have a SEEPS, HFI, and the Shell model. So all of these models I have talked about before, and I'm just going to show you. I'm not going to go in detail, but I'm going to highlight you the couple of aspects of the Shell model, which is very important in terms of understanding the role human factors played in COVID-19 pandemic. So the Shell model stands from the software, hardware, environment, and liveware. And I want your attention mainly on the environment aspect of the Shell model, because this is the key thing which happened in this extraordinary circumstances which we have faced or still facing, that the pandemic came and the healthcare facilities were overburdened. And as you could see on this model, the environment do play a major role in terms of the performance. So the noise, temperature, light, physical space, time of the day, how tired you are, and how well you are, and it's all affect in terms of the performance, and which we know what happened in the COVID-19 pandemic, when the people from different part of the world were overwhelmed with the disease burden and with the patient burden, which we will talk in the next few slides as well. So, and again, the Teams model, which we have discussed before, is the model which focus on the soft skills, especially the leadership, situational awareness, mutual respect, communication, and all these soft skills you call non-technical skills, you can call the human factors, plays a major role in terms of the human performance. And we're going to discuss this with the COVID-19 pandemic. So here we are. So we all know that the first case was around end of the 2019 reported by China, and then the 2020 March, the WHO declared the pandemic, and gradually the infection was spread around the world, and we all gone through with this pandemic, or actually still going through with this. And as Amira mentioned, the new variants are coming and the new challenges are still around. So we haven't completely come out of this pandemic yet. And we know these figures. This is the most recent data yesterday, that the billions have been affected. There is millions who've been passed away, unfortunately, and we're still battling with this pandemic as well. Now, coming back to the human factors, how the human factors have played a role in terms of managing COVID-19 pandemic. So I'm going to talk a little bit about and we've seen these pictures. I want to highlight these pictures to remind you that what happened in different parts of the world. So we all seen these pictures that people have overwhelmed in terms of the health needs. People were queuing outside the emergency departments, inside the corridors of the emergency department, and part of the world were struggling with the supply of oxygens. So we have seen all of that. And we have seen this side of the story as well, that how quickly we resilient human have come across with the ideas and managed to build these makeshift hospitals over the weeks and kind of days, and start treating the patients in these big facilities, stadiums and exhibition centers, and I'm sure you've seen all of these pictures. Coming back to the human factor. So first factor I want to highlight here is the leadership. Now, a lot of this talk is a literature review. There's a lot of literature out there which have reviewed the leadership role positively or negatively in terms of the managing COVID-19 pandemic. Okay, and I'm going to briefly talk about in the next slide. Unfortunately, in 20 minutes, I cannot cover everything, so it will be a brief overview of these elements of human factors and how they played a role in the COVID-19 pandemic. So there are success stories, there are failures as well, and I'm going to put these pictures, and you can guess yourself who did what. So everybody quote the New Zealand, Jacinda Ardern, that her strategy was very successful in keeping the New Zealand out of the pandemic for the long time. And obviously it's a multifactorial. I'm not taking the credit of the human factors only. It is a multifactorial story. But at the same time, we know that the countries who we thought have a best healthcare system and the best resources unfortunately could not perform very well. So the highest death rate and the highest infection rate was unfortunately in the US and the United Kingdom. And I have to say the human factors do play the role. So in terms of situational awareness, in terms of decision making, who did the situational awareness at which level, and who did the prompt decision making of social distancing, of face masking, of self-isolation, of lockdown, whatever. So all of these experiments which we have been going through and have told the world that who was early and who was late. And I'm really proud to present this picture as well, because we have to be proud that how successfully we managed the COVID-19 pandemic in this country. And again, it goes to the human factor. So the leadership from top to bottom, whether it's the top leadership of the country or whether it's a leadership of your own hospital. So everybody was very focused and very clear. And I think I have to say at this point that the decision was taken very promptly, appropriately, and alhamdulillah, we are in the very good shape. And this is again the data from yesterday. So we have hardly 2,000 active COVID cases in the whole kingdom. And if you could see from the bottom graph, I'm not sure it's very clear or not, which is the Wall Street analysis yesterday, that the Saudi Arabia is still on the top in terms of facing the new Omicron virus. So we are 24 in the world in terms of facing the new challenges which these COVID-19 virus keep bringing. And we are very well prepared if the next wave of the COVID-19 will come. So that's about the leadership. And as I said, we don't have time to discuss in more detail. So just the brief outcome of the leadership analysis as a human factors. Now, literature is full with the human factors analysis. And as I said, I cannot review the whole review in this short talk. And there's multiple articles which have been published across the globe. And I'm going to just give you a brief summary for some of the key points which I thought important to share is in terms of the learning point, and important to kind of acknowledge them should we have another pandemic or should we have another wave of the coronavirus. So safety problems, which is very important, which has been highlighted. And safety problems are direct core of the human factors because they directly affect us, you know. And as I mentioned you with the Shell model before, if you as a healthcare provider have been affected by the factors around you, your performance will decrease, the chances of the mistake will increase, and the quality of the care will not be optimal. So here are the four important things which has been highlighted from the literature review. The fatigue and the burnout, which was one of the top element which has been noticed during the pandemic by the healthcare providers. Absence of the trust among the care team members, lack of adequate time for patient or self-care, and lack of psychological safety. And I'm going to briefly go through with some of them in a little bit more detail. So this was the first study again from China, Henan province, and where they concluded that the fatigue and the burnout is very common, and because they are the one who faced this first, and they concluded if we have the explicit evidence-based infection control guideline, we have customized equipment and specialized facilities, this can certainly decrease the burnout in the healthcare providers. Another study from the China where they looked the importance of peer support and the crisis communication, and they highlighted that the resilience, the crisis communication, and the staff support are the three key elements which can again reduce the fatigue and the burnout in the healthcare providers. Another study by the Italian colleague, because they are the second one who faced the pandemic and the disease burden before it came across the world and to us as well. And they find this if you remove this stigma of help-seeking behavior, and then if we increase the peer support, then certainly we can decrease the burnout and fatigue in the healthcare providers. Now, I've got Tariq Hazwani sitting in front of me, and I remember when the pediatric intensive care in our hospital faced this challenge to looking after 70 years old. I mean, imagine how can they do this? They've never done in their life. They were never trained. So people have seen this extraordinary challenges to having a new teams, to having a new area of the clinical medicine which they have to face and cover. And obviously this result in the new team formation. So obviously if you have a new team, you don't know the team, your trust level will decrease. I mean, luckily we did not get to this point, but in the US and the UK, I'm sure you're aware of, they upgraded the final year student to an intern and resident because there were no option. They needed doctors. So they upscaled, they upgraded. Pediatricians across the globe looked after the adult patient, which they have never done before. So you're all working in out of your comfort zone. You're all working to the area where the chances of the mistake will certainly increase. So how can you cope? And here the human factors comes. And again, I don't have time to go through with all of these team steps tools, but I've highlighted with the red the 3 tools which people have used, and they were very successful. So briefing, debriefing, and huddles. People have used this in the new team formation, and unknown people who meet each other, they don't know each other. So that's the only way you can cope with us. So you've been to the very difficult situation, somebody passed away, or somebody you barely safe, debrief, discuss, unpin, learn from the mistake, learn from the event outcome, and then move forward. So these are the useful tools people have used, and I would recommend to those who still have not aware of them, use in your clinical settings. There was very little time for patient management because of the disease burden, and especially in some part of the world, which obviously I mentioned before, it will definitely has affected in terms of the decision making. These are all the CRM, the skills, the decision making, task accuracy, mindfulness, situational awareness, and information sharing, and these all could have been or must have been affected during the pandemic and looking after the high number of patients. Now here are some of the solutions people have used, and some of the suggestions came out from this literature review. So if we make sure that the staff will get enough breaks, food and hydration, very important. Yes, you're working very hard, you're working non-stop, you got the patient after the patient, you got the patient dying after the patient, especially those who are in the very busy intensive care units. And so these are certainly the elements they have highlighted which will decrease the stressful situation and circumstances. So do look after your staff in terms of proper breaks, proper food, proper hydration, positive feedback, confidence in the infection control, and adequate PPE. And I don't have time to go through with all the stories. I'm sure you have seen the stories in the literature and the media, that how some of the part of the world they have no PPEs. I mean, the nurses was washing their mask and coming back to the next day's shift. They have no gowns to wear. They have no gloves to wear. So they were washing the gloves. You know, I mean, people have gone through with this. So yeah. So and then certainly increase the stress. If it's increased the stress, human nature, it will affect the patient care, and it will make the mistakes happen more often. So here is I put this picture of they call sleeping pod. So the NHS has introduced the sleeping pod during the COVID. It came to the COVID-19 pandemic. So previously there was a myth or taboo. I mean, you are a doctor, you are on an 8-hour shift or 10-hour shift. How come you get a rest? You know what I mean? You're not supposed to take a rest. You know, and if you take a rest, people will say, well, he's making a bunk, or he's kind of cheating from his work. But that's the reality. People get tired. They need to rest. And actually, NHS has introduced the sleeping pod across the country. So now every single UK hospital you will go, you will get the 4 or 5 sleeping pod in the doctor's mess or somewhere, where whoever feels tired can go into pod and get rest for 10-20 minutes, feel better, come back to the work. So that's the way to look after the healthcare staff, to get them out of the stress and the fatigue, and improve the patient care. Now, psychological safety was another major area which has been talked a lot in the literature. And due to the time constraint, I'm just going to go to some of the conclusions and and some of the efforts which has been done in terms of the improving the psychological safety. And the reason were same: unfamiliar environment, new challenges, new team, unprecedented, extraordinary work, which all less in the psychological safety of the healthcare providers. So how can we increase the psychological safety? We can increase with the safety culture, which is not something new. The people like me, or the people who are advocate of the quality improvement, they always talk, Dr. Tassi is here, so they always talk about the safety cultures. So it has to be a culture where everybody can speak up with any little safety issues, and there should be solutions, and there should be people who will listen them and solve the problem. Now, experience of the high-risk industries. Now, I have to say the simulation obviously has done a lot to learn from the high-stake industries, naming aviation, nuclear technology or the nuclear energy, and the offshore drilling. So these are the three key industries who are very high-stake industries. You know, they work in a challenge all the time. You know what I mean? And healthcare has learned from them, and we have to learn more from them. These three industries are ready for any disaster, large-scale disaster, anytime. I mean, alhamdulillah, we got Aramco here. Go and speak to the Aramco safety people. So the people are thousands of people working in the middle of the sea, nowhere. Any disaster can happen. They are nowhere in the connection with the world. They have all safety measures in place and plan in place. Similarly for the nuclear power plants, and so we have to learn more and more from the way they tackle the disaster, and obviously the organizational support and work safety. Okay, so I'm going to conclude with few take-home messages, and I don't know how I'm doing with the time-wise. So strategies to improve safety via the human factors. And I conclude these four things probably have been used and are very successful in the COVID-19 pandemics. And I'm sure my colleague before, Dr. Amira, has used a lot of sign. I mean, she is good in signage. I'm not, and we got Amani here, she's very good, but I'm a very basic in signage. But you've seen all of these, you know, the signposting, signage help the human nature to keep them focused on the task, and they keep them focused on the clinical aspects. And we have successfully used this signposting everywhere, especially our nursing staff. This room is unclean, there is a sign there. This patient is COVID, there is a sign there. And not even for the healthcare provider, for the people as well, and for the public as well. So that's a very successful mode we have used during the COVID-19 pandemic. The second is the checklist. And checklist, honestly, it's another session for 20 minutes if you go with the background of the checklist, that how successfully WHO Operation Theatre Safety Checklist has decreased the risk and the complication associated with the operation. And again, it came from the high-stake industries, which I named you before. And you can see some of the example of our Wizarat al-Sihha checklist and the WHO COVID checklist. So use the checklist, create more checklists. It make people to not, so I don't have time to explain you, but you know, we have two types of memories when we talk about the cognitive psychology. So we have a automated memory, and then we have a more focused, intentional task memory. So, you know, 80% we work in this automated memory mode, you know. So, and nurses, everybody, all the doctors, we work on this automated memory mode. So for automated memory mode, you have these things, skills, checklists, which will keep you focused on the task. Otherwise, you will slip and you will do the mistake. And checklist certainly has helped in the COVID-19 pandemic. Another big area of workflow review and redesigning, and people have done and all of you who have worked have redesigned your workplace, your units, your wards, your emergency departments, and in terms of the patient safety and guidelines. And I think last but not least, I have to say the simulation, which have played a major role in terms of and will play the role in terms of adopting these simulation, these human factors. And I have here we got so optimizing the preparedness of the crisis. And again, I've got our local team here from the PD STEP and from the King Abdullah Specialized Children's Hospital, Zahra and Dr. Hazwani and Ahlam. And they nicely organize all of these different drills, which you could see in the pictures, whether it's a simulation center drill, whether it's an operation theater, emergency department, X-ray department, intensive care, corridors. So they've done all the preparedness that when we have this patient, and how we're going to cope with them, and how we're going to keep the patient safe from the infections, and they try to test, and we can test the new facilities and new workflow issues through the simulation. So I'm going to finish my talk with some of the conclusions and the learning point. So human factors ergonomics is a discipline we talked about that aims to maximize the human performance and the well-being. The extraordinary circumstances we faced due to the COVID-19 resulted in the fatigue, burnout, absence of trust among the team, lack of time, medical illness, poor psychological safety, and each of which can result in reduced performance and contribute to the failure, such as misdiagnosis and adverse effect. How can we cope? Using human factors, enhancing techniques, especially which I mentioned to you, recommended by the team steps and many other human factor engineering models, can improve the staff well-being, and which can result in the high quality patient care which we all aim to provide. And here are some of the references which I used. And thank you very much again for giving me this opportunity. And I'm sure in the end of the session, I'm more than happy to take any questions. Thank you very much for listening.
Our next talk will be the guidelines in simulation operation during COVID-19 pandemic. It will be presented by Mr. Mohammed Al-Amar. He holds a bachelor degree in nursing and a postgraduate diploma as clinical instructor. He joined King Fahd Medical City in 2006 to establish and operate the Clinical Skills Center for the Faculty of Medicine. The center kept growing with new members and leaders until it became the current Crescent, where Mohammed works as a simulation operation manager. Mohammed is a big fan and a member of SimGhost. He served as the MEA region officer since 2015. He is an SSH and Saudi SSH member, worked with many members on national and international level to advocate for simulation-based education and spread the knowledge and skills of best practice through workshops, conferences, and direct training.
Assalamu alaikum. Good morning, everyone, and thank you for having me and give me this opportunity. I'm waiting just for my slides to appear. Okay. So I start by disclosing that I don't have any conflict of interest. This is not to promote any person or company or product, but I will mention some of the national and international institutions and teams that contribute to the success story that we preview here. Next. Okay. So this is related to the mask that I did not remove from the start. So next. Yes. So the first question, do you know this guy with the face mask? I think he's well known, even with mask. I don't know. Okay. So this is the mask effect. This is Mr. Bean. And alhamdulillah that I'm allowed to remove my mask so you know me on this screen. Next. Okay. So I will talk today about the main safety concern in simulation operation. We have a lot. And the simulation safety guidelines and resources, how we get those guidelines in simulation. And I will talk about also the adjustment that we did during the COVID-19 pandemic and crisis. Okay. Actually, the statistics show that the demand in simulation did not go down by numbers. It was actually keep on the same level. So, like in Crescent at King Fahd Medical City, we have pretty the same numbers of training sessions. We have 250 training sessions and more than 4,000 trainees per 2020 alone. And it is actually matching the previous 5 years, as you can see in the screen. And those statistics on the screens are only for the skill lab. We have also the life support, we have the STARS, the surgical simulation, and we have the nursing lab and the in situ training. And I will show you also the operational challenges that we have during the pandemic. Next. Okay. So the simulation operation, for those who don't know, actually, it is the efforts and process of utilizing the available resources to implement the healthcare simulation plans. We are working to achieve the strategic plans of our institutions and also the goals of the simulation center. Next. Okay. The health care simulation, actually, the main definition of the simulation is a safe learning environment, and that it should be always safe environment. As they said, the safety first in everything, especially in the simulation. You don't want to bring people and they may be harmed. So the simulation should be safe environment, like the place, machines, tools, consumables, and a lot of environmental factors. It should be safe to the learners, employees, and everyone involved. And then the physical safety should be also maintained, safety of the people involved, trainees, instructors, staff, and everyone. And the last is psychological safety, and it is very important to keep them safe, especially the trainees, then instructors and staff and others. Thanks. Okay. So actually there was a huge pressure on the simulation operation during the crisis. On one hand, we are required to train people and prepare them to just face the crisis that we have. So we are required to train as much as we can of the staff and as fast as possible. We have a limited time, like 2, 3 to 4 months to be ready. As you can preview, you previewed already with Dr. Amira, there was national efforts and even international to upscale the trainees numbers or the healthcare workers numbers who are able to deal with COVID-19 patients. So we are required to train as much as we can and as fast as we can, and at the same time maintain the quality of the training. And it is really challenging, especially for the simulation centers and simulation teams. On the other hand, there is a risk of safety, the COVID-19 situation, and there is a limited time. And the trainees actually and the trainers are the first liners who are dealing with COVID patients, and we want to bring them all together for the training, and this actually was a risk. On the other hand, also we have limited resources. We don't have that scale of resources to train people on the space. Of course, the PPEs was very limited at that time. We utilized them for the patients. And we have limited simulators, staff, consumables, even PCR tests to confirm that the trainees are healthy. So those are the balance that control our efforts or plans to upscale the training and increase the operation. So we are required at that time of planning to do this target of do 4 courses and train more than 4,000 people within this short time of 4 months from March to June. So we do 5C course and the COVID-19 critical care course for nurses and the physician course, and we have our own courses for KFMC, King Fahd Medical City, to do the airway management in the in situ training for the ICU, ER, OR, and other multiple sites. So the target was really very huge and challenging to achieve it within in a very short time, and it is really the number one challenge was the safety. So what we did actually to achieve that in a safe learning environment, we go back to the references first. So we go to Ministry of Health, Wiqaya, World Health Organization, those other resources to know what exactly we should do to keep people safe and maintain safety in the training and simulation. And then we develop our own guidelines that match our resources and rooms, spaces, and in order to make everything clear for our staff. So we developed the practical guide for infection prevention in the simulation center and life support. And then we plan what to do with the infrastructure and resources that we have. At the same time, we adjust the staff level, the simulation staff level of knowledge and skills in dealing with such challenge. And then, of course, infection prevention guidelines to just publish them and announce them for everyone involved, for the staff, the trainees, instructors, and everyone coming. And we should maintain them in the pre and during and after. Then we start by set those clear instructions and protocols and announce them for everyone who is coming to the simulation or the training. And we make a mandatory step to convert all theories and lectures to online and pre-recorded sessions. So, and that was actually a huge step forward to just focus on the hands-on skills. Then we activate the online links and forms, barcodes, and we limit the door access and crowd flow. So we go to the floor plans and we redesign them and structure them where the trainees will come and where they have to go and from which place they have to go. And we develop the declaration form, which is a checklist, and we activate the tracking of all involved people in the simulation, the participants, instructors, and everyone. We track them all and we get their data so we can communicate with them and keep them informed all the way. Next. So this is one example of the mandatory actions that we take during the the sessions, before the sessions, and in the registration desk. We mandate the protective mask to be on all the time for everyone, and more often of alcohol hand washing for everyone. Less number of trainees. We watch the social distancing and everyone actually required to wear the surgical gloves or latex gloves during the practice on the simulators, and they have to change them every time. So they are not allowed to touch the simulators or tools without gloves. And then we do a lot of service cleaning, mannequins cleaning, instrument cleaning between each group. So if we have like 4 groups, between each group we go in and clean those tools and mannequins to make them safe for the next group. So we minimize the cross infection transfer if it is possible. So, and this is actually support what Dr. Saeed Jamil said about the visual guidance of the people. So we did actually put visual marks on the ground and even on the walls. We give them signage to what to do, how to do, and where. And with the efforts also of the checklist that we developed to check their health status and declaration, so we can track them all safe are to go in the training. So we did this before we bring them to the training. And as you can see in the waiting areas and also in the training rooms, we put marks where they should go. And actually we assign staff from the simulation center to watch those process and orders to be followed. And then, so strict distancing. And as you can see, we did actually pre-recording materials, and we support and we provided to the trainees before they come. So even for some of the practical stations, we record the video and we show them those skills, what they should do. And actually this helps in 2 things: to minimize the stay in the center. It will minimize the time that they have to spend in the center, and also minimize the number of trainees in the same room. As you can see down the screen there, we developed the method, or we utilize the method of record the presentations, so they can, the instructors can record their sessions and put it online. And then this is example of the declaration form that we use, and this is a attendance sheet, and it was mandated for everyone, even the staff of the centers. They have to go to this form every day and declare their status and put their communication or contact numbers and informations, and we make sure that everyone is informed. Even the cleaners of the center, they were required to do this form every day. On the other hand, as we said, the space was limited, and to reach this target, huge target of trainees, it was really challenging. So we have to look to other solutions to achieve this goal. So we minimize the skills lab training, as we said. If we, in the regular days, accommodate like 6 people in this room, now we accommodate 3. So still we could not achieve our goal. So what we did, next. So what we did, actually, we increased the in situ training inside the hospitals, inside the departments. So we ship our mannequins, tools, and everything to the emergency room, and we did pediatric and adult. We ship it to the operation rooms, and there was a multi-sites actually running at the same time. also in the ICU, the pediatric ICU, and other departments as well. And at that time, we had limited resources, like we don't have hemodynamic, more than 2 or 3 hemodynamic simulations. So we looked to the market and how we can find virtual hemodynamic monitor. As you can see here in the left, one of the virtual hemodynamic monitors that can be controlled by the instructor. And also we re-innovate our obsolete models. So we bring them back to life. This is, on the right, actually was one of the mannequins that actually it was dead. It was on the DNR room. So we return it back from the simulation stores, and we utilize them in the in situ training along with those monitors on the left. So that enable us to maximize our resources to do another training in other place or area. Next. As you can see, those are the borrowing data in 2020. Actually, we did 164 actions of borrowing, and that was involve 262 items to be lended outside the center, so they can train in their own departments, especially the nursing department. They use those items a lot, and they can go for one-to-one training, 1-to-2 training, one instructor, one trainee or 2 trainees to do COVID-19 related training. So that was a very helpful action that done by the Simulation Center and the administration. Next. So what we achieved actually at the end of this operation, we trained 550 people in this skill lab, in the simulation center. But the majority of people was in the in situ, in the clinical area. So we trained, we reached our target actually, and we trained 3,700 people in the bedside. And those are the data of 2021 so far until the end of this November. In the whole Crescent areas, we train about 7,000 people with more than 900 training sessions. So those are really a huge number. And actually what was the result of those, following those guidelines and the efforts of the teams inside King Fahd Medical City and the administration. So we achieved, alhamdulillah, until today, 0 infection case reported as a result of training at Crescent. So we achieved, alhamdulillah, no case was reported, even with those huge numbers of trainees and instructors. There is no case reported at Crescent. Next. Next. Okay, so this is a picture of the team who was behind the this huge effort and achievement of the simulation operation. And we did also our best to really achieve those results, but at the same time with safety, keeping safety for everyone. So thank you for the Crescent team. Next. And now the take-home message actually is the same as the Ministry of Health and the government is cautiously we return, and we have to keep committed to the guidelines, and we did and we achieved. So yes, we are going back to the other training sessions and simulations, but also we have to keep the safety first and follow the guidelines by the administration and other resources in this field. And this is the end of my presentation. Thank you for listening, and I'm ready for any question. Thank you.
Can we start? Yeah. So it's my pleasure to introduce our next speaker, Ms. Ghada Al-Mujalli. Ms. Ghada, she is the Assessment Unit Supervisor and Simulation Educator at Simulation and Skills Development Center in Princess Noura bint Abdurrahman University. Ms. Ghada is a clinical nutritionist and a holder of 2 master degrees in clinical nutrition and medical education, and she is certified healthcare simulation educator. And welcome to Ms. Ghada, and the podium is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Thank you so much for the introduction, Doctor. And thank you to the Society of Simulation for their invitation. And I hope my presentation will be Yes, it is. Hello. Okay, so my topic today will be designing and conducting faculty development programs during the COVID-19 pandemic. I thought a lot about what I'm going to present today. Will I be presenting how to design a faculty development program, or what are the challenges that we faced during conducting faculty development program? So I tried to mix the 2 topics together. So I will be talking about what are the challenges we faced when we faced the quarantine after the COVID pandemic broke out, and what are the lessons learned from the literature and from my experience. Of course, I am disclosing that I have no conflict of interest. I am presenting a teamwork from my center, the Simulation and Clinical Skills Development Center in Princess Noura University. Our team made a lot of efforts to conduct faculty development programs and training and maximize the safety of trainers that we take in our center. So faculty development programs are a broad range of activities that institutions and organizations use to renew or assess the faculty in their roles. We talk a lot about topics involved in the faculty development programs. They are professional development, they are career development. They usually target topics of teaching, research, administration, and education. So because they vary in range and the time required for the development programs, we usually divide it in 3 types. So the short faculty development programs, which involve courses, workshops, and seminars. The integrated longitudinal faculty development programs, which are fellowships and long courses. And finally, we involved also the role modeling or shadowing, which involves coaching or personal coaching and self-directed initiatives. Of course, my topic will involve my experience, and I tried to look through the literature about papers that studied the current status of faculty development programs. And what's interesting was a lot of the findings we found in our center were reported in the literature too. So what happened to faculty development programs when the pandemic broke out? My colleagues explained thoroughly all the statistics involved in this pandemics and what the action took by simulation centers, by institutions to address this pandemic, either training or healthcare providers or frontliners. So from my part, the faculty development program, so I'm considered one of the people who are developing and conducting the faculty development programs in our center. So we changed the whole system of how to conduct it. We either done it online or on-site with precautions. Of course, Dr. Mohammed, the speaker before me, details what they did in their center and how they addressed the safety concerns when training participants. We faced a similar challenge in this area. While our center is considered one of the largest centers in the world, simulation centers in the world, what the challenge we faced is because there are a lot of venues and a lot of classrooms, auditoriums, we had to make a very concise and applicable infection control protocol that can be applied and can be used by our faculty, by our simulation staff, and our trainees. So what we did is we did a study of the already available supplies. We had to quickly address the need for faculty development programs. What Dr. Amira talked about, which is the 5C course, this was our initiative and how we pilot the the infection control protocol. So the task force sat together and tried to find a way to implement the training and to optimize the training while keeping the environment safe. So for lectures, on-site lectures, we try to prepare venues for lectures and seminars for the staff and faculty who are not available to come to be online. Of course, we have already an annual faculty development programs for Princess Noura University staff or faculty. It's conducted annually by our center, and that's why we transform it to online format, of course, for large scale. Why we did that is because we are addressing 5 colleges, and it is difficult to find a time that's suitable for everyone or the location, and because of the large number of staff involved. Of course, if we are conducting a practical training for the participants, we had to ensure that it's a safe environment. All PPE and supplies and mannequins are prepared, and all participants are informed on how to safely practice and protect themselves. Signage, of course, was placed throughout the center. And of course, when I looked through the literature, every center usually does this, but what we are currently facing is effect of applying those protocols on the personal level. So what's interesting was when I looked at the literature and we spoke with the faculty who are attending those programs, the faculty development programs does not take into consideration different groups. Of course, the pandemic personally affected everyone. But what's interesting was the literature mentioned that women academics and online learning of their children, for example, or someone who they take care of, they find it that the women academic find it very difficult to attend faculty development programs because they don't have enough time or they are very limited in the way that it can attend. So because we are transferring all faculty development programs online, the problem was that we are doing it similar to what we're doing in the conference. It's not pre-recorded. We upload it online as a video, but some of the organizations did not do that, and that was addressed. On the institutional level, the gap in the faculty development programming and how the institutions choose the faculty development programs. Each individual or each faculty have their own goals and their own aim and how they want to develop their career. But the institution has, sometimes some of the institutions have a different aim. They have a different interest. And sometimes those things do not align. So from my perspective as a simulation educator, I want the faculty who attend the activities to be very knowledgeable about how they conduct simulation activities. But when we talked to the faculty themselves, they were saying things like, okay, I'm interested in how to conduct simulation activities, but the topics you're offering sometimes do not cover my needs. I need, for example, for you to offer me more workshops or more faculty development programs on how to do research. While me, as a simulation educator, I was focusing more on the conduction, on how to do the debriefing, on how to develop simulation scenarios. So this sometimes, the misalignments sometimes happen. And also the institution usually focus on something we call institutional input. So institutional input is what we want to train our faculty. So our faculty, for example, let's take something outside from simulation. We want them to know how to write, for example, multiple choice questions. This is very simple, right? But do we study the output of it? Do we take the multiple choice questions developed by those faculty and see, are they good enough, or do they achieve the courses, the outcome of the courses? This is something simply happen when we are focusing always on the input, but the output is not studied. So we don't know if the faculty development programs are working. Of course, after the COVID-19 pandemic, there's a talk or the sentence I always heard, which is never let a good water crisis go to waste, which means we have a crisis now. Thank God our organization, our institution, our leaders gave us all the support and actions, prompt actions, to limit the catastrophe's result. That's why we need to learn from this catastrophe. So we need to reassess the programming of faculty development program to be able to cater to personal career development. We also need to design and conduct faculty development program that take into consideration the faculty that are still affected by COVID-19. Where still most of our children now go through, for example, online learning. Because some of the working mothers are still working with them and trying to monitor this, maybe those are affected. There are also healthcare providers and faculty who are affected by this. So the institution need to study the current situation and develop faculty development programs that cater to their situation, to their needs, and to their time available to attend those faculty development programs. We also need to consider implementing a hybrid method of delivering faculty development programs that are designed based on best practice. A hybrid method is a very interesting approach to teaching or to delivering faculty development programs. So hybrid is basically when you have, similar to this, you have an audience with you, and you have people who are attending online. The assembly is basically what is this method, hybrid method. If you are planning to conduct this method of delivering faculty development program, you need to ensure the engagement level is high, because I think we saw the human factors now, that the technology is affected, so you have to consider a lot of factors, and we will go through it after the slide. We also consider the strategic approach to faculty development. We have to consider the institutional aim, and we have to consider the career development aspect of each faculty involved, and designing faculty development programs that serve the institutional goals that are also based on best practice. I'm repeating this sentence, best practice, because what we notice is when we take lectures and put it online, for example, we are shifting the method of delivering information or delivering learning objectives. Online learning is very different than on-site learning. The engagement is nearly zero, and you have a very unengaged learner. So you have to shift the method of, the learning materials to fit this method of delivery. So if you are considering online or hybrid faculty development program, I tried to make it very the best practice that I noticed and the experience we saw and I found in the previous papers. So if you are considering faculty development programs, you have to consider participants' engagement. So you can use engagements to improve the engagement. You have to use chat rooms or separate rooms to include the participants. Some of the softwares available now, they have a feature that you can put the participants in groups. They will be in a group separate, and they can discuss if you're planning to do a group activity. You can do that using online format. It's already been done, and it's very successful, and it's very helpful for the participants because now you can make them very familiar with each other, and the engagement will be higher. Of course, all of the literature actually focused on using opening the audio and the face cameras. This was, let's say, to limit the distractions that the participants will have. Because they are online, they will not be available to you. They most likely will put it off, everything's off, and they will listen. Therefore, the engagement is lower. That's why they recommended to let the participants or mandate them to open their cameras and open the audio channels. The second one is technical support. So you have to ensure that the faculty, both the faculty and the participants have good network. Some of the papers recommended that you provide the developers with softwares and the hardware required to develop the faculty development programs. And for the designing of the faculty development programs, as I said before, you have to consider, because it's online, it's different than on site. The engagement is very low, so you have to redesign it again and consider it, design it using models like ADDIE model or Kern steps, 6 steps. So when you design it like that, you will keep in mind what are the obstacles, what are the challenges, and you will cater more to the methodology of delivery. If you are considering hybrid faculty development programs, online participants and on-site participants, similar to the technical support and designing faculty development programs, you have to redesign all your materials to fit this methodology. The venue itself, you have to ensure, because we are still going through the pandemic, you have to ensure that you have a very strong, rigorous infection control protocol. And for the participant engagement, in addition to the cameras for the online, learners, you have to keep an open channel of communication between the participants in the site and online. You have to keep it on at all time. This way, they will keep working together. They also recommend that we put the online group with the on-site group, and you have to ensure also that you are doing exercises that can be implemented in this format. So, of course, you can do any practical training using both methodologies of delivery, but those are very useful if you are planning to conduct a training prior to practical training. Those are some of the references I used. Thank you so much for listening.
So we reached the end of our first session in the morning. As we are running late in the schedule, we will cancel the panel questions of that session, and we're gonna have break only for 10 minutes. Thank you.
السلام عليكم.
وعليكم السلام.
مرحبا. أخيرا أتكلم. Sorry, I كنت حاطة الميوت on, that's why.
No, it's fine now. Thank you.
مرحبا، أنا هدى الفودري من الكويت. السلام عليكم. وعليكم السلام. صوتي واضح؟ اي واضح، أنا أسمع واضح. عفوا، سؤال بالنسبة للأسئلة. لأن I'll be taking the questions راح تكون محطوطة بالchat box. I believe so. Okay. السلام عليكم. السلام عليكم. أهل الخبر، تسمعونني؟
الصوت عندكم لو سمحتم بس ميوتد. في حال بس طلبنا منكم مداخلة تفتحوا الصوت لو سمحتوا عشان في عندنا رتور.
On the queue, on your queue. عفوا أنا بعثوني لينك جديد للزوم. Is this the Zoom link للمؤتمر ولا لازم لينك ثاني؟
هذا نفسه.
اوكي انا بعثوا لي لينك ثاني قالوا لي استخدمي هذا اللينك بدال اللي تستخدمينه لانه مو قاعدين يشوفوني. يعني ما احتاج استخدم اللينك الثاني صح؟
Can you hear me?
Yes, I hear you. يلا.
We can start.
طيب تمام. Okay.
On your cue, once you're ready, just tell me to start.
طيب طيب
I can start. Can I start?
Yeah, left click. Yes, okay, control. Okay, start.
Assalamu alaikum wa rahmatullahi wa barakatuh. I welcome everyone everywhere, Jeddah, Riyadh, Al-Khubar, and those who are online for the second session of day one of this scientific assembly. I would thank the scientific and organizing committee for their tremendous efforts to put all this magnificent activity all together. Without further ado, I want to welcome our first keynote for day one, Prof. Abdulaziz Bokar, the President of the Saudi Society of Simulation and Healthcare, and the Chair of Department of Anesthesia and Critical Care. He's a professor in anesthesia and education and very well-known figure in simulation and the father of simulation, if to be more accurate, in Saudi Arabia. I welcome you, Prof. Bokar, for his keynote. We'll be discussing running the simulation center during COVID-19 and during those challenges that we all faced during COVID-19. Prof. Bokar, تفضل.
Dr. Rola and the rest of the moderators, thank you very much for joining us today, and it's an honor to be part of this event. And also I would like to thank the previous speakers because they covered most of the things, so I will be shortening my presentation to keep in with the program. So if I can have my first slides on the talk, please, on the show. So running a simulation center during COVID, actually it was a great opportunity for simulation education nationally and internationally to showcase the outcome. This is King Abdulaziz University where I work and will be presenting most of the work. This is the hospital where my daily living is, and I'm working with a great team of anesthesia critical care department who is a big support. Of course, this is part of what the society do here, advancing simulation practices together in this and other with cooperation collaboration with the Ministry of Health, and I hope the coming 2 days, today and tomorrow, will bring a lot of activities and collaboration and networking like others. As I said before, many of the speakers today covered the practical aspects that I was trying to cover. So I'll be more moving to secondary objectives, how to use principles of learning to integrate simulation at a large part for previous crises or any other situations or new surfaces, and how to enhance engagement with audience and with organizational needs in simulation. Simulation is not different than any other leading industries like engineering. We always plan, do, check, and act, and go back. And this is the way that people go to space and come back, is to have these experiments, always planning, doing, checking, and acting. And this is what is simulation, to prepare individual organizations. And this is how we get back. So why simulation? A lot of reasons, and the uses and the future for this. So we know that adults learn with there is a problem, there's immediate need to solve problems, and that's why simulation, if you tailor it well to the problem like the COVID-19, people will be prepared either in situ or in the simulation center. Of course, simulation has been used widely to prepare for COVID emergencies everywhere, and the experience started from China to Europe to America to us, and we gain advantage by having everybody grow this cycle of work as imagined and work as done, and then going back and forth on these rotations in order to implement simulation from being a concept, new guidelines, to real life. In our hospital, at our center, as many other centers, we start planning. We had an active engagement from all departments. We're doing in situ, and in the simulation center exercises, a lot of debriefing, lots of people worked on this, and then developing protocols to implement this and bring safety to the, and we used a lot of the valid check forms or frameworks for micro check, debriefing, briefing, hurdle, and going through these cycles. And the system introduced by the Harvard group, the SMS, talking about how you could do the same techniques during any shift or any simulation crisis or any future crisis. This is what we used during the last few months or during the last year with the crisis. And of course, as colleagues from Crescent and other centers, it is very highly effective to safeguard against institutional infections by having effective training. And our data coincides with the early data from UK that if you train people, you save the healthcare worker. Actually, most of the infection at healthcare institutions happen in the back sides of the hospital where COVID patients are not coming. Training was not focused, and that have led the importance of so of course, during COVID, simulation was used to test new systems, and this is the studies from Crescent, how did they use, and they published their experience in preparing organizational changes, implementing and spreading the fact that these useful tools could be shared from one institution to another. And that has been a great example of the progresses that we've done in Saudi Arabia in bringing simulation. Of course, this has been done at many experimental models, how to save against aerosolization and infection, how we test new systems, new equipments, new ideas during COVID. This is all has been covered using simulation. Of course, what if we need more ventilators than we don't have. Of course, that has been also tested by simulation, simulating how we could use. Of course, alhamdulillah, I think not here or many other countries, we never needed to use one ventilator to more than one patient, but simulation has been used to prepare even for the eventuality that we have that crisis. Again, different types of interventions and treatments. And of course, this has been done like in Saudi Arabia, like in other places, in Canada, Europe, and also in Saudi Arabia. We published our international experience in using simulation for critical care, and this has been published recently. Of course, if you want the guidelines from the Saudi Society of Simulation in Healthcare, led by the scientific committee, led by Dr. Taqwa Omar and her team, published the guidelines for the roadmap for using an operating simulation center from the planning through running till exiting, and these are all available in our website, and it's very useful guide for during the COVID, now and in the future, because the world is different. We will not be back to pre-COVID areas. Again, I'll be just some of our experiences at our simulation center from King Abdulaziz University. As you know, our simulation center has been one of, we are 40 plus great team who are doing a lot of these works, supported by the hospital. This is our vision, mission, and goals for the simulation center at King Abdulaziz University, and the center has been accredited by Royal College of Canada, American Society of Simulation, and we got the Emmy Award for Excellence in Simulation Education. That all helped us to prepare for this upcoming epidemic. We started very active planning, as many other centers, to prepare the hospital, the institution, the university, and maybe other centers to prepare. We've had a lot of energy going into this. It was a tough time, but we had a lot of support. Those are the courses that we've conducted over the first 6 months of the epidemic. 147 BBE course, 8 activities for 5C, as Dr. Amira explained, and difficult airway. We've had over 100 trainers training more than 5,000 hours. Those are the numbers of the trainees from the start from March till September 2007. Even the cleaners of the hospital, everybody in the university was trained. Of course, the program went through a rigorous process of setting up and running, and we spared nobody at the institution in terms of the training. And we went through the current cycle for development, deployment, and running the courses. These are the BBE courses, as I said, 2,500 people in 83 days were trained. Also, we implemented the National COVID Crisis Crash Course for non-critical care, and we run courses to train over 100 people using the same strategy that Dr. Amira Clinton covered during her presentation, and we managed to train 100 people in 8 days to increase the critical care capacity at our institution. Of course, we also developed virtual and on-site 2-hour hand-on simulation course to supplement difficult airway management. Also, we managed to train 70 people in 4 days for difficult airway and airway management at our institution. Together with that, we've had a very active social media presence to spread the fact and raise hope and prepare other centers to follow suit, and that has been very effective. Of course, to summarize, lesson learned in preparing for COVID, it's very well known that this is, I think, the model for the future. Pre-COVID, there were a lot of educational protocols, but during COVID, there were a lot of testing. I think the future for COVID, for training, is to go up, because everybody recognized, as you could see during this event, during many others, simulation has been more integrated, and you cannot train people, teams, and individuals and institutions without having heavy and instrumental investment to simulation. Of course, World Health Organization have introduced a lot of resources in its website, and it's available in all languages for simulation-based training, and it's available in their website for references. And of course, you could train everybody on-site, off-site, using even laparoscopic training. These are experiments are now very well spread, like even laparoscopic surgery. You could train people abroad or in other countries or other locations using effective techniques of telesimulation. And my next speaker will be talking about the experience from Morocco, and other speakers will be talking from Oman. This is reinforcing that this is doable. It doesn't matter where, Taiwan or Saudi Arabia, Morocco or Oman, you could always do this, and this is very effective. So challenges for remote training is always, people will tune out. How to get people focused with you when you do telesimulation, distance simulation, or of course you have to describe the program, provide good material, good follow-up before, during, and after. So it needs a lot of training and a lot of practice from us educators, administrators, and simulationists to prepare for this. Of course, you have to have follow-up, like having people videotape themselves, feedback, evaluation, testing. As Dr. Amira said, you just can't assume people will understand everything. So you have to follow your simulation activities, especially distance simulation, by some sort of testing or reconfirmation of competence of the recipients. Of course, you have to have post-course material and follow-up for feedback, and also if you could also do later assessment to test the system. Like in our hospital, we do some tests before, then do the simulation, and then we test the system again with other instruments or another drills to make sure that people got. So running simulation during COVID and after COVID is very great opportunity to advance the use of simulation. How to develop practical tools. I think now in Saudi and many other countries, we do have the resources. We just need to work together with our clinicians and our departments and our administration at the hospitals, how to integrate this. Simulation, because it solves people problem of competence or need to be competent. It always works better if there is a need. And COVID and post-COVID era, there's a lot for needs for training that you cannot do in real life. Again, the guidelines from the Saudi Society of Health Simulation and other organizations are great asset to develop these science. And I would like to thank you, and sorry for being short, just to keep with the program, and I'm sure it will be covered and we could have. Thanks again for my great Department of Anesthesia at King Abdulaziz University for their outstanding support for our activities and for our simulation program and staff at King Abdulaziz University Clinical Skill and Simulation Center. Thank you very much. And for the society members who always been there for this event and others, and we would like to see all of you during this assembly and maybe other assemblies to having more activities and more of your successes shared on this platform and others. Thank you very much. Thank you.
and Pharmacy of Canada, head of the Emergency Department at Pre-Hospital System of the University Hospital of Casablanca, and he is the head of Morocco Simulation Coordinator of University Degree of Emergency Medicine. He is also a coordinator of the University Degree of Pedagogy and Simulation in Health. Prof. Muhammad is an author of several books about simulation in health and emergency medicine, and he has several publications. He also was a speaker and presenter in several conferences. Please join me to welcome Prof. Muhammad Mohawi for the next presentation. Thank you.
السلام عليكم ورحمة الله تعالى وبركاته. هل تتمكنون من السماع؟ هل تسمعونني؟
نعم نسمعك.
سأقوم I will just now share the file, please. 1 second, please. So it's my here. Assalamu alaikum. Everything is well? You are able to see my slides?
Yes, continue please.
Okay, thank you. So, hello. First of all, I must thank the organizing committee of the 2021 Saudi Society of Simulation Scientific Assembly, and especially my dear friend and Mr. President, Professor Boka, for his invitation, as well as Dr. Amani and all the technical staff. I'm really very, very proud, so proud, honored, and pleased to be part of this assembly. Thank you so much. Let me introduce myself, but I think it's already done. I want to just notify that I'm the head of the Morocco Society of Medical Simulation. We called Moroccan SIM. So the Moroccan SIM is working for the promotion and development of simulation in health, as well as educational innovation throughout our kingdom. So for today, I'm very pleased to give this talk about a current topic inherent to pedagogy and COVID. My topic is entitled COVID-19, from tele-education to tele-simulation for healthcare providers in Morocco. So before I begin my presentation, I would like to remind you that I have no financial disclosure or conflicts of interest with the eventual material in this presentation. It will be not possible to talk about training courses without mentioning the famous learning circle. The circle aims at a progressive attitude in the acquisition of skills. It's composed of 5 essential steps. First one, the acquisition of knowledge. Then the masteries of technical gesture. Then computer simulation, such as serious game. Then team simulation, and finally clinical practice at the patient's bed. It's very important to be able to respect this progression for a better pedagogical output. What about the training of healthcare providers and COVID? It should be remembered that training at COVID has 2 main components. First, an organizational component which aim at setting up internal and external procedures for the best management of circuits, the massive inflow of patients, media, families, but also a second component, purely scientific, which is interested in the implementation of care protocols and ensure that they are updated according to the latest therapeutic recommendation. For which target audience is this training addressed? In fact, COVID training can interest several levels, starting from the novice in initial training, then the competent in initial and continuous training, the professional bringing his expertise, and then the expert, especially in the organizational aspect. What will be interesting is to adapt the content of the training to the target audience. For example, basic level would be offered for the novice, the advanced level to the competent, the specialized level to the professional, and finally, the organizational level to the experts. This training also had to have several characteristics. It was very important, both in content and form. In terms of content, the training had to be very flexible in terms of duration, but also in terms of occurrence and content, adapting to the different target audience. It also had to be interprofessional between several health professions. The training had to be interactive and very simple. There were some constraints to be remembered in this context. For example, the training has to be very rapid training, convenience for everyone, adaptable and especially possible at a distance. It's for this reason that teleeducation was initially imposed. So let's talk now about teleeducation. At the beginning of the pandemic, we organized ourselves into a scientific committee and set up several series of interactive conferences on a web platform, either isolated or in the form of MOOC, massive open online courses. This lecture covered the main aspects of the management of COVID, from epidemiology to treatment, including pediatric specificity. In addition to the theoretical lecture, we gave great importance to the demonstration in the form of video clips. Here, for example, was a video clip showing the value of hand washing with the paint and glove test. We also organized all other clips, but this time in the form of live simulations, showing the different stage of the different steps of the management of COVID patients in the emergency and resuscitation department. Of course, all these clips were available on the web platform and available for free. The aspect that was more difficult to implement in teleeducation was that of learning how to control the airway, as the human presence was mandatory. We used a hybrid approach in which each participant can learn at the same time, respecting the distance, and the video laryngoscopy screen was remotely connected so that his colleague could follow his performance and progress. For the novices, there were a session of discussion of clinical cases addressing different themes of COVID. These clinical cases were discussed in an interactive way on a special platform and sometimes took the form of simulation scenario well documented with clinical data and iconography. Once the main aspects of COVID management were mastered, we moved to a second level with the novice, namely virtual meeting, the implementation of education gamification process, and finally the discussion of clinical cases through simulation in small groups. Let me tell you that the gamification was really a huge success with all the learners and had a great pedagogical impact. For all the healthcare professionals, a series of online meetings were organized by experts on specific topics related to the management of COVID. For example, this was a remote education meeting on the use and value of lung ultrasound in the emergency department. Better still, the contribution of our scientific societies was very notable in teleeducation. I'm talking particularly about the Society of Anesthesiology and Resuscitation and the Society of Emergency Medicine in collaboration with our Morocco team. We had organized two major events. The first one, e-corona meeting, which was followed and seen by more than 78,000 people, but also the e-conference of the Moroccan Society of Anesthesiology and Intensive Care, whose main theme was precisely COVID. Also, in the same sense, Morocco had set up an African platform aimed at teaching and training by teleeducation of our friends on different African countries. As you see now on the map as Mauritania, Libya, Djibouti, Guinea, and Burkina Faso. We call this training Morocco e-Corona training. This training was organized in 4 tracks. The first one, it was about airway and management of airway and ventilation. The second one about hemodynamic aspect. The third one about medical care. And finally, the fourth track is about nursing care. The demand for this training was notable and very, very relevant. So what about the benefit of this kind of distance learning, of remote learning? The first point, attendees can log into a training in any location convenient to them, saving them the time and effort to travel to a specific conference venue or office. The second point, said tele-education training are not restricted to a specific location. Stakeholders who are based in other cities or even counties can attend, saving the need to bring in attendees to a central location. Or have a trainer travel to multiple sites. The third point about cost effective. Indeed, the total cost of running a tele-education training is much lower than hosting a traditional conference. This includes financial as well as labor. And the last point, a training like that can be recorded as part of the broadcast, enabling people to fit the training session into their own schedule at a later time. It will be very interesting for that. On the other hand, let's move now to the limitation of this approach by tele-education. The lower amount of effort required to plan for attending makes it easier for potential attendees to drop out. The second point, not being able to see the audience, the presenter cannot gauge interest, reaction, or mood and adjust the presentation accordingly. The third point, to view the training requires attendees to have compatible equipment and software as well as the necessary technological skills to use them. We need also a stable, high-speed internet connection is also necessary. The last limitation is about without the presence of other students or the watchful eye of the presenter, attendees are more likely to try to do multi-tasks at the same time and to complete work or personal tasks at the same time, as I said, which means that are more distracted from the presentation. So to overcome all these problems, a new pedagogical approach is beginning to emerge, namely the concept of telesimulation. So what is it about? Before answering this question, let's first recall some basic principles of simulation, as Booker has said in the last presentation. Let's start with the definition. Simulation is about the imitation or representation of one act or system by another. Healthcare simulation can be said then to have 4 main purposes: education, assessment, research, and health system integration in facilitating patient security and safety. So what's the rationale behind this? Ethics 1. Let's start by the ethics 1. We said all the time, never the first time on the patient. To ensure quality, safety, efficiency of care, and the professional medical practice, considering half-life of medical knowledge, transformation of pedagogy, and new technologies. Fans of simulation are convinced that simulation is a real tool. Indeed, it allows contextual learning, it allows reproducible rare events, teaching specific skills, knowledge to patients, and very important, is an essential research tool. On the other hand, the anti-simulation think that it's just a widget, a gadget. We are talking about thinking that simulation giving more high cost, lack of realism, risk of negative learning, giving different emotion, emulating, simulating, and asking ourselves if there is any evidence of validity. Now, let's move to the concept of telesimulation. Let's start by the definition. We define telesimulation as a process by which telecommunication and simulation resources are utilized to provide education, training, and or assessment to learners and at an off-site location. Off-site location refers to a distant site that would include the education, training, and or assessment without the use of telecommunication resources. The unifying definition encompasses all areas where telecommunication and, let me say, simulation resources have been used in the past. To talk about telesimulation, we have to talk mandatory about two theories. The first one, the adult learning theory, and the second one is the experiential theory. Let's start by the first theory, the adult learning theory. Adult learning theory is premised on several crucial assumptions about the characteristics of adult learners and propose that adults are self-directed and self-regulated. Adults are intrinsically motivated to learn. Adults have prior knowledge and experience that can be built upon of learning. Adults have formed mental models which guide their behavior. And last, adults, we are using analogic reasoning in learning and practice. What about the experiential theory? Experience, either real or simulated, serve as a catalyst for learning, which occurs during reflection and debriefing that follows each experience. Experience provide an opportunity for, let me say, for this reflection, during which individual can evaluate, refine, and enhance mental models that guide their behavior. I will show you this picture. So the process of having an experience, I'm talking about concrete experience, reflecting on that experience, that reflective observation, developing mental models, it's the abstract conceptualization, and then testing that mental model active experimentation is based on what is known as Kolb's experiential learning cycle. Telesimulation helps develop crucial cognitive, kinesthetic, and psychomotor skills of learning by providing real-time, hands-on training that is facilitated by task training and or instructor feedback. Telesimulation is procedural. Task training has been used in areas such as surgery and critical care fields, assessment of off-site learners, ultrasound, and tele-debriefing. Let's see now what are we doing in Morocco. We recorded several COVID scenarios. We broadcast them on a special platform and thus proceeded to a tele-debriefing with all the protagonists of this scenario. It also sometimes happened to carry out scenarios on conventional simulation with participants respecting distanciation. So conventional simulation scenario, and that the debriefing was conducted with a small group. The same debriefing and broadcast are redebriefed with all the participants. We also recorded a hybrid in situ scenario. In fact, the first part of the scenario was played by a standardized patient. And when we wanted to intubate him, we stopped the scenario and we brought in the high fidelity mannequin to continue the scenario. Finally, the debriefing part was conducted in remote debriefing. It was practically the same concept for the training of the dispatching center assistants. Indeed, we had recorded several audio clips with different accents and constraints, and we made a simulated phone call followed, of course, by a tele-debriefing. We have also created and implemented the first serious game ever on the management of COVID in the doctor's office, a serious game that was designed by ourselves and implemented using the mid-active platform that we thank very much. Another aspect of telesimulation is that of training in ventilation adjustments of patients intubated for COVID. It was a virtual solution in the form of a virtual respirator, making possible to unfold many scenarios and to follow the evolution of patients according to their respiratory parameters. In the same vein of ideas, we had set up scenarios in telesimulation, but this time focusing on the hemodynamic aspect of the COVID. This was a virtual monitor with a remote connection. At the end of the curriculum, we unfold complete scenarios combining all aspects of the management of COVID, including respiratory, hemodynamic, but also paraclinic examination to be analyzed. And the last novelty is our board game, inspired by the famous game Monopoly. I wonder if you know this game. It's very known in Europe and Africa. So where instead of buying lots of lands, houses, and hotels, the goal of this game, which we named Coropoly, was to build a complete resuscitation box where the learner was able to take care of a COVID patient. What are the benefits of telesimulation? Some benefits of this technique, it's about allowing for education and training of learning at off-site location. It allows assessment of learning at an off-site location. It eliminates distance, so no distance barrier to educational content delivery, no time barrier to educational content delivery, and provide added convenience for educational content delivery. Other benefits, it confers benefits of simulation beyond the walls of simulation center. It can provide significant cost saving for individual programs and institutions. It can provide revenue generation for simulation and education center. It allows for inter-institutional networking and collaboration. And finally, it allows for the rapid dissemination of new content in medical education. Implementing telesimulation into educational curriculum requires resources that include but are, not limited to simulation resources, ranging from simple procedural tasks, trained to high fidelity mannequin or standardized patients. The second resource to use, telecommunication equipment that allows the capture of and transmission of audiovisual data can range from a simple smartphone, computer or web camera, an internet connection, and software that has teleconferencing capabilities. What about the future? The future is a process by which the communication and simulation resources are utilized to provide education, training, and or assessment to learning at on-off-site location. This comprehensive and unified definition makes apparent the critical mass of educational research that has been conducted using telecommunication and simulation resources. Still in its infancy, this area of simulation provides the opportunity for innovating ways to provide education to learners of the 21st century, and also has opened the door for new research with strong methodologic underpinning to evaluate and establish its utility in the field of medical education. Finally, as a conclusion, let me remind you these three case sentences. The first one, never the first time on the patient. The second one, simulation is a technique, not a technology. And the third one that we've created in Morocco, too much simulation, kill simulation. Indeed, remote simulation is good, it's very good, it's very interesting. I'm so happy of that. But still simulation remains good when it's used in a good sense within the framework of a well-defined curriculum. My last slide is concerning our first healthcare training and innovation conference, which will be held in Tangier in the north of Morocco. We will be delighted to see many of you coming and attending our conference. Thank you so much.
Okay, thank you very much, Professor Mohammed and Professor Boker as well for two excellent presentations on challenges with utilizing simulation during the COVID-19 pandemic. I should mention my admiration actually of Professor Boker and how much you brought in simulation forward in not just in Saudi Arabia, but also in the whole region. You've done a tremendous work really seeing this huge group of team that is involved in simulation. And also it's really pleased to see the same thing happening in Morocco with the advancement in simulation. So I'm going to just start by mentioning the questions. I've got a couple of questions here from the audience. The first one to Professor Mohammed. I've got a question. How can we measure the performance during the telesimulation?
Okay, thank you so much for this question. Actually, we didn't conduct any evaluation program of this telesimulation. For a simple reason, we are so few persons to adapt and to perform this telesimulation. But actually, we are conducting a work, a thesis, a medical doctor thesis, and the student is implementing some sheets and to send via internet to be able to evaluate our program. So to answer your question, we didn't yet propose any evaluation program for that.
Okay, excellent. Thank you very much. And I have another question for Professor Boker. How do you manage the budgets with the new challenge? Professor Boker. Professor Boker, are you still with us?
I think they are moving to another session.
He will.
Okay, so no time for questions?
Yep, we have to leave, I think.
Okay. Okay, well, I'd like to thank both speakers for their excellent presentation on challenges with utilizing simulation during COVID-19. Thank you very much. That was excellent outlay there. Thank you.
Thank you. Thank you.
Okay. Thank you all, speakers and moderators. This is Dr. Atassi from Riyadh. I would like just to ask you now to start your lunch break. Unfortunately, it's going to be a little bit shorter because of the time constraint. And we really promise you a very exciting afternoon with the simulation dowry and the ceremony and the rest of the program. So please, let's meet all in all regions at 1300. And thank you very, very much for very rich 2 sessions in the morning.
Thank you.
Thank you.
initially with Dr. Abdullah. Dr. Abdullah is in Khobar. So Dr. Abdullah will start by introducing the teams who's volunteered to do a simulation session with us. So we really appreciate your help يا شباب وصبايا ويعطيكم العافية. دكتور عبد الله المايك عندك. دكتور عبد الله تسمعني؟
طيب
هو
It's okay.
Those are the monitors that we're going to use.
No.
This one, the white one.
We're supposed to put
crash card there.
بس راح الصوت. اوكي انا وضوي اوكي تمام ولا لسه نحن ننتظر اشاره من الخبر.
Check.
خبر تسمعوني؟
Test.
دكتور عبد الله؟
صوت واضح. تسمعوني؟
ممتاز. طيب فاحنا كنا قاعدين نقول انه thank you for the teams.
We are still in the final stage of orienting our learner and putting the
تمام.
mics for them.
Excellent. احنا حطينا المايكس. جدة كيفكم؟ حطيتوا المايكس؟ براء تسمعنا؟ هذا simulation للفضاء نفس الشيء. Everybody will be away and around and you don't know what's going to happen here and there. So this is a real simulation for telesimulation. This is the plan. That's what we plan for, to show how telesimulation is very challenging.
So I think we can start.
ممتاز. So mic is yours.
Welcome to Simdawri. So we will run 3 teams, or there will be a 3 competition. One we will start in Khobar, then we will move to Riyadh, then after that we will do it in Jeddah. Let me introduce the first team in Khobar. Dr. Arij Abdullah Al-Wakil, she is the lead or the supervisor for the team. We have the team also Dr. Athir Bajad Al-Mutairi, Dr. Khalid Saleh Al-Balawi, Dr. Ala Hassan Al-Haiki, and Muhammad Ali Al-Wadi, and Dr. Adnan Fawzi Al-Faraj. So welcome
جماعة لهم.
the team.
حماس للجروب حق الخبر.
We cannot hear her very well.
Still, we don't have the slide yet. So now, also, I would like to welcome our judges, and I will give the mic to Dr. Manal to introduce the judges from Riyadh.
Assalamu alaikum. Judges for the Sindawri this year will be Dr. Jamila Abul-Ainain, anesthesia ER consultant and simulations, and Dr. Osama Ziregi, anesthesia consultant and simulations consultant as well, and Dr. Abir Arab, for anesthesia consultant and simulations.
في كمان عشان بقية التيم في عندنا في الرياض دكتور محمود الصومالي and his team, دكتور محمد القحطاني, دكتور أحمد, دكتور فيصل, دكتور مس روزالين and مس ريم. حماس كبير لجروب الرياض. جروب جدة في الدكتورة صفيناز الشيخ هي الترينر for the group, دكتورة دينا, دكتورة شهد, دكتورة ميس, دكتور فادي and دكتور فايز. حماس لجروب جدة. دكتور براء بس حيعطينا البيزك assumption. دكتور براء. كاميرا جدة.
Alaikum. So, as we all know, basic assumption, we are here, we are all competent, we are here to improve ourselves. We are here.
راح صوته. عبالي يرجع الدكتور براء صوته. Like everybody knows, we have a basic assumption that the team is here to do their performance and they do well. And we know that any things happen, we don't call it mistaken simulation, we call it opportunity to learn. Although in this simulation session, we thank the team because they actually performance for us. The fiction contract, we know there is area that we don't know and the mannequin cannot do. And we know that all the team is actually expert. And also, we want everybody to treat everything as real. Very important point for everybody that should be kept confidential. We don't like to talk about the performance of the trainees. We really actually thank them for doing this action for us. عشان بس نزيد الحماس.
At this time, I would like you to get your phone out and scan this barcode. It will take you to a website where everyone will be able to rank everyone's team. So the team one will be ranked accordingly to anticipation, communication, and leadership.
تمام. So scan it, everybody. You will see after the team will finish their action, we need you to rank their performance. You don't have to memorize زي ما قال ياسر. You will see it in the screen, so you just only rank with their performance, what they will do during the action. So now we will start with the team al-Khubar. So please, the other moderator, can you take your teams outside the room? And we'll give Khubar 1 minute and then we'll start. معانا الخبر. الخبر معانا. نبدأ السيناريو. عبد الله. Abdullah? So you are an emergency team in a small emergency department at Rural Hospital, who you are going to receive Mashhoor. He's a 20-year-old male. He was involved in a car accident this evening. The EMS found him competitive and confused. He has a multiple abrasion over his left face and hematoma over the left scalp. He's complaining of leg pain, and this is your patient.
You are the emergency team in a small emergency department at rural area who is going to receive Mashhoor is a 22-year-old male who fell off of his motorcycle earlier this evening. EMS find him combative, confused. He has multiple abrasions over his left face and hematoma over his left scalp, and complain of left leg pain that prevent him from walking on his own. His weight is 60 kg. You can start managing this patient.
I'm Dr. Ala. We have one patient who's victim for motorcycle accident. So Adnan, please be sure, all of you, you are wearing your PPE first and make sure it's fit before touching the patient. Adnan, you will be assigned for the airway, please.
All right.
Athir, you will be assigned, please, for examination of the chest. Khalid, you will be assigned for examination of the abdomen. Please. Muhammad, you will be assigned for touching the patient to the cardiac monitor established to large bore IV line right now, please.
This is Adnan. I'm going to be handling the airway. Assalamu alaikum. How are you doing? Hello?
Okay.
Hello? إيش اسمك? Do you know where you are? So the patient apparently is confused. He's not answering any questions. I cannot see any pooling of blood or any secretions in the airway.
Checking level of consciousness, please.
So the facial weakness. I'm suspecting any brain injury, please.
Okay, so
the patient is not moving.
As this patient is confused, please prepare for intubation
All right.
right now.
All right.
We will prepare the medication for you just
right.
as soon as possible.
Yeah.
So the vital signs now, this patient seems to be hypotensive. Setting.
So we're praying for the
setting. Okay, setting well.
Intubation. I'm preparing the C-collar as well after the intubation.
Please, may you start warmed 1 liter normal saline right now, and draw blood for CBC, chemistry, VBG, glucose level, coagulation, and toxicology, please. After starting warming, normal saline right now, please, huh? Okay. Athir, what about the chest? Okay. Any deformity of the chest? Okay.
I'm exposing the chest of the patient. There is a symmetrical airway chest movement. I'm looking for centralized of the trachea. It seems to be centralized. Regarding the auscultation, it's equal bilateral air entry, and there is obvious seat belt signs in the chest. There is no active bleeding or open wound in the chest, except for the seat belt sign.
Prepare medication.
I needed to hold this to do inline immobilization for the patient. Is the patient optimal for intubation? Medication has been given?
Just we are preparing medication right now. Okay. So Muhammad, also prepare succinylcholine 70 milligram to be given right now. Started. Okay, in the other line, draw the medication, please.
I'll check about the abdomen, okay?
Go. Okay. Okay, Adnan, you can start.
Hello?
Intubation right now.
So the patient is out. I need to do inline immobilization. I'm using glidoscope for better visualization of the airway and minimal
Muhammad, please, after
manipulation.
Fluid, start blood transfusion, 2 bucketed blood cells. 2 unit bucketed blood cells right now.
Yeah, lubricant is there.
Khalid, what about the
Yeah,
first exam?
I'm checking
The
the abdomen, if there is any tenderness. Okay,
Mhm.
there is seatbelt sign in the abdomen. Okay, I will do fast scan right now. Okay, start with the subxiphoid area.
So the patient is
Any patient
intubated,
hypertension?
enter direct laryngoscopy, connected to CO2 detector.
So we need just X-ray to confirm.
Ultrasound on the screen now.
So let's auscultate. Let's auscultate
Okay,
the patient.
auscultate, Athir, please. Okay. Okay, we need to give this patient also transmit acid.
Ultrasound on the screen now.
Okay.
Thank you.
Okay, can you hold
We
the
need
door
another
while
set of the
I'm
vital
connected to
signs
this
also,
e-collar?
Mohammed. Okay.
This is your X-ray,
Indicator tube is in a place.
Yeah.
and this is your X-ray.
What about the fast exam? Any free fluids in
Hold
the
the line
abdomen?
of mobilization.
Thank you. What about the blood result? VBG result? Any base deficit?
7.25, bicarb is 15.
Any findings in the fast exam?
You can see it in the monitor, the image. Can you see it?
So after giving fluid resuscitation, blood resuscitation, for this patient, we need another set of the vital signs. Still, our patient is hypertensive.
His CO is CO2 is dropping for 88.
For 88?
Yeah.
Please check the tube again.
Yeah, the tube is in.
intubated, yes.
And CO2 detector is already 20.
So complete the exam, Khalid. What about the pelvis? Is it stable or not?
Yeah, it's stable.
Is it stable? Okay. What about the lower extremity?
Okay.
We need to do compression dressing to this one, please. Okay. So, yes, please. Okay. Now the patient is starting well. We need another set of the vital signs. Now it's coming more nice. It's 90/54.
Dr. Ali, I was not concerned. Did we activate massive transfusion protocol?
Actually, our hospital, just a small hospital, maybe they don't have actually the massive transfusion
Let's make
therapy
sure
right
we
now,
do
but
that.
we will
Maybe they
make it sure of it.
Okay.
Mohammed, may you notify the lab for massive transfusion therapy, please? Okay, thank you. Okay.
So the peripheral hospital, the central hospital, the central hospital accept your patient. Thank you, guys. You really manage him very well. يعطيكم العافية.
I need to connect the patient to the ventilator.
Okay.
We don't have a ventilator, so it's going to be a little bit. See the chest.
يا شباب
Okay.
تسمعوني؟
So the tube is
The tube is in a place, yes.
Yeah,
Thank
there
you.
is no signs of Thank you. In the chest X-ray.
جروب الشرقية تسمعوني؟
1, 2, 3.
Simulation terminated. يا شباب يا صبايا وشباب ألا
Okay.
1,
Okay.
2,
So please, thank you. Cover the patient to prevent hypothermia. Start post-intubation medication, analgesia, and antibiotic. Actually, we will take this patient, transfer this patient for a trauma center as this patient is young patient.
Okay, thank you very much. Time is over.
Okay,
thank you very much.
يعطيكم العافية يا شباب وصبايا أنا ماني شايفة العدد تسمعوني؟
Great job.
تسمعوني جروب الخبر ولا ما تسمعوني؟
Now
سوري
we
تسمعوني؟
will move our, we will have the second competition. We will move to Riyadh to have the second team.
شكرا يعطيكم العافية تسمعوني جروب الخبر ولا أنا أكلم نفسي؟
نسمعك في جدة يا دكتور أمان.
تسمعوني جدة؟
ايوه جدا نسمعك.
لأن أنا حسيت إني بكلم نفسي كذا وكذا في الفضاء في لوحدي.
لا
تمام.
لا جدة معك لا تخافي.
كويس ممتاز. طيب إذا ممكن تدخل سلايدو يا جماعة، حيطلع لكم رانكينج للجروب. إيش بس؟ نعطيكم 10 seconds عبال التيم يتجهز. جروب الرياض. So it's ranking للcommunication والanticipation والleadership. وشكرا جروب الخبر، يعطيكم ألف عافية. طيب جروب الرياض جاهزين؟
Yep.
طيب. So you are the emergency team in a small emergency department at rural area who's going to receive Mashhoor, which is actually Mashhoor is here, 20-year-old male. He was involved in a car accident this evening. And the EMS found him competitive, confused. He has a multiple abrasion over his left face and hematoma over his left scalp. And he's complaining of left leg pain that prevents him from walking in his own. His weight is 60 kg, and this is your patient.
Yeah, thank you so much. My name is Dr. Faisal. I will be the team leader. Mohammed, you will be the head and airway assessment. Ahmed, you will be the C and P for and exposure to the patient. Reem, you will be the documentation and taking a brief history. Rosaline, you will run the C with the IV lines and connect to the monitor.
Yep.
Let's start. Mohammed, please, can you assist the airway of the patient, please?
Assalamu alaikum. Mashhoor, do you hear me? Mashhoor, do you know where you are? Okay, so he's moaning.
He's moaning.
Yes.
Can you check the pupils, Ahmed, please? Mohammed?
I'm looking for someone to take a history. Is anyone with the patient?
What is the miss? We need to take the more detailed history, please.
Mashhoor, I need you to stay focused with me.
So, guys, can we apply the C-collar for the patient and assist the airway, please?
Yes.
Okay, we already have lines, large bore needle, and now I am running the normal saline.
Thank you so much. We need 2 large bore IV cannula and run 1 liter of normal saline.
So the airway is clear. He's moaning. There is no foreign objects, no edema, no bleeding inside the airway.
Thank you so much. We need a set of vitals, blood pressure, we need heart rate.
The heart rate 130, the SAT is 88, your blood pressure is 75/35,
Yeah.
and your respiratory rate is 10.
Yeah, okay. Sure. We need to call for 2 units uncross-matched blood, please. And can you assist the airway again?
طيب مشهور, you still focused with me? مشهور.
So, put the patient in oxygen. Let's start with intubation. We need the intubation kit, guys. We will run for rapid sequence intubation. So, please intubate the patient, please.
Yes.
Labs already done. Now we are waiting for the BBG.
Thank you so much. We need VBG, glucose check as well. We need full electrolyte coagulation and cross-match.
Your glucose is 3 and your pH is 7.25, bicarb is 15.
Yeah, please, can you call the blood bank? We need 2 units and cross-match, please.
Okay, Dr. Faisal, regarding the breathing, there is decreased air entry in the left side.
Okay, there is decreasing in the left side. Let's do needle decompression in the fourth intercostal space.
Okay, sure.
Please, Ahmed, can you do it?
Sure. I will proceed with needle decompression.
So
Yes.
when you did the needle decompression, there was no air coming out.
Yeah, the glucose is 3. Let's start to give D50, 50 ml.
Noted, doctor.
Thank you so much, Rosalind.
So, doctor, I would suggest that we recap again from the airway.
Let's recap again. Airway.
Mashhoor.
I am giving D50, 50
So
ml.
he is not responding.
He's not responding.
Yes, we'll start
So
amplifying.
let's start to bag him, put him in
D50
oxygen, and
needed.
prepare for intubation, please. Ahmed, needle decompression done?
Okay, needle decompression done. I will proceed with the EFAS.
Thank you so much, and prepare for chest tube as well.
Okay, sure.
The height of the bed is good?
Yes. Doctor, we are ready for intubation.
Yeah, let's start with intubation. We need fentanyl 100, etomidate 20, and succinylcholine 100.
Noted, doctor.
Thank you so much. Let's start with fentanyl 100, Rosalind, please.
Noted, doctor.
Thank you so much.
Fentanyl 100 IV, giving.
Thank you.
Fentanyl 100 IV, given.
Thank you so much. Let's start with etomidate 20.
Etomidate 20, ready. Giving etomidate 20, given already.
Thank you so much. Let's start now with succinylcholine. Let's give him 100 succinylcholine.
Okay. Succinylcholine 100 milligram IV, now giving. Given.
Thank you so much.
Okay,
Let's
shall we?
proceed with the intubation. And we need to reset the vitals again, please.
Okay. Dr. Faisal, regarding the exposure, the patient has open fracture on the right lower limb.
Okay, apply pressure for the wound and we will assist the pelvis and abdomen as well. What about the fast result? We need to call the x-rays for chest x-ray and pelvic x-ray as well.
This is your chest X-ray.
Okay.
So there is a right side pneumothorax and we insert already needle decompression and follow the intubation as well.
Doctor, I'd suggest that after we recap, the airway is already secured with an endotracheal tube. It was in place in the X-ray.
Yeah.
It was inserted in direct observation.
Thank you. Let's recap again the airway. So the patient now is intubated, needle decompression done. We will prepare for chest tube. The EFAST, can we see the EFAST again, please?
EFAST is coming.
Yeah, please.
Okay.
Can you assist the abdomen, Ahmed, please, and
Abdomen
expose
soft.
the patient?
Okay, sure. Abdomen soft and lax, pelvic is stable. There is abrasion in the suprapubic area.
So there is free fluid in the abdomen, right upper quadrant. So let's activate trauma team. We need to activate the trauma team as soon as possible. Right now, please.
Trauma team, you're in a very rural hospital. They don't have a trauma team, sorry.
Okay. So let's start him on massive transfusion protocol. We need to call any trauma surgeon or any trauma team near to us, please.
You have a trauma team 2 minutes away from you.
Okay, thank you so much.
Doctor,
Let's start
the blood
the blood.
is ready. Shall we start?
Yeah, please, let's start the blood. And let's recap again.
So the airway is secured now with an endotracheal tube, 24 and 7.5 in size. There was no edema and no blood there. The breathing is, the chest was secured with the chest tube. He was saturating well, 97%.
Yeah. What about the abdomen?
Abdomen soft and lax, there is abrasion on suprapubic area, and the lower limb pulse is intact, but there is open fraction. Already the pressure was done for this patient.
What about the pelvic? Is it stable?
Pelvic is stable.
Stable. By X-ray, we confirmed everything with ultrasound is positive. Let's recap again and let's do log roll and exposure for the patient.
Okay, sure.
Can we do log roll, please?
Sure.
Yeah. So on my count, if you are ready.
بس ارفع الصدر من هناك. صدر.
Ready, team?
Okay.
Everyone is positioned?
Faisal, can you just assist the patient?
In your account, Muhammad, please.
1, 2, and 3.
So, there is nothing. There is no stiffing, no abrasion, no ecchymosis. Thank you so much.
1, 2, and 3. Back.
Team arrived and thank you very much.
Thank you so much.
بالعافية.
Thank you so much. We are a trauma emergency. We have a patient, 22 years old, involved in RTA. The patient was not maintaining the airway. We are intubating. The chest X-ray was showing the pneumothorax, inserted needle decompression followed by chest tube. We done AFAST, which is positive. We start him on massive transfusion protocol. Thank you so much.
Thank you.
يعطيكم العافية يا شباب. So again, سلايدو جدة والرياض والخبر لو سمحتوا. سكرين نفس الباركود. ممكن حتلاقوه على الجوالات نفس الشيء. بس if you did not scan it, please scan. Again, we're ranking the communication, the leadership, and the anticipation for complication. جروب جدة مستعدين؟ نبغى حماس الرياض كان أعلى. حماس أبى أسمع تصفيق أعلى. صعبة كذا ما نقدر نصفر هنا إحنا بس يلا. براء المايك is yours. جا الفريق عشان احنا ما نشوف.
الو ايوه
ايوه تمام.
سامعيني؟
Yes, clear.
Okay. So welcome Group Jeddah, come to the stage. So you are the emergency team in a small emergency department at a rural area who is going to receive Mashhoor is a 22-year-old male who fell off his motorcycle earlier this evening. EMS finds him combative, confused. He has multiple abrasions over his left face and hematoma over his left scalp, side, and complains of left leg pain that prevents him from walking on his own. He weighs around 60 kilograms. You go with your patient.
جدة يا جماعة حماس قبل لا يلبسوا gloves.
And Faiz will be our nurse. Please, I need 2 large anticubital IVs. Connect patient please to monitor. I need full set of vitals, heart rate, respiratory rate, blood pressure, oxygen saturation, temperature, and blood glucose. You can start the assessment. Faiz, please obtain labs. Faiz, I need full labs. VBG, CBC, linear profile, liver profile, coagulation, and blood group and safe serum. Thank you. Now let's start the assessment.
سامعني انت معايا؟ قول اسمك، ارفع يدك.
He's mourning and not responding, doing any actions. Cycle accident. We don't have information. There is no another one. You don't have any person to give history.
He's able to tolerate his saliva secretions. There's any oral.
He's mourning. There is no bleeding and there is some airway secretions.
Okay. So the airway is patent, maintaining, tolerating the saliva secretions, but he's mourning. Yes, C-spine was applied from the EMS.
No clear trauma on the chest. Chest rise equal, no major fractures.
Now we are done from the airway and breathing. We have full set of vitals. Patient is tachycardic, 128. Blood pressure on the lower side. Faiz, please contact the blood bank. I need 2 units of packed RBC and cross-matched. Start 1 liter fluid bolus, please. عندك أي حساسية من أي حاجة? Any allergy?
He's mourning. He's not replying back.
Faiz, let's give him 100 mics fentanyl for the pain control. Let's see the saturation. Saturation is an 88. Faiz, please connect non-rebreather mask. Fadi, I need you to reassess the airway. I think maybe he's having compromised airway issues. So please do jaw thrust and assess if he can tolerate the secretion so we can assess our pharyngeal versus nasopharyngeal airway.
He's not tolerating his secretions.
He's not tolerating. So I think let's proceed to intubation. Fadi, I need you to do the jaw thrust. Shahad, you will prepare the intubation settings. Tubes, he's male, so I need 7.5 tubes, stylet, suction, Yanker, all other stuff. And prepare for the glidoscope because he is on the C-collar. Faiz, fentanyl given, perfect. Okay, and the fluid started? Perfect. So let's prepare Faiz for the intubation medication. We already gave fentanyl, so let's prepare etomidate 20, prepare 69 choline 100. Prepare the on intubation and call RT please for the intubation. So saturation now is still 88. Fadi, jaw thrust. Faiz, I need oropharyngeal airway just to improve the saturation and bring him the ambu bag so he can do bagging. Type. Miss, please move to the circulation while we are stabilizing the airway. Type. Yalla. Yes, perfect. Good.
E-fast, yes, and you'll see the results on the screen.
Put the ambu bag while we are giving the medications. And Shahad.
Dr. Aman, تحط لنا الإي-فاست.
Shahad, bring the nasal cannula to start the apneic oxygenation for this patient to improve the saturation.
The EFAST in the monitor, can you see it?
Yes.
Perfect.
So we have positive fast. Shahad, you prepare for the intubation. Please contact the GS team regarding the positive fast case of 20-year-old case of RTA with positive fast for abdominal GS assessment. طيب Shahad.
You feel prefer pulses. Intact, bilateral.
Shahad, please review the labs and the chest X-ray and the pelvic X-ray, please, and look for the VBG if it's already in the system. طيب let's finish from the airway.
X-ray.
X-ray will be on the screen.
So we are ready for intubation.
Dr. Amani, X-rays.
طيب يلا please put this tablet.
هي بس تاخذ seconds بين الرياض وجدة
So chest X-ray, I think it's clear. Let's move to the pelvic X-ray. What's remaining for the intubation? RT is already away. So we have the glidoscope. RT is ready. Faiz, 1 liter fluid. I need full set of vitals, please, to reassess the patient after the interventions. Still vitals, still the same. Faiz, please give the packed RBC and cross-matched and the pressure back, please. Miss, what you have in the lower limb?
I have a displaced fracture. I want to reduce it.
So there's a displaced fracture. Pulse is intact.
Pulse is
Okay, pulse is intact, and the neurovascular examination is unremarkable. Is there any active bleeding?
Yes.
So please, I need you to do direct pressure and try to apply gauze. Do not reduce it as long as there is pulse and neurovascular is intact. Just keep it as it is. Then splint it to and direct pressure to control the bleeding, just to stabilize the blood pressure. Ready to intubate. Faiz RT is already available. Medication is ready. Suction, all equipments are ready. Perfect. So we have plan A, it will be glidoscope. Plan B, we have the LMA, just in case we fail the intubation. LMA is available, Faiz. معلش the pelvic X-ray, I didn't see the pelvic X-ray.
The pelvis is stable, but we still didn't do it.
Dr. Amani, pelvic X-ray.
Coming now.
So pelvic X-ray, it looks normal. Agree, Miss and Shahad. So let's start the intubation to fix the airway. Medication is ready. Saturation still 88. Blood pressure still low. Fluid given 1 liter. So let's recap again. We have this 20-year-old male patient. He's young, medically fit most likely. He's having case of motor vehicle accident. Initially, airway it was compromised. We planned to start intubation. He was hypoxic. We start ambobagging with oropharyngeal airway and jaw thrust. We will start for the intubation. He was hypotension. We give him the 1 liter fluid. We give him the first unit of 2 units of packed RBC and cross match. He's still not improving. So I will Shahad, please activate the massive transfusion protocols because this one is still hypotension.
You're in a rural hospital, no massive transfusion. What do you want?
No massive transfusion protocol.
What do you want exactly?
Let's call the GS and orthopedic just to control the site of the bleeding, and let's give tranexamic acid 1 gram. And if still, I will start pressures just to maintain the map above 65. Tranexamic acid 1 gram given. Let's fix the airway, my team. Let's fix the airway, then we'll move to the next step. Yalla, medication is ready. Let's give the push dose pressors just to improve the blood pressure before the intubation. Push dose pressors. So epinephrine given, perfect. Let's give the etomidate 20 milligram. Perfect. Let's see the new blood pressure after the medications. So still hypotension. Miss, please insert central line, femoral. Shahad, please contact the blood bank urgently. I need uncrossed groups as soon as possible, please. Quickly. Faiz, start another 1 liter also bolus, please.
Second liter ongoing.
This one, the second bolus.
20 seconds remaining in the session.
Let's give the etomidate given. Fadi, assist the airway. Do we need to give the relaxant? It's relaxed. So start with the intubation, please. Miss, you already applied the pressure. طيب we already contacted GS. طيب Miss خلاص let's talk to the blood bank to bring the
10 seconds and we will end the scenario.
طيب يلا airway, so airway is in. طيب شهد خلاص contact the orthopedic regarding the fracture. We already contacted the VGS. Arrange for the PANC.
Patient intubated, general surgery team arrived, and they took over the case and transferred to the main trauma center in the city. Thank you very much for your care.
Thank you very much, Group Jeddah. Back to the Slido, and please rank their performance. Communication, leadership, and anticipation. يعطيكم العافية جروب الرياض وجدة والخبر. Thank you so much يا شباب وصبايا. المايك للدكتورة منال.
دكتور أسامة, please give the feedback to the خبر group. Thank you. Sorry, Dr. Osama Ziregi will give the feedback to the Riyadh group. Thank you. I think the group in Al-Khobar, they have a group technical problem, so Dr. Jamil, please give the feedback to the Al-Khobar group. Thank you.
السلام عليكم يعطيكم العافية. خبر يسمعوني ولا لا؟ خبر يسمعني؟
الرياض، احنا نسمعك في الرياض. الخبر
الخبر أكيد صح؟
صح. شكله في أحد جاي على الستيج. جدة تسمعك.
تبوني أعطي جدة طيب؟
لا احنا بس عشان نسوي سبورت إنه ترى we hear you, you're not alone. خبر تسمعونا؟ طيب ممكن نبدأ بالرياض بما إنه عبد الله تسمعنا؟ تمام. تفضل دكتور جميل.
عبد الله تسمعنا؟ خبر في كاميرا بس ما في صوت.
في كاميرا وما في صوت صحيح. يس. يس هذا عبد الله.
عبد الله سوي ثامز اب. دكتور عبد الله.
ايوه نسمعكم بس احنا بننتظر التيم يكونوا موجودين في القاعه.
تمام.
طيب تمام.
Okay, the team arrived, so you can start.
طيب يعطيكم الف عافيه. معكم اخوكم كبير شويه جميل ابو حنين. Thank you very much, and I think it was a very fascinating experience. تجربة جدا جميلة. We do it virtually through 3 areas. I know there were a lot of challenge, but still يعني simulation competition always fun to have. فريق الشرقية ما شاء الله, you guys I think did a very good job. Briefly, I know I have few minutes وما حيكون أظن عندكم وقت كمان للتعليق. In general, I think you guys hit most of the items. في ال communication stuff, there was a clear leadership, بس يعني يمكن الصوت خاننا. أنا ما سمعت a leadership identified himself as a leader على السين. يمكن قيلت, بس it was very obvious to me who's leading. There was a very good closed loop communication. plus a tone والnon-verbal communication كانت very nice, and I've seen few examples when you needed really to rush them and you needed to slow down and you needed to reassure them. So this was very good. في التكنيكال بارت او اللي هو الكلينيكال مانجمنت بارت, I think you guys followed ATLS and did a very good trauma survey. You focused on A, you fixed A, then you moved to B, and you fixed C as well. My only comment on that, يعني احنا بالذات لما نجيكم النيوروسيرجن and if you expect a patient with TBI, traumatic brain injury, you need to have to document at least what is your neural status before you knock out the patient with the paralytics and the sedation. So maybe we have to call out usually for trauma surveys the Glasgow Coma scale to document that وحتى للneuro team. Always remember to uncover your patient completely, not to miss any injuries, plus cover the patient to prevent hypothermia and always check for the temperature. يعطيكم ألف عافية و very well done. That's my short quick feedback. Thank you.
شكرا دكتور جميل، يعطيك العافية.
السلام عليكم. Regarding, I'm Osama Zreigi, consultant anesthesiologist. Regarding the Riyadh team, I think the team did a very good job. When we talk about the leadership style, it was clearly that pre-assignment happened in the beginning, which is almost, we see it most of the teams. And then the team goes with the sequence of the ABC management for the patient, and they target most of the requirement and reach to the diagnosis that's really applied or have the patient. I think the team dynamic was synchronized. We saw many actions and management at the same time from different team members, which indicate that there is a good leadership style. Many examples happened regarding the closed loop communication during the scenario, and I think we hear also many recapping and trying to make sure that the whole team are involved together, and they have the same mental model when they manage this patient. Also, I like the end when the leader try to summarize this is the end, which is before transferring to higher level institution. The same point regarding the hypothermia and covering the patient, maybe this is which is need to be improved in the next time. In general, they did great, and I hope that summarize the feedback for the team.
عافية دكتور أسامة.
Please, Dr. Abir Arab, you can now give your feedback to the group of Jeddah.
جدة.
I'm there somewhere. طيب سامعين؟
Yes.
أطلع على الستيج. طيب تمام. So I'll speak here.
Yes.
طيب.
يعطيك العافية يا رب.
So remembering how it was difficult in the first SIM dowry that we ever had, having them in one room, being seen by everybody else, and now I could see it evolving. They're seen by the whole country and maybe outside the country. So I will just stop before I give the feedback and ask everybody in all regions to clap for those heroes who came on the stage to show others how these cases could be done in their own centers, in their own hospitals. So what we saw in the third scenario was an excellent example of how you come over challenges. The challenge of being in an abnormal or a new environment. The team took a couple of minutes to be oriented to the environment. One of the things that I'll give them credit for is choosing a leader. So the leader was very clear throughout. The position of the leader standing in an era when they could see all the events around them, he will be able to get feedback from everybody else. Calling them by names as a team dynamic helped a lot to get the information out of his team members. Having everybody assigned to task helped them getting feedback from those when it came back. Apart from that, it was clear that they were using both verbal and non-verbal communication. So I could see that even sometimes we couldn't hear a loop is closed, we could see the eye contact with people confirming that they listened or heard the order and they gave it back. Regarding the management, they might not have finished all the stages yet. They made sure that they were not rushed by the time. They made sure the patient is always stable before running from one stage to the other. They made sure all the equipment ready and checked before they went ahead to do the intubation, and not moving from one stage to the other until the patient is stable. I love the fact that this is an example to show us what could we do in our centers, what could we do with our trainee or our faculty, and I'd love to see more centers and more areas in the next conference. So again, thank you very much for everybody, and thanks for those who set examples for us on the stage in all three areas. Thank you.
يعطيك العافية دكتور عبير. And thank you for all the judges, moderators, sim, tech in 3 areas. It was very challenging to run it 3 areas at the same time. So thank you so much. And I think now we're going to move to the opening ceremony.
بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد بن عبد الله عليه وعلى آله وصحبه أفضل الصلاة والتسليم. أصحاب المعالي والسعادة، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. يسعدنا ويطيب لنا أن نلتقي معكم اليوم بمناسبة الملتقى العلمي للجمعية السعودية للمحاكاة الصحية 2021، والذي يسلط الضوء على ما حظيت به القطاعات الصحية والتعليمية بالمملكة من اهتمام بالغ من خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وولي عهده الأمير محمد بن سلمان حفظهم الله، حيث شهد القطاع الصحي تطوراً كبيراً ونهضة تقنية رائعة واستخدام دائم للمحاكاة في كافة الوسائل التعليمية والتدريبية للكوادر الصحية. Ladies and gentlemen, from the Kingdom of Saudi Arabia, we would like to welcome you all to the Scientific Assembly 2021 of the Saudi Society of Simulation. It is our great pleasure to have you all with us today in the opening ceremony. من مملكة الخير والنماء نرحب بكم في هذا الافتتاح تحت رعاية الأمين العام للهيئة السعودية للتخصصات الصحية وبمشاركة التجمع الصحي بالمنطقة الشرقية وجامعة الملك سعود بن عبد العزيز للعلوم الصحية في الرياض وجدة. وخير ما نبدأ به حفلنا هذا هو آيات من القرآن الكريم.
والذي أوحينا إليك من الكتاب والحق مصدقا لما إليه إن الله بعباده لخبير بصير. ثم أورثنا الكتاب الذين اصطفينا من عبادنا فمنهم ظالم لنفسه ومنهم مقتصد ومنهم سابق بالخيرات بإذن الله ذلك هو الفضل الكبير. جنات عدن يدخلونها يحلون فيها من أساور من ذهب ولؤلؤا ولباسهم فيها حرير وقالوا الحمد لله الذي أذهب عنا الحزن إن ربنا لغفور شكور الذي أحلنا دار المقامة من فضله لا يمسنا فيها نصب ولا يمسنا فيها لغوب.
حضوريا أو عن بعد في موقع أو في مواقع مختلفة، تضمن الملتقى العلمي العديد من المحاضرات وورش العمل والفعاليات والمسابقات وأنشطة أخرى كثيرة تولت الإجابة والتحدث عنها رئيس اللجنة التنظيمية، فيتفضل سعادة الدكتور عبد العليم الأتاسي.
شكرا جزيلا. بسم الله والصلاة والسلام على رسول الله. أصحاب السعادة أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته. أهلا بكم في أول انطلاقة للملتقى العلمي للجمعية السعودية للمحاكاة الصحية 2021، حيث عملت اللجنة المنظمة مع اللجان المختلفة لإخراج البرنامج العلمي الحافل والملتقى بطريقة جيدة مبتكرة تجمع بين الافتراضية والمقر المكاني في 3 مدن تشمل كل من الخبر والرياض وجدة. وقد حثت اللجنة المنظمة الخطى لجعل التجربة فريدة من نوعها كما وكيفا، بحيث يشارك الجميع سواء حضوريا أو عن بعد، ومتماشية مع الإجراءات المتاحة والاحترازات المتبعة في وقت إقامة الملتقى. نسعد بمشاركتكم ونرحب بكم وبأفكاركم لنجاح الملتقى لتحقيق أهداف الجمعية السعودية للمحاكاة الصحية لدفع عجلة التطوير والتدريب باستخدام كافة وسائل المحاكاة وتبادل الخبرات والتجارب الناجحة في كل مركز من مراكز المحاكاة بمملكتنا الحبيبة والمنطقة وعالميا. ولا ننسى أن نشكر كل أعضاء اللجنة المنظمة واللجان الفرعية لجهودهم المخلصة لنجاح الملتقى وإخراجه بالصورة المثلى، كما نتقدم بالشكر للشركات الراعية ولأعضاء الجهات المشاركة ابتداء بالتجمع الصحي بالمنطقة الشرقية وكلية الطب في جامعة الملك سعود بن عبد العزيز في مدينة الرياض، وكلية الطب في جامعة الملك سعود بن عبد العزيز العلوم الصحية في مدينة جدة. ونخص الداعم الاستراتيجي والرئيس لهذا الملتقى الهيئة السعودية للتخصصات الصحية بوافر الشكر والعرفان، ودمتم بألف خير.
إنشاء أنظمة صحية مرنة باستخدام المحاكاة هو الشعار الذي اختارته اللجنة العلمية للملتقى، وتكون المحاكاة إحدى وسائل تحقيق أعلى مستويات سلامة المرضى والعاملين في القطاع الصحي، ورفع مستوى الجاهزية في النظام الصحي والنظام التعليمي الطبي. لتسليط الضوء على المحتوى العلمي للجنة العلمية، تتفضل سعادة الدكتورة أماني عزيز الرحمن رئيسة اللجنة.
السلام عليكم ورحمة الله وبركاته. يشرفنا أن نرحب بحضوركم الكريم في الملتقى العلمي للجمعية السعودية للمحاكاة الصحية 2021، والذي حرصنا فيه على تقديم برنامج علمي متميز لجميع الممارسين الصحيين المهتمين بالمحاكاة الصحية. شعارنا إنشاء أنظمة مرنة من خلال المحاكاة الطبية. محاور الملتقى تم اختيارها بعناية لتكون مواكبة لتغيرات الفترة الحالية، والتي تتضمن الآتي مثل التحديات مع استخدام المحاكاة في الأزمات مثل كوفيد-19 وأزمته، ودمج المحاكاة في البرامج الطبية، وأخيراً استخدام المحاكاة كأداة التعليم الطبي المستمر. يتضمن البرنامج العلمي على 8 جلسات علمية، وتحتوي على 27 محاضرة و13 ورشة عمل تفاعلية على مدى 4 أيام. كما حرصنا على إشراك الحضور، وذلك عن طريق 7 مسابقات، 4 منها تم التقديم لها قبل المؤتمر، و3 خلال المؤتمر، احنا خلصنا واحدة منهم موسم دوري. وسيتم إعلان الفائزين في نهاية الملتقى اليوم 7 ديسمبر. وأخيراً أتقدم بالشكر الجزيل لأعضاء اللجنة العلمية والمتحدثين ومدراء الجلسات والمحكمين في المسابقات، والبالغ عددهم 114، شاملاً 15 متحدث دولي و39 مدراء جلسات وجلسات علمية، وكذلك 14 متحدث محلي، وكذلك 14 محكم. نتطلع في اللجنة العلمية لمشاركتكم لإنجاح هذا الملتقى، وشكراً جزيلاً لكم.
قصة تكللت بالنجاح واستمرت على مدى 3 سنوات تحكي لنا مراحل نشأة وتطور الجمعية السعودية للمحاكاة الصحية تحت إشراف الهيئة السعودية للتخصصات الصحية. الآن الكلمة لرئيس اللجنة العليا للملتقى ورئيس مجلس إدارة الجمعية السعودية للمحاكاة الصحية الأستاذ الدكتور عبد العزيز بوكر.
طيب الرحمن الرحيم. أصحاب المعالي، سعادة أيها الحفل الكريم هنا وفي الرياض وجدة وعلى البث المباشر، أهلا وسهلا ومرحبا بكم جميعا للملتقى العلمي للجمعية السعودية 2021. شكرا للرعاية الكريمة من الهيئة السعودية للتخصصات الصحية الذي كانوا فعلا داعمين كبير للجمعية من منذ نشأتها إلى الآن، والمشاركة عالية المستوى من التجمع الصحي في المنطقة الشرقية وكليتي الطب في جامعة الملك سعود بن عبد العزيز في مدينة الرياض وجدة، والعديد من الوزارات والجهات المتخصصة ومراكز المحاكاة تتوالد منها مستويات عالية من الحماس والحمد لله رب العالمين. كما نشاهد مئات المتابعات سواء في المناطق الثلاث وكذلك عن طريق الموقع والتسجيل الإلكتروني. طبعا جهود كبيرة من الشركات الراعية ومن الجهات الراعية وكذلك من أعضاء الجمعية. زملائي في اللجنة العلمية واللجنة التنظيمية بذلوا جهود كبيرة جدا مع كل التحديات، عدم الأنظمة أو ماذا سيكون الوضع الآن، فالحمد لله رب العالمين وشكرا لكم جميعا. والشكر كبير طبعا للأمين العام للهيئة السعودية للتخصصات الصحية الداعم الرئيسي لهذا الملتقى والجمعية، وإن شاء الله نستطيع نستعرض كلمته المسجلة لعدم تمام الحضور معنا اليوم. شكرا جزيلا لكم.
تتقدم الجمعية السعودية للمحاكاة الصحية بالشكر والتقدير والتكريم لكل من ساهم في نجاح هذا الملتقى. الجهات المنظمة والمشاركة في الفعاليات والمعرض المصاحب له، أولاً الشركات الراعية، الشركاء في النجاح، التجمع الصحي بالمنطقة الشرقية ويتسلم التكريم سعادة الدكتور عبد العزيز الغامدي المدير العام التنفيذي للتجمع، كلية الطب جامعة الملك سعود بن عبد العزيز العلوم الصحية في الرياض يتسلم التكريم عميد كلية الطب الدكتور أحمد الرميان، كلية الطب جامعة الملك سعود بن عبد العزيز للعلوم الصحية في جدة، يتسلم التكريم عميد كلية الطب الدكتور منصور القرشي. لا المفروض جدة الحين. لا جدة. ولا يكمل لسه بقى الجمعية. ما حطوا. الجمعية العلمية للرعاية التنفسية يستلمها سعادة رئيس الجمعية دكتور عبد الله المجيبل. الجمعية السعودية لطب الطوارئ يتسلم التكريم سعادة الدكتورة أماني عزيز الرحمن. كلمة الأمين عام ما أدري. والآن مع كلمة الأمين العام للهيئة السعودية للتخصصات الصحية.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا ومرحبا بكم في هذا الملتقى العلمي للجمعية السعودية للمحاكاة الصحية. المحاكاة تلعب دورا كبيرا ومحوريا وبارزا في التعليم الصحي الحديث. لا يمكن أن نتعلم جميع المعارف والمهارات على المرضى أنفسهم أو على الحالات التي يكون فيها خطورة على المريض أو ذويه أو الوضع الصحي العام. ولذلك فلا بد من تدريب الممارسين الصحيين على هذه المهارات وهذه المعارف في بيئات افتراضية. أولا، تطورات كبيرة جدا حصلت في علم وتقنية المحاكاة اليوم وغدا وبعد غد ستناقشونها. سنتعلم سويا من أفضل الأساتذة والعلماء في هذا التخصص. سنناقش سويا أحدث التقنيات وكيف تستخدم وكيف تندمج ضمن مناهج التعليم الطبي والصحي. الجمعية السعودية للمحاكاة الصحية هي جمعية ناشئة وحديثة، ولكن بدأت في الحقيقة تقوم بأدوار رائعة ومميزة لخدمة القطاع الصحي وبخاصة في خدمة التحول الصحي. نتوقع الكثير من هذه الجمعية بسبب أهمية موضوعها وهو موضوع المحاكاة. لا يمكننا أن نقوم بتأهيل الممارسين الصحيين لمستقبل الرعاية الصحية السعودية من غير برنامج قوي ومميز في المحاكاة. أشكر سعادة رئيس مجلس إدارة الجمعية وأعضاء المجلس وجميع أعضاء الجمعية الذين حقيقة تفانوا في وضع هذا البرنامج المميز. أشكر جميع المتحدثين وجميع المشاركين وجميع الرعاة. أتمنى لكم مؤتمرا تحاكون فيه الإبداع.
يقدم رئيس اللجنة العليا للملتقى ورئيس مجلس إدارة الجمعية السعودية للمحاكاة درعا تذكاريا للأمين العام لهيئة التخصصات الصحية سعادة الدكتور أيمن عبده. إلى هنا أصل معكم إلى نهاية حفلنا هذا، على أمل أن نلتقي بكم في مناسبات قادمة. نتقدم بالشكر والعرفان لكل من شارك معنا في إنجاح هذا الحفل، وشكرا لكل من حضر وشاركنا في هذا اليوم. وغدا في العاجل القريب نلتقي معكم على دروب الرفعة والعطاء لخدمة القطاع الصحي في بلادنا الغاية. فدامت أيام السعادة والخير علينا جميعا، والسلام عليكم ورحمة الله وبركاته.
اشتغل معك تعلمني دي جي الوان خلاص. طيب we have a break till 2:45 يا جماعة 2:45 we will be back إن شاء الله. اوكي نصلي العصر يا دكتور. نصلي اي بإذن الله. لا العصر almost ايه 2:45. اوكي اخوان بجدة اخوان بالخبر يعطيكم الف عافية. البرنامج يرجع ان شاء الله 2:45 على الموعد باذن الواحد الاحد. اشوفكم على خير. السلام عليكم. اخوان في الخبر تسمعوني؟ ممكن نسمعكم اخوان في الخبر؟ طيب الاخوان في جدة حياكم الله، ممكن نسمعكم؟ تدونا الصوت بس نسمع الاخوان الخبر وجدة.
تسمعوني ولا لا؟
اي نعم. جدة تمام. عبد العليم من الرياض. عندنا احد من الخبر؟
اي عبد الله مرشد من الخبر.
عبد الله اوكي. طيب shall we start the next session?
Okay. Assalamu alaikum. Good afternoon, everyone. Welcome to the third session of the day. The third session is going to be about utilization of simulation during crisis. We have three speakers. I'll introduce myself first. I'm Sawsan Al-Yusuf. I'm a pediatric intensivist at King Fahd Medical City. So to introduce the first speaker we have with us is Dr. Abdurrahman Al-Sabagh. Dr. Abdurrahman Al-Sabagh is the emergency medicine and clinical simulation consultant at King Fahd Medical City in Riyadh. And he has experience in health professions education and works as a consultant to the health academic at the Saudi Commission Society. His academic interest as emergency medicine and plus healthcare simulation and medical educator and faculty development and research. Plus Dr. Sabagh, his interests in marathon runner, and he really interested in promoting for physical activity always. Thank you very much. Welcome, Dr. Abdurrahman.
شكرا يعطيكم العافية. بس في صدى بيجي هنا. we'll keep talking. اوكي تسمعوني كده كويس؟ طيب الله يعطيكم العافية. شكرا جزيلا على إتاحة الفرصة. أتشرف أكون معاكم في مؤتمر بتنظيم مختلف في 3 مدن في نفس الوقت بالإضافة إلى إقامته افتراضيا. حاب أشكر اللجنة المنظمة اللي أنا عضو فيها واللجنة العلمية ورئيس المؤتمر وجميع الحضور. طيب so we'll be switching to English. اليوم نتكلم إن شاء الله we'll speak about in-situ simulation during crisis. I'm just testing this. Okay. So what is crisis? According to Oxford, is an intense time or a danger, and I believe in the new century, if we apply this definition, we are always in crisis. So, inside the simulation, first of all, I have no financial disclosure or conflict of interest with any of the materials in this presentation, and I want to highlight are all the pictures or videos that is here are not for real patients. It's all simulation and actors. طيب, sorry. So inside the simulation, it's a simulation that occurs in the actual clinical environment, as simple as that definition is. And the participants are on duty clinical providers during their actual workday. Sometimes it doesn't have to be, but the main definition is in the actual clinical environment. And also it's an educational strategy that promotes patient safety and enhance interdisciplinary teamwork. So why? Why in-situ simulation? Okay, so in-situ simulation, it allows teams to practice in more realistic environment instead of going to the sim center or a remote area from the clinical area to simulate the clinical area. So if you work in this actual bedside in the ED, emergency department or 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 anesthesia or even pre-hospital as we will describe later, that's the actual clinical environment. So more realism and fidelity for the simulation experience itself. It helps to test systems, not only like individual and teamwork. It will identify system gaps and system challenges when we practice and rehearse the experiences of seeing patients or multiple patients Also, it will improve the reliability and safety, especially in area of high risk and high stress environments. We'll demonstrate some example. It's also an attractive alternative for some institution, those who doesn't have a simulation center. And in my opinion, sometimes it's the first one to go in some scenario. It depends on your educational learning objective. Sometimes the learning experience, if it's done in the actual clinical environment, maybe it's better than the simulation center. So, some features of why in situ simulation sometimes should be the preferred methods of educational simulation strategy. Cost, sometimes it will be less costly, especially if you cannot afford building a fancy simulation centers. Also, it can identify, as I said, latent hazard knowledge gaps within teams and within the system. It's also serves as a diagnostic method to identify clinical providers, either as individual, as teams. Also resources, medication, equipment. Sometimes we have a new equipment, as I will show in the example of the in situ simulation that we did in the last year. You can test a new equipment, even if you know it's tested and validated. Again, practicing it, getting familiar in it in the real actual environment, it's going to be more psychologically safe for the learners and the healthcare practitioner to try that. And also, as I said, it's an opportunity to stress the system, identify the area that highest risk and the greatest need for remediation or revisiting what should be done, what shouldn't be. Okay. So, I promise I will talk a little about COVID, because this is the crisis that helped utilizing more of in situ simulation during a crisis. I will just quick overview of what have been done, what we have been done. Then I will go to something I believe more exciting, because myself and I believe I would say all or most of us are fed up with COVID related talks. So I promise it's going to be quick. So these are multiple projects, publications done in situ simulation, emergency department, ICUs, anesthesia, OR, even in the ward. So most of those articles were having two main focus for the in situ simulation during crisis, specifically during COVID, because there was a surge in that utilization of in situ simulation due to the limitation of and the curfew during the pandemic. It is an educational focus and systemic focus, or we could say translational simulation. These are the main two focus of all those articles. Some of them were having combination of both, some of them purely educational, some of them purely to testing the system, transferring the patient, isolating them. Again, the purpose of collectively for all of these literatures, transfer the skills to real life, testing the system again, providing opportunity for interprofessional training, as I will go briefly in a few slides. Also, department preparedness for the expected surge in patients. We all know that the surge of patients were very high and was predicted but unpredicted in case of COVID. So this was a good testing before we reached the surge capacity using in situ simulation. I won't read all of these, but these are summary of what all these articles have found. So we'll just pick. So I will go. So some of the studies uncovered potential threats and needed logistics. Even they identify some simple logistics that make difference in the patient care by using in situ simulation. If this has been done in a simulation center, these logistics were uncovered. So this is one of the main benefit of doing in situ simulation. Again, another uncover logistical issues. Also, in that difficult time of stress of COVID, the world is ending because of COVID, etc., etc. It has accelerated the development of skills and agility and keep people agile. So I will go quickly. We had an experience during April like a month after declaring the pandemic by WHO or so, me and some of my colleagues at Kenfag Medical City, we saw an opportunity in why we don't practice airway management in suspected or COVID patient before we have that surgeon capacity and having something on the ground that we agree on all as interprofessional teams. So required equipment, we had the actual patient room, we had some mannequins, airman, and the patient monitor like my senior colleague, Mr. Muhammad Al-Amar, explained on the iPad monitoring system in the morning session. The actual clinical equipment, we simulated some equipment that are expensive, like N95. That's a limitation, but again, we have utilized the same, almost the same equipment. We run it as a study. It is a cross-sectional study, combining both quantitative and qualitative. The quantitative part is level 1 Kirkpatrick reaction of the participants to their experience in the in the learning experience. And the qualitative, we utilize the plus delta. We unify the plus delta approach of debriefing and the debriefing after the clinical scenario. And we did some qualitative analysis, data analysis, to get out with the themes for the common things that need to be improved. The simulation session was 1 hour. Remember, this was during the beginning of the hit of COVID. Everyone is busy, working hard, working non-stop. So we arranged the logistic to 3, 5, or 6 interprofessional who are on duty to do this. It's just 1 hour, 15 minutes of briefing, 15 minutes of simulation scenario, then 30 minutes of debriefing or discussion about the performance in the scenario, then summarizing with take-home message by group discussion and by written for each individual, just to rehearse and remember what are the most important take-home message. Then a survey to capture the feedback and satisfaction. These are we had like physicians, nurses, respiratory therapists, around 278 participants over 62 sessions, like 5 to 6 per session according to the schedules. 3 departments, adult emergency, pediatric emergency, and anesthesiology in the operating room. The average satisfaction was, the immediate satisfaction was above 90% satisfaction. So this was a newly developed curriculum. We followed the six-step approach in building it. It was feasible for the busy healthcare provider. It showed like you can safely practice and perform airway management in general, procedures including intubation for suspected COVID patient. And from our qualitative analysis, it showed that the most common theme was anticipation of difficult airway and speaking up. So one clinical, one non-technical skill were the most frequent challenges identified. So this is after all of these sessions, this was the most common theme identified among the participant of this project and study. Enough with COVID. Okay. So, just see this video. I hope it worked. I'm not sure if it's gonna work or not. This was 2018 Formula 3 race or Formula 2 in Macau. Keep watching. Okay, this is a female driver, Sophia. You saw how bad was the accident. Many accidents on YouTube. You can see for Formula 1. I think most of us now are more aware about Formula 1. Especially Dr. Hani here, I think he enjoyed the Formula 1 event just last night. I enjoyed it myself. So why I put this video? Because there's some pre-hospital care and disaster preparedness and management need to be planned and practiced on. Because this event gonna happen. And it's very high acuity. So proudly we hosted Formula 1 Saudi Arabian Grand Prix event as the first time. It was very amazing. And as part of that, there was a... Yeah. So this happened last night for those who watched the event. This is a video. This is a real video, but this is everywhere in the social media and in the official media as well. So this was F2 main race, just before the main event F1 race. So see the white car didn't go, they avoided. Okay. Did you notice the flying debris of the car that went all the way to the pit lane when they changed, and you see this guy here? So all of this was like anticipated, practiced, and there was like 4 multiple crashes last night in the main events of F1, F2, and Porsche as well. There are 3 main races, all managed, and this is it again. Wait 1 second, sorry. So see the white car, something happened, the last driver couldn't avoid. Okay. So this is what you saw from all the team, medical team, and also all marshals in the race were practiced, but this is what we're doing. This is one of the drills. This is the extrication during exercise that's done in almost 14 seconds. All of this is by Saudi nationals with the help of our brothers from Bahrain, because they are more experienced in the region since 2004. Organized by نادي منظمي السباقات السعودي or Saudi Motor Marshal Sport والاتحاد السعودي للسيارات وتنسيق مع وزارة الصحة والرياضة. رئيسة نادي السعودي موتور سبورت مارشال كلوب الدكتورة عهد آل سعود, also an emergency medicine and disaster consultant from Riyadh, practicing in Riyadh, and months and months of training has been done to be ready for this event. Alhamdulillah, we did great, all as a medical team, all the marshals. I was part of this, training with them, being at the learner seat. It was a very joyful experience for me because I tend to teach simulation. Here I was the learner, so it was very amazing, new thing that I learned and I enjoyed. This is another. So this is at the scene also. This is an actor. Now that's at the scene. Now we are at the ambulance. We simulated the whole thing, the whole journey, either all together or separately. This is at the resus area. This is me, by the way. Dr. Sousan, you introduced me as Abdurrahman Sabbaq. Let me clarify. I am Dr. Abdurrahman Yasin Sabbaq. وهذا دكتور عبد الرحمن جعفر صباغ. He was with me at the team. I was the team leader of the medical area in the medical center, only the clinical area. I had Dr. Adel Al-Tamimi, medical director, and Dr. Ahad as a CMO. It was a very nice experience. It is a simulated experience. This is also Dr. Yahya Al-Marhabi, trauma surgeon. Who else? Dr. Ahmed Al-Yami, consultant. وعد وديمة ما أعرفها من وراء أعتقد رغد. So all of us working together for the first time together. We didn't know each other from before. I know Abdurrahman Sabbagh, of course, because obviously I know him from before for the name, and he is my colleague and senior colleague in King Fahd Medical City before. But we never worked together before, actually, on a bedside. But we did this multiple times, many times, and when the real patients came, the real drivers came, even the marshals. And in this event, it's not only the driver, maybe 10% only the driver, but you have marshals sitting on the sun for 12 hours who come in heat-related illness or any other trauma or anything. So the medical center was running for the whole event. So in summary, inside the simulation, it's the actual clinical environment or pre-hospital clinical environment as we saw here and here. So that was really amazing experience for me. A good area to show that in situ simulation could be helpful in preparing for crisis, not only when crises happen. In summary, in situ simulation should be seen as an interventive tool. And at the beginning of the slide, I wrote alternative in purpose. It's not alternative because I want to say it now. Sometimes it's the first educational strategy you want to go for. For example, Formula 1. We have Dr. Taha Masri here attending, mashallah, he with the Dr. Rayes Suleimani and Dr. Wadda did a very nice course in ايش اسمه؟ اعطيني اسمه بالضبط عشان لا اخرب عليكم الكورس.
Dr. Abdurrahman, 2 minutes left.
In-flight medical emergency simulation that done في مبنى الخطوط السعودية هنا في جدة in actual simulated هي actual plane ولا simulated؟ Simulated plane بس يعني كأنها نفس الطيارة. It was an amazing. I didn't attend it. I didn't teach in it. I would love to be part of something like this.
Dr. Abdurrahman,
this
1
is
minute.
where inside the simulation we should think out of the box. We should think of it as a first go, not as an alternative.
Dr. Abdurrahman, can we conclude here? Dr. Abdurrahman, can we conclude here, please?
Cut me off. خلاص باقي لي 2 slides.
Okay.
I have 2 minutes remaining أساسا.
والله قالوا لي past. Okay.
طيب, finding from training session can help identifying and shaping learning goals, staff preparedness, improving systems and some existing protocol or invent new protocol, and ultimately patient safety. This is what it's all about. Either before the era of simulation, after the era of simulation. And any more slides? Okay. So, again, this is some tips or takeaways if you want to implement simulation. Ensure the need of the organization are well understood. Know what are the resources available in terms of material, equipment, people. Find balance between the learning and providing system improvement. Be aware of potential extra load put on the learner. Sometimes it's an extra load on the learner. Also consider knowledge and skills you learner require. As we give example, flight, medical emergency, Formula 1. Rally, I was part of Rally Dakar, but we didn't do simulation at that time. So, you remember the first slide? Crisis? Sometimes it's an opportunity, not a crisis. With that, I conclude. These are my references. Thank you very much. Thank you for giving me the opportunity. سوسن خلاص دكتورة سوسن on time.
يعطيك العافية. Thank you very much. يعطيك العافية. On time.
السلام عليكم. الصوت واضح؟
أنا إيش المفروض أسوي دحين؟ أجلس مكاني صح؟
الصوت واضح؟
علي بس شوية.
دكتور حاتم صوتك واضح. You can start.
Okay. السلام عليكم. Firstly, welcome and good afternoon, everyone. Secondly, thank you so much, Dr. Abdurrahman, for your nice and amazing talk. I'm Dr. Hatem Zahrani. I'm so excited, actually, to be here today to participate in Saudi Society Simulation Scientific Assembly 2021, and to have opportunity to introduce our guest speaker, Dr. Cynthia John. Dr. Cynthia is currently an associate course director, instructor of clinical skills simulation at Al Faisal University College of Medicine since 2018. Graduated in Massachusetts General Hospital Institute of Health Professions year 2020 as PhD student in interprofessional education simulation track.
Who is controlling here?
Master of Science in Health Simulation year 2018 and at University of Alabama at Birmingham. Bachelor of Medicine, Bachelor of Surgery at Al-Faisal University College of Medicine, Bachelor of Science, Health Sciences at Clayton College. We are very pleased to have Dr. Cynthia Chan here today to discuss what else needs to be done to improve education in perspective of engagement, distance, debriefing during crisis. Please give her a warm as she comes to start her talk. Dr. Cynthia, you can start, please. Thank you.
All from here. Hello, good afternoon. Assalamu alaikum. Thank you very much for having me. I am presenting today a body of research that we have conducted on engagement and distance debriefing. Excuse me? It's a different presentation here. It's not mine. Okay. So this topic is engagement and distance debriefing. So we need to understand what is the significance of engagement, especially in distance debriefing, because we engage our learners in situ, on-site, in person, whether we're conducting a simulation or we're conducting a debriefing. But distance debriefing is different. And what took us to distance debriefing, it's not new, brand new. There is distance debriefing that is occurring before the pandemic hit. But once the pandemic started and we were all pushed to the online world, distance simulation and distance debriefing became very active. And the unfortunate side of that is that we didn't have guidelines to conduct the debriefings. So the debriefings followed the standard guidelines that are existing for in-person. And this is where the challenges come in. So the pandemic pushed us into that situation. And we had variants of simulation and distance debriefing. And it presented many challenges, such as psychological safety, being able to view body language and facial expressions, things that you normally take for granted when you're in person, they become very challenging in the distance situation. So the need for distance debriefing development is also there, because what we are seeing is that more and more people are embracing the distance simulation and distance debriefing, and we need the guidelines to be able to develop further. So our first study was factors of online engagement in synchronous virtual learning conversations. This was a realist synthesis, and this was accepted for publication, Simulation in Healthcare, in November. And our aims in this study were, what are the learner factors of engagement in synchronous online learning conversations via web conferencing platforms that exist in the literature? And this was a realist synthesis review. And the reason we turned to the online learning conversations is because when we did our review, running our realist synthesis, we found that there was no research existing regarding engagement online in distance debriefing. There were studies and literature focused on debriefing engagement in person, on site, and but what we found when we went back as far as possible to the first mention of web conferencing was in the online learning conversations area of information. So that was what we focused our realist synthesis review on, and the realist synthesis review is up and coming in this decade, and what it does, the difference in it compared to, say, a systematic review, it looks at the context, the mechanism, and the outcome to be able to look at a complex situation that involves human behavior and how you can review and synthesize the information from a review in that way. So in our study search process, we identified 1,283 pieces of literature. And after we screened, we went through and reviewed all of these articles and screened them based on our inclusion and exclusion criteria that would be able to focus on engagement and conversations online. We were only able to identify 18 that fit our criteria. And in our findings, we found 10 very important things. First of all, it's very important to orient yourself to the learners. When you have learners come in and you're not familiar with what what they have to work with, what kind of system they're working with online, what their technological challenges are. This can compromise the engagement of your learners. You also need to conduct an orientation prior, because one of the big things that stood out among online conversation learners in their perceptions of engagement were being familiar with the setting and being familiar with the people that they would be working with, so that they would be open to sharing and engaging with each other. Establishing rules of participation was always also very important, because people are new to the online setting and they have to understand how they can communicate and engage. So having those rules set in advance so that they understand the opportunities for engagement and how they should be used makes engagement a lot more rich. Active facilitation by the educator was another important opportunity for increasing engagement, but we also found that it can also reduce engagement if the educator is overly active. It causes everyone to focus on the educator like a lecturer rather than actually engaging themselves in conversation with the group. Use of audio and video were important, because some people view having video on and having audio on and using the audio means that you're engaged and you're interested. And when it's turned off, it means that you're not engaged or you're not interested, in their opinion. Others felt that, no, I can still be engaged and I can demonstrate my engagement in different ways. Educator and peer feedback were also important findings, so that you interact with each other and give feedback on what is said in the online setting. Limiting participants was very important, because some of the studies that we looked at used more than 50, especially in the MOCC, the large conferences where they do web conferencing. It's almost impossible for people to be engaged and contribute and be active. So limiting participants in online conversations and in online debriefing, so that you create more opportunity for engagement. If you have too many participants, you create less opportunity for engagement. A comfortable atmosphere is very important. So again, it goes back to psychological safety and feeling safe and comfortable to be able to contribute. Judicious use of tools, not too much, because if people get sidetracked into chat and they become overwhelmed with in discussing in chat and keeping track of the chat, it can cause people to disengage from the entire discussion. And then finally, the role of technology, and that goes back to the orientation, that you need to understand what works for everyone, how you can best use your tools, and what you need to prepare in case technological issues come up. We also found something that we found very interesting, which was the cyclical relationship between internal and external factors. So if you as a facilitator or a debriefer do something that makes someone feel uncomfortable, they're going to step back. So that's an internal feeling that they have from an external factor. And vice versa, you can have an external factor where someone speaks up and says something about a discussion that they're interested in, and that will feed into them engaging, and they will contribute to that discussion. In our study 2, Factors of Online Engagement in Synchronous Virtual Learning Conversations and Debriefing, this was a realist synthesis, and this was published in November 2021 in Advances in Simulation. So what are our perceptions of engagement, and what are the factors that influence the engagement? This is what we were looking for, and our methods were a qualitative content analysis of interviews and the Communities of Inquiry Framework, which was by Randy Garrison. Now our findings here, again, we identified 10 very important themes. The first was, I can support engagement. So this is the facilitator, the debriefer, and the learner demonstrating that they can do things that will encourage engagement in other people. So like if someone is speaking, they bring up a point, by following up with that person and building upon what they said, they support engagement of everyone else, because it leads to a chain effect of everyone becoming involved. Camera off does not equal engagement, and camera off does not equal engagement, and camera off does not mean disengagement. And this was something that came up prominently in this study when we interviewed people, because some had the very strong feeling that your camera should be on so that everyone can see you, and other people felt, no, I can be off camera, I can use tools, I can speak through audio, and I can be just as engaged as everyone else. So this is still a subject of debate for distance debriefing. False engagement is a thing, and this is where if you're sitting in a group, and you've probably seen this in meetings, people have attended online and in a debriefing, and you raise a question and you maybe ask a particular person to answer. Showing that they are engaged would be to be able to answer the question, of course, but sometimes people will ask you to repeat the question, or they will comment saying something that someone just before them said, which indicates that though they appear to be engaged, they're likely not engaged. And then active engagement, someone being active, it can create engagement. It can also create disengagement. So if you have someone who's dominating the conversation, many people will feel silenced, or they will feel like they don't need to say anything because this person is carrying the load for everyone. And the same applies to a facilitator or debriefer. By interjecting too much or speaking up too much, you tend to stem the conversation of the learners. Using tools can help, but they can also hurt. As I mentioned regarding the chat, getting too caught up in chat on the side can take people's attention, and it can increase their cognitive load. Body language and nonverbal is limited, so as we've all experienced during COVID with the mask, sometimes it's difficult to understand, see, and appreciate people's facial expressions because we have something covering us. Preparation, orientation, and feedback, all three of these were found to lead to more vibrant engagement, and these were all expressed by the participants that we interviewed. And the simulation effect, this was a very important finding in this study, in that the simulation itself, and keep in mind that if you're doing distance debriefing, you're most likely doing a distance simulation. The simulation itself can affect poorly or negatively or positively the engagement of your learners. So there's an element of designing and delivering that simulation in a way on-site as well as online so that you increase the engagement. Environmental distractions. So imagine online, and I'm sure you've all seen it in Zoom meetings and in some of the very funny things that have gone around, you have people passing by in your background. That's violating psychological safety. You have a pet jumping up into your lap and into the camera. It's going to distract everyone. So all of these things, these environmental distractions, noise, people who shouldn't be there and they're listening to a conversation that should be confidential, these can all take away from your learner's engagement. And finally, we found one very interesting one, which is, do I look okay? And this is where if you're in a meeting on camera and your video is on, there is an effect of making sure that you look okay in the camera. Every once in a while you will look at yourself to make sure that your presentation is fine. In our study 3, this is a study underway. This is online engagement and debriefing, a concept development. So what we're looking for here is that we want to analyze the engagement in online healthcare simulation debriefing and develop a conceptual model that we can build on. And we follow the methods of Schwartz, Barcott, and Kim, and this is a hybrid model of concept development. And we used a mixed methods analysis in 3 phases, which is the theoretical phase, and that was where we went into the literature to see what we could find and synthesize from that. Our fieldwork phase, where we conducted interviews, and we're also doing focus groups and having discussions with experts in the field, technological and simulation. And then we will be reaching our analytical phase. And you can take a look at the theoretical phase. So we started with this, and you can see in the teaching and learning, these are all teaching and learning, cognitive presence, and social presence. This is in with the community of inquiry framework. And we have applied that to our first and second study, as well as our third study. And we will be doing the same with our fourth study. So this was our theoretical. And then we came into our Model 2 fieldwork phase. And it is here that we found more the internal and external factors that were mentioned earlier. The presentation has gone back. The presentation has gone back to another one. It's not mine. The fieldwork phase model, this is where we took in the things that we found from our previous research so that we could build upon it, and we found the internal and external factors were also deeply embedded into this, because all of these antecedents that we found, such as the influence of the simulation, will feed into the engagement of the participants either negatively or positively. So it can add to their engagement, and it can also take away from their engagement. Our final study is a structural equation model of the influence of the sim. So if you recall that I spoke about the influence of the simulation on the engagement of learners, we will be conducting a randomized controlled crossover design trial so that we have a very complex simulation and a very straightforward simulation. And we want to compare the differences of engagement of learners in these two situations. So as we were intending to recruit 60 participants, and we'll be running our trial this month. Those 60 participants, they will be divided into groups so that half of the group will be conducted in smaller groups, and they will take the simulation that is more complex, and the other half will take the simulation that is less complex. They will be debriefed, complete a survey of their perceptions of their engagement, and at the same time the debriefings will be video recorded, and we will have educators who will action code the videos for engagement, and we will compare the results through our structural equation modeling. This will be conducted in February after our pilot in December and moving forward with our recruitment. And through these 4 studies, which compose all of my dissertation work at Massachusetts General Hospital Institute of Health Professions, we hope to be able to inform future guidelines for the practice of distance debriefing so that we create a structure for all of us who work in distance debriefing for the future. And I think considering all of the distance debriefing and distance simulation that is building and all the advances that are made in technology and the way things are moving, not away from mannequins, but more into VR and AR and just using the online world, people have found great success in it, and we believe this is going to be a career opportunity for a lot of simulationists to be able to pursue in addition to their simulation career. Thank you very much.
Thank you very much, Dr. Santhia. That was really very nice presentation. I enjoyed it myself. So it's time now to introduce our third speaker. We have Prof. Edgar Israel Herrera Bastido. Prof. Edgar is the president of the Mexican Society for Simulation and Health Science presidents from 2018 till 2021, professor at the Health Science Faculty, Anahuac University, Mexico, and coordinator of Anahuac University Simulation Program. Welcome, Prof.
Thank you very much. Good evening. Assalamu alaikum. Good morning from Mexico. I'm very happy to be with all of you. Let me share my screen. And just a moment. Okay. Well, thank you very much for this invitation. I want to introduce myself also. My name is Edgar Herrera, and I'm from Mexico. And the objective of this session is that I want to share Mexico's successful experience using different medical simulation modalities during COVID-19 pandemic with all of you. I hope that this will be an inspiring talk and to open new opportunities for Saudi and Mexico civil societies to work together in order to improve patient and health personnel security. I consider that the medical education will be a before COVID and after COVID era. Before COVID, most professors and students view virtual patients, telesimulation, and the use of video conference only as a modified video game or something that it's fun, that it's very spectacular, but maybe not very useful. But when COVID-19 came, everything changed. So the first experience that we had in order to attend this pandemic problem in my country was to introduce the use of virtual patients. What we have done with the virtual patients is that we have integrated them into our simulation and healthcare activities. In Mexico, unfortunately, when the pandemic started, all the hospitals closed the doors for our medical students, nurses, emergency medical technicians, and also universities were closed. So the tool that we found that can be helpful for us in order to not lose time and to improve the training of our students was the use of these simulated patients. We use them for homework before or after clinical case discussion. We send our students the access that they can use in their computers to work with these virtual patients. And after they interact with this virtual patient, we have a clinical session with them. We also use them as in an hybrid virtual patient with simulated patient. In this case, what we have done is that the students must work with the virtual patient and simultaneously an actor and standardized patient using video conference was answering their questions or improving the experience that the virtual patient can offer. And fortunately, 6 months ago, we started to open the simulation laboratories in my country. So we started to use virtual patient and also with full body mannequin or task simulator with our students. What are the advantages of using virtual patients that we found? Well, the first advantage that we found with using this methodology of virtual patients is the patient consistency. I'm sure that everybody that has the experience of using the standardized patients, the simulated patients, we have the human factor against us. We as persons get tired so fast, and sometimes it is inconsistent. We have inconsistency between every case that they are developing. But the virtual patient offers this consistency. The other advantage that we found is that it's a multi-platform use way that we can interact with our students. They can interact using their own laptop, or maybe in a simulation lab using these touchscreen tables, or even using their cell phone. So it is very easy, and almost everybody can access this technology in a very easy way. The other advantage that we found using virtual patients during this pandemic is that they improve the team and individual work. When we developed this virtual patient methodology, we try to recreate the way that you have to work with a patient. Sometimes you have to do it by yourself, and sometimes you have to work with other persons by treating these patients. So this was a great tool for us. The other advantage is the worldwide available. It was amazing that we found that, well, we were trying just to solve the problem in a local way, just in a hospital or in a university. But this methodology helped us to make it available for everybody around the world. So we can have the same case in Mexico, in Saudi, in Japan, or in other parts of the world, and we can work together with the same patient. And one of the most important things that we see as an advantage of using these virtual patients is the objective assessment of the participants. Every time the participant uses these virtual patients, we have a record of his performance, and in this way we can assign a grade for them. Well, we found that it was not so hard to use virtual patients. The students love these virtual patients. Professors like a lot these virtual patients. So we started to think, well, we can grow this project. So we developed it in 2020, the first undergraduate medical students using virtual patients called Virtual Patient Challenge 2020. With the Mexican Society for Simulation Health Sciences, we developed this event. Over 200 students from America, Europe, Asia participate in this challenge. They have a clinical match using the virtual patient, and after the match they obtain certain points, and the best team advances to the next stage, just like in a sport contest. And the final in the last year was Portugal, Mexico, and India. And it was an amazing experience for everybody, especially for our medical students, because they find that they can work together with many people around the world. Even if they don't speak the same language, it has been an amazing experience, and it opened a great way to work together. These are the trophies from the 2019 National Virtual Patient and for the 2020 International Virtual Patient Challenge. Now I want to talk a little about distance simulation. Distance simulation has many variables of this methodology. The three most common distance simulation that you can find is telesimulation, virtual simulation, and mental simulation. And I want to focus on telesimulation and mental simulation for the next slides. The opportunity that we have using this methodology is that you can participate in any part of the world. You can use your personal computer and interact in a virtual world like this virtual hospital. You can be in a real hospital. The second photo is from one of the biggest hospitals in Mexico City called Hospital General de Mexico, General Hospital of Mexico. It's one of the biggest and most prestigious hospitals in my city. And also you can work from your university. Everybody at the same time interacting with the same patient, virtual patient, standardized patient, and using video conference technology. Some years ago, I know, video conference was something that everybody thinks that it was too expensive, too complicated to be used. But nowadays, we can use video conference with using our cell phones, or even you can get an extraordinary great video conference system by a low price. So this helped us a lot in order to develop this telesimulation and distance simulation. Using this methodology, you can assess, you can obtain objective results, and the most important is that you make shorter distance between participants, and you can enjoy from professors from all around the country, all around the world, in order to improve the students' experience learning about medicine or any healthcare sciences. Our first international telesimulation experience was between Japan. I know, Mexico and Japan, they are very distant and we don't speak the same language. But the idea that we developed between Mexico and Japan was, okay, we have to find a way that maybe using a common language, in this case English, and using a methodology that we can develop at the same time, like virtual patients, we can make our students during a semester work together, solving cases and learning from each other. And it was an amazing experience between our countries during this year of pandemic. Well, and what's mental simulation? This is a new methodology, well, at least for me and many of the members in Mexico, that we have discovered during pandemic. Mental simulation is when you, if you are a surgeon, for example, when you are planning a surgery, you have to think a lot of things before you develop this surgery. You have to think in anatomy, in the technique, what do I have to do, how can I make it happen, and what can go wrong, and how can I solve it? So you develop this mental model in your head. So this is called mental simulation. Well, how can you transform these ideas in your head into an educational experience for everybody? Well, we developed these role-play games. The idea, and this was very useful because we can get in the same room that our students during the pandemic, is that you have to develop this character. You have to be a doctor, a nurse, a surgeon, or even a patient in a different clinical case. And the idea is that when you prepare this character, we have to interact between us using video conference. And in this way, you can find, well, what can go wrong? How can we solve it? What do I have to be prepared when I treat this kind of patients? And it was an amazing experience for our students because we developed this methodology, then we use the distance simulation, and if it's possible, in real time in the simulation lab, they make the simulation experience using a mannequin or a standardized patient. For the Mexican society, well, it was an amazing experience for some universities, but we wanted to share it with all of our members. Mexico is a very big country, and we have a lot of different simulation programs affiliated, some with a great budget, some very low budget. But we want to share this experience. So we developed this virtual convention center, and in this way, any member of the Mexican society can experience this distance simulation, virtual patient, and on this methodology with all of their students also. Here is a view of this virtual convention center. We also have like a sport area where we developed this virtual patient challenge also. Well, And using my last minutes, I want to introduce you also the university where I work. This is the Anáhuac University in Mexico City. We work with over 2,000 medical students in this university. And what we have developed is this virtual hospital for the Anáhuac University. This virtual hospital, the idea was to offer our students the opportunity to experience how they will work in a real hospital from their houses. So, as you can see, it's almost like in a video game. You start this program, you enter to the main hall, and you have to select where do you want to go, just like in a real hospital. Do you want to go to internal medicine floor, to gynecology, or to operating room, or where do you want to visit this hospital? One of the most popular places to visit is the operating room. Here our students, as you can see, can push these little buttons that are the red ones, the yellow ones, and they can interact in a live camera using a 360 camera, and they can live just in real time the opportunity to work with a surgeon during a real surgery procedure. Or using the yellow one, they can view a pre-recorded session from their professors in this place. Now, let me show the function of the virtual hospital activities in an hybrid way. This is the simulation lab from my university. There you can see that they are using these rooms, that we are working in real time, but also using these teleconference devices where people from their houses can interact with the students, and they can ask questions, and they can also interact with their friends in order to treat the patient. Sorry, I don't have a translation in English. This is one of our surgery professors developing a surgical class from the university using this distance simulation methodology. And over this professor, you can find an standardized patient interacting with one of our students from their houses. So even if they can't go out of their houses, they can interact and experience this communication skills development using this methodology. And finally, I want to show you that we have also developed a virtual OSCE program where just the same way that the virtual hospital, they can go stage by stage assessing a patient. And, well, what were the results of this experience? We compare in blue one the online experience between the hybrid experience using these methodologies. As you can see, knowledge, comprehension, application, analysis, synthesis, and evaluation were almost the same thing. Of course, this was the first time we developed this methodology. We have a lot of things to improve, but it was great to find that even if this was the first time and we don't have a lot of experience or the best equipment to develop it, we have obtained almost the same performance that in the real world experience. And for my conclusion, simulation methodology offers many possibilities. The imagination and strict education methodology were our best tools. And I want to conclude my participation by thanking again for this opportunity to share the work we developed in my country, hoping you find some inspiration for future activities using medical simulation. And I hope through virtual patients, video conference, and whatever may rise soon in the simulation community from Saudi and Mexico's societies, we'll find a way to work together for our students and our patients. Thank you very much. Gracias. Shukran.
Thank you very much, Prof. Edgar. So I think there is no questions raised for the three presentation. So at this stage, we can conclude the session 3 for today. Thank you.
Thank you very much.
Thank you very much. Just we have a 5-minute break, then we'll go to the debriefing to competition. Thank you very much. We'll have 5-minute break, then we'll go to the debriefing competition.
السلام عليكم. جاهز؟ جدة تسمعونا دكتور براء؟ أحمد تسمعونا؟ يا هلا وسهلا. أهلين، شرفنا الله يحفظك. طيب والأخوان بالخبر تسمعونا؟ دكتور عبد الله؟ اوكي طيب مين المودريتور حيبدا؟ الدكتور براء؟ طيب دكتور انا الميكروفون معك، جاهزين؟
بكره الساعه 4 صح؟ 3 لا
جدا ما يسمعوا يا احمد.
طيب السلام عليكم. تسمعونا؟
سلام، الرياض تسمعك. نعم.
الخبر؟ طيب I'm gonna assume انه الخبر يسمعنا. بسم الله والحمد لله والصلاة والسلام على رسول الله. Welcome everyone to the debriefing competition, the second competition of the day. This is the first time we do a debriefing competition in the conference, so this is inshallah a great start and we'll welcome your feedback. We'll start with Dr. Muhammad introducing our learners for the competition today. Dr. Muhammad.
Consultant pediatric emergency. Today, inshallah, we'll start to present our participant in this competition today. The first participant, Dr. Najmi, is a faculty member from College of Medicine, Qasim University, and also Ms. Sajida Al-Qada. She is a clinical simulation specialist from Prince Sultan Military College of Health in Dhahran. And also Mr. Ajlan Al-Shahri. He is a simulation specialist from King Fahd Medical City. And last participant is Dr. Qasim Al-Qasim. He is from Anesthesia and Critical Care Department, King Abdulaziz University Hospital from Jeddah.
The judges for this... Sorry.
Go ahead.
The judges for this competition will be Dr. Abdulalim Atasi, Dr. Usama Ziraiqi, and Dr. Abir Arab.
Thank you. Dr. Muhammad will help us introduce the scenario.
So this is for our participant, Sada, and so you are going to debrief the trainees who underwent educational session in how to break bad news in clinical-based setting using the spikes. The trainee in the scenario are two medical students, and the script scenario is going to display on the screen now.
Patients, can you give me the over, please? Hi. How can I help?
Are you the doctor?
Yes. My name is Amani. I'm the one who's running today the clinic, and this is my colleague.
I am also a physician.
Hi. How can I help?
I did the blood tests and I came to follow up the results.
Okay. What is your name?
Hissa.
Hassa.
13.
Okay.
2000. 240.
Do you know what test you did?
No, I don't know. I'm not a doctor.
Do you know why you did the test?
No, I have no idea. They just told me I need to get the test, so I did it. Is there something wrong with me?
Just trying to find out.
Did you need help and the calculator?
Do you think this is the test?
Yes.
Okay. Okay, I got it. So I think they did the test because you have like difficulty sleeping, and the results came back. You have difficulty sleeping before, right?
No.
No? Okay. So they did a test, and it's found out, like in the test, you have diabetes. So that's why, like, they brought you back here.
But what is diabetes?
What
do you mean?
It's a disease, and you have to take a medicine for it.
But why do I have to take medicine? Why do I have it?
It is a disease affect to your pancreas, and need not able to produce an insulin in your body. It's not enough because that you need to take medication.
Yeah, you did not notice that you like sick or anything? Because diabetes, usually people become very sick.
No, I feel like I'm still young and healthy. Why do I need to take medicine?
The test says that you have diabetes, so you have to take medicine.
No, I don't care about what the test says. I know this disease. Some members of my family, they got it and they had terrible complications. I don't want to have my legs amputated. And I have no symptoms like the other members in my family. Like, what do you mean I need to take medication?
Yeah, the test we did for you, it's very accurate, and it is the hemoglobin A1C. And I think you have to take the medication and the medicine and go to your home and try it. And I'm sorry for your what's the happening with your cousin or nephew or your uncle, I guess, yeah?
Yes.
Yes, I'm totally understanding this. But you know, you have to take the medication, and we are here to help you.
No, but I'm not gonna take medication just because you think I should take medication. I need to have a second opinion.
Well, you can take a second opinion. As my colleague said, like, diabetes is a disease which, like, your pancreas is not working very well. And we were sorry, we thought that, like, you know about the disease.
How would you assume that I know about the disease? I'm just a patient, I'm not a doctor.
How we can we help you?
I don't know.
I think, like, if you want, we can give you like a brochure about the disease, and you can read about it, and like you can take a second opinion. We can schedule you next time with like the senior physician that we have in the clinic, and then you can see with them like if you want to take the medication or they have another option for the disease. And if you want to bring somebody else with you, like to see or to speak with you, or like any other person of your family, you want them to come to the clinic with you, I think can help you with this. What do you think about this plan?
Okay. Okay, I will do that. Thank you.
Yes, Hassa, we are here to help you.
We're here to help you. And I will give you like a couple of the brochures that we have, or like a website if you like to use the internet, and it can give you an idea about the disease and how to treat. Not all patients actually got amputated. If we get the disease early on, then probably you will be fine and you will not get the disease.
Okay, thank you.
Thank you so much. We'll schedule it next week, right?
Okay.
Now we would like to introduce our medical student, Dr. Amani and Ustad Al-Jawhara.
Okay, so Dr. Amani will be the one who can debrief Unfortunately, the participant from Jeddah could not participate today, so we'll start with the participant from Al-Khubar. May I ask the participant from Riyadh that they leave the room so they can, so the Khubar can start?
Yes, they already left.
Ms. Sajida, can you start?
Okay, Khubar, you can start. We will focus on the reaction phase of the debriefing for the sake of time. And as we explained earlier, we use the dash format for assessment and the results later. You can start.
We'll spend a couple minutes talking about your performance during the simulation scenario. My role in this discussion to facilitate the conversation between the team, and I expect from you to share in that discussion, to answer a question, to open to share your perception in a professional manner. Just think about the reality of the scenario. Simulation not exactly like a real life scenario, but we are doing our best to be realistic during the scenario, and we are learning from our mistakes. It will deal with it like a puzzle to solve, not crime to punish or to feel bad. I will guide this discussion in 3 phases. First phase will talk about how it was the scenario, how it went the scenario, how about your feeling during the scenario. Then we will dig deep, so deep. Then we'll talk about analysis and understand what happened and how we can improve our performance. Then we are going to summarize, take-home message, and we will summarize the key points. So will the goal of this scenario, as we mentioned at the beginning, it is about communication. How we can break bad news for the patient using Spike's technique. Amani, can you tell me talk about your feeling during this scenario, if you please?
Yes, I think my feeling is, I was very happy. I think I did very well.
Can you tell me about your feeling? How it was the scenario for you? Talk about the scenario, feeling during the scenario.
Very happy doing the scenario, and I felt very comfortable when I was doing it.
Thank you, Amani. I want to hear from Johara.
Yes, I'm also very happy because I'm doing very well.
Okay, great. Let us recap about what happened during the simulation scenario. Anyone from the team can summarize what was going on during this scenario?
We had a female coming to the clinic with following up her results, and it turned out to be having diabetes, and she did not know. And we told her that it's a treatable disease and she can go and take the medication and be happy, and afterwards, if she starts the treatment, she will be well.
So, now, let us talk about the technique that you use. Thank you, Amani. We will discuss Spike technique. Can you tell me, Johara, Spike stands for what? Let us start from S.
Sitting.
I'm curious to know about how you prepare for the sitting.
The place, and there is a tissue, and we are introduced for us first. Yeah, that's it.
Okay, great. I saw you during when the patient came in the scenario. Get busy with your phone. I wonder why.
Why? I didn't remember right now, but I guess it's something urgent.
Why?
Why? When she when she entered first, maybe in the next time when she inserts the room, I leave my phone. I leave my cell phone.
Okay, طيب Mani, when the patient came in, you were busy looking to the computer screen. Help me understand why.
Looking at the patient name just to make sure she is the right person, that she is in my clinic.
You knew you had any idea or any information about the patient before she came in?
No.
So in that situation, how you are going to look for information about the patient who will come inside your clinic?
Well, maybe next time I will try to look for the names before they come, so it's going to be easier for them to do that and introduce themselves in a better way.
Let us talk about the body language now. I saw both of you sitting behind the table, busy, like I mentioned before, Johara with her mobile, getting Mani focusing on the screen. I think if you want to speak with a patient coming to you, you need to give him attention, him or her. I wonder why didn't do that.
Yes, maybe next time I sit beside with her and rub it in her shoulder.
Okay, thank you very much, Doctora.
My time is over.
Thank you.
Thank you, Amani.
Welcome.
Okay, can you hear us? And
so our next
Jeddah and Riyadh?
Yes, we can hear Jeddah, and we can hear Khubar.
Okay, Dr. Muhammad, thank you very much. Now we'll move to Riyadh. So can we have one of the participants come to debrief Dr. Amani, Dr. Al-Jawhara?
Because the Khubar have a problem with the venue, they're going to close the venue soon. So Dr. Muhammad will have his candidate first.
Okay.
Assalam.
We will have our debriefing session today, inshallah, will be conducted. And what we're going to do is, first we're going to give you a chance if you have any concerns or comments, and then I'm going to give you feedback about your performance and give you some time to reflect on your performance, and then finally we're going to summarize what were the points and what were the points that you need to improve for your next inshallah session. So, first, first, do you have any comments or concerns that you want to discuss?
I think we want to know, like, if we did a good job, because we read the material and, like, we practiced it before. So we want to know I want to know if I did good. What do you think?
Like Dr. Amani, I want to know.
You followed the spikes, and I think I like very much that you set a very private environment and there was no interruption. That was really good. Then when you ask the patient how much she knew, it wasn't, first she didn't, you just tell her that she had diabetes, and it's good to ask her how much she knew about diabetes. And then you need to explain to her, when you told her this is a problem of insulin, the patient might not know exactly what is the effect of that, and you tell her that she needs medication. So it will be good to explain to her what does it mean to have a problem in insulin in terms of what is the effect on her body, and why is the medication necessary to take. And then you need to tell her about the prognosis also, and what is the treatment plan, and what will be coming next. I like that you've addressed her concerns about her ankle, and you emphasize, you were good when you comfort and told her that she's not everybody will have amputation. But that's also a good point to further clarify to her that what's important to know about avoiding these complications so that she didn't get them. And you need also to encourage her to ask questions. And I see that she's not convinced, and that is that's expected, because it's not when a patient had a bad news, they may have this denial, and she seems to have this denial because she's saying she feels well, and that's okay. But then you need to give her some time to sort of to have a silence for a while, so that she reflects on this, and she could sort of think it over. And her reaction was expected. The denial is so. So I think that what you do is to sort of, after you give her some time to reflect on this, to give her some more information that help her to make an informed decision about the treatment. And it's good that you gave her these brochures and websites to go to. That's a good point. And it's good also to tell her that where she could get support. And of course she was sort of in denial, and she requested a second opinion. And it's good that you give her a chance for a second opinion. But what you could do is you could try and sort of discuss with her in simple terms what does that mean. But now she's requesting a second opinion. I think that's a good idea, to give her some information to go and look it up. Yeah, okay, sorry. Okay.
Shall we move to Riyadh?
Okay, we'll move to Riyadh. Can we have can we have the competition in Riyadh? Can you hear me in Riyadh? رياض دكتور أماني تسمعينا؟
سامعينكم. السلام عليكم. سامعينكم دكتور براء. بس دقيقة يجينا الكونتستنت.
طيب.
Yeah.
ننتظر الرياض. I want to take this time actually to thank Dr. Al-Jawhara or Dr. Amani for their participation. It's not easy to come out and get debriefed in front of maybe the whole world as we are online.
أخذ أوسكار
So
أنا
thank you
وجوهرة.
very much for your time, for doing the scenario, and we hold the basic assumption here again that we discussed during Simdawri.
Yes, I would like to introduce myself, Ajlan Al-Shehri, and I would like to debrief Dr. Amani and Dr. Al-Jawhara. So let's start. Right. Describe what happened in the simulation, Dr. Amani and Al-Jawhara.
So we had a patient who is sick and she having symptoms of she's not feeling well, and she came to the clinic, and me and Johara told her that she has diabetes.
All right, and now we would like to know your feeling. How was your feeling after the simulation?
I'm happy. I did very well, actually.
What about you, Dr. Amani?
I think we're medical students. We don't know much, so I think we did very well.
But you feel that you're happy and you...
I feel comfortable and happy.
All right. So we would like to talk about the non-verbal communication. Could you tell me what went well during the simulation?
We were medical students and in the clinic, and we were breaking bad news regarding diabetes.
So I would like to remind you about the objective of this simulation. It's about how to debrief a patient and give him deliver bad news following the spikes. So I would like to hear from you also, Al-Jawhara. Tell me what went well with you during the simulation, please. So I noticed...
yes, we did very well.
Yes.
In this session.
So I noticed it's about the non-verbal communication, and I noticed that Dr. Amani was looking to the screen and talking to your colleague. So at that moment, what was in your mind?
Well, I don't know her name, so I was looking at the screen to make sure that she is the right patient who's coming to see, in the clinic to visit us. So that was what I doing. And in my mind, I want to double check that she is the right patient.
All right. And what do you think also? I noticed that Mr. Al-Jawhara was looking at her phone. I wonder what was your what are you thinking at that moment?
Sorry, but I get a message from my mom. I have to answer.
All right. So I would like to explore about the communication and how it's important. Would you please tell me about the importance of the communication, especially with when delivering bad news to patient?
Maybe I wouldn't use my phone in the clinic next time, or when she entered the first.
And I guess like I will make sure of the patient name before I let them come to my clinic.
All right. So the summary.
Thank you so much, Adnan. Time is up. Now we're gonna move to the next session. Thank you so much, guys.
I'd like to thank all the participants in this competition. We did it first time, and it's very challenging to do it in front of people in the Zoom and the virtual. So thank you so much, and I think we can move to the next session.
Thank you. I just want to say that the results will be tomorrow. Thank you.
إذا جاهزين. هلو. شغال؟ جاهز يا جاهز احنا؟ اللي في الفيرتشوال جاهزين؟ اللي في الفيرتشوال جاهزين؟ دكتور آدم جاهز؟ It's my pleasure to moderate the last session today. In the last session, I'm going to be with Dr. Abir Arab and Dr. Hood moderating this session. And we're going to start our first speaker. And I would like to thank the first speaker for waking up early in the morning, because Dr. Adam Ching is actually in Canada. And he thankfully agreed to be with us at this time. So Dr. Adam Ching is a professor in the Department of Pediatric and Emergency Medicine, and he is like a great researcher in form of resuscitation and also in debriefing. Dr. Ching is also a co-founder of Inspire Network, and he was my program, and he is still my program director in simulation when I was a fellow in Canada. So Dr. Ching is going to talk about the challenges in debriefing virtually, which is I think we had couples of them today. So Dr. Ching, the floor is yours, and please.
Thank you, Amani, and thank you so much to the organizing committee for this opportunity to speak today. Before I dive in, though, I just want to check that my audio is okay. How does it sound, Amani?
Sound perfect.
All right, I'm going to share my screen.
We can see your screen now.
Great. So thank you so much to the organizing committee for this opportunity to speak today. The last couple of years have been really challenging for all of us all around the world, and it's sort of pushed us to try things differently, to deliver education differently. And with those come challenges in being able to optimize the way that we offer our education, particularly through simulation. So today I'm going to spend some time talking a little bit about virtual debriefing and how to best optimize the learning experience through platforms such as this when we're debriefing through online platforms. So the objectives for today are to describe a conceptual framework for virtual debriefing. I'll then go into illustrating some techniques to enhance the virtual debriefings that you're running. And then lastly, I'm going to highlight some faculty development strategies for virtual debriefing. So just last week, actually, there was a paper published by a colleague of mine, Amanda Rose Dizordan, and in her paper, what she describes is 4 key roles for the simulation educator or debriefer. So when facilitating or conducting a debriefer, we see the debriefer playing the role as a guide who both develops and nurtures relationships and provides some structure to the conversation. The debriefer also facilitates conversation, and in doing that role, he or she seeks to understand learner perspectives, responds to learner thoughts and emotions. Of course, there's a teacher role as a debriefer, so there you're imparting knowledge, you're cultivating insights. And then lastly, sometimes there's a need to be a mediator when there's conflict, when there's disagreement. The debriefer then manages this conflict, seeks to flatten hierarchies, and reconcile differences. All of these four roles and the role of the debriefer is underpinned by the importance of psychological safety. And so without a psychologically safe learning environment, specifically within this debriefing conversation, it makes it really difficult for the debriefer to execute these four roles. And so the question is how do these four roles translate over to the virtual or online environment? And what is different? And how do we make it feel like we're in person? So let's start first with the definition of virtual debriefing. Virtual debriefing is a type of virtual learning where educators use web-based video conferencing to facilitate reflective discussions. As I said, in the past couple of years, there's been a very abrupt shift to telesimulation with virtual debriefings. And, this has forced simulation educators to adapt their current debriefing approaches to online platforms. Unfortunately, many debriefing skills that they normally use don't necessarily translate over to the online environment. And so what educators need is some sort of practical guidance to support meaningful virtual learning and the transition from in-person to virtual debriefings. And I believe this is best framed by the three presences that are described in the Communities of Inquiry framework. So Professor Randy Garrison and his team have offered up this Communities of Inquiry framework to describe three core interrelated elements: teacher presence or educator presence, social presence, and cognitive presence, all of which are required to create successful virtual learning environments. And these three elements, what they do is they help to conceptualize how online learning spaces are jointly created by the manner in which educators plan and facilitate their session, how learners think and solve problems together, and the ways in which all parties sort of connect socially within these online contexts. And although this was originally developed for asynchronous online learning, this Communities of Inquiry framework has been studied and applied extensively and adapted to synchronous online learning, and I believe that it is a very nice fit for what we do as debriefers in the virtual environment. And so today I'm going to be talking about some of the details shared in this paper that was recently published in Advanced Simulation. So to be socially present, individuals, they should be able to project their personal characteristics and their identity in the online environment. And so, for example, a normally extroverted and gregarious person, sometimes they may actually project as shy, cautious, or introverted in an online environment. So what we want to do is we want to create an environment where they can project their real selves. And this involves creating a climate where learners can communicate openly and share emotion that's been generated by their learning experiences. And so three key elements of social presence are open communication, emotional expression, and group cohesion. So psychological safety is required to be able to build social presence. So psychological safety is really the sense and the perception that consequences of taking interpersonal risks in a given context. For example, in a particular team, it's sort of a sense of confidence that the team will not embarrass, reject, punish someone for speaking up. What's key about psychological safety is that it's not something that can be declared. It's something in the eyes and minds of the learner. And so it's perceived, it's unstable, it's dynamic, and it's extremely fragile. And you have to work as an educator to be able to build and maintain psychological safety. So if we think about the typical simulation, that contains, a pre-briefing, a simulation event, and a debriefing. So we've all been taught during the pre-briefing to address psychological safety and to reassure learners that it's a safe environment. However, just because we declare that doesn't necessarily make it so. And so our job is to start to build psychological safety in the pre-briefing, through the simulation, and then maintain it in the debriefing. And this requires us to be consistent. And so what we say in the pre-briefing needs to be carried through to the debriefing. If we make promises in the pre-briefing, we need to execute those promises in the debriefing. When those promises are broken, they represent a threat to psychological safety. And then what happens is then you have to work to rebuild psychological safety as an educator, and that becomes much tougher. So I want to show you a quick video, and this video is of a debriefing. Now the simulation was an online simulation where there were 3 participants. I'm playing the role of the emergency doctor. The gentleman in the right lower panel is a fellow. The young lady in the right upper panel is a nurse. And then Grace Amy, who's a colleague and friend of mine from New York, she's playing the role of the debriefer in the left upper panel. And so she's run us through a simulation where we had to conduct a huddle in the trauma room in advance of a sick patient arriving for us to look after. And so what I want you to look at is sort of what elements of debriefing make it challenging, what features or what behaviors threaten the psychological safety of this debriefing.
So now let's talk about maintaining situational awareness when you are assessing the workflow and volume in the ED. So looks like you were getting a team together pretty well in the process, but somewhere along the line, right before the patient arrived, you learned that the ED was actually pretty full and there were multiple patients in the waiting room. So I'm curious to hear, how did that change your assessment of how you should organize yourself? Katie, there?
Go ahead, Aaron.
I don't know how I did, because a lot of this functions, I was wondering what we were going to do it all. The patients are on the minute, and we're just getting clean. We can't stick the patients there. We do, give them COVID while we're trying to stop them from seizing. And so I was starting to worry we were going to intubate the nursing station.
Good point.
If you get intubated, unfortunately.
Yeah, I mean, I was just wanting to get us a space. It didn't really matter if you're helping or what I did on normal days. And I was more just worried about human resources and this patient.
Yeah, there's certainly concerns typically in a busy emergency department.
So you can see from this short clip that there are several things that are apparent, the potential challenges with debriefing in the online environment. First off, there's one learner who's sort of coming on and off camera, which makes it really difficult to interact with that particular person. The camera view of the 2 of the participants is skewed, and one is off to the side and the other half of his head is cut off. And then you can notice that they have trouble with turn taking, and so that makes the flow of conversation quite challenging. And then, of course, at the very end, Aaron, who's playing the role of the fellow, is typing on his computer, which can be quite distracting. And not exactly knowing what he's doing, but ultimately we learned that he's actually typing in a chat box for which there was no particular ground rule set ahead of time in terms of how the chat box was going to be used. And so all of these different behaviors contribute individually and then collectively to threaten psychological safety. And so these are some additional barriers are also the reduced use and ability to use nonverbals as signals for cueing and for facilitating conversation. The difficulty with eye contact and being able to manage conversation by using eye contact. And lastly, the difficulty to be able to acknowledge contributions through nonverbals. And so all of these present significant challenges in trying to facilitate debriefing in the online environment. The question is, if these are the challenges, then what do we do to go about building and maintaining psychological safety in this new environment? So the first comes with very explicit verbal communication. So what we say, like that carries through in virtual debriefings, and that's really important. And so all of these different strategies that I've listed there, the expression of appreciation, validating and acknowledging contributions, normalizing certain behaviors, particularly errors when they occur, is incredibly powerful. As a debriefer, if you're able to demonstrate some vulnerability, that will help to flatten hierarchy and also level the playing field to make learners feel psychologically safe. And then inviting and encouraging input verbally and the use of inclusive language. Words like we and us, as opposed to you did this, and you did this, you did that, next time you need to do this and that. The use of terms like we and us can help to build psychological safety and a sense of teamwork. Nonverbal or implicit strategies, they're generally categorized as sort of state of mind, body language, and eye contact. And of course, as I mentioned, these things here, the body language and the eye contact, are a lot more difficult to use in online debriefings. So we need to rely more on verbals, and when possible, if you can exaggerate your body language, that can help. And so oftentimes what I like to do is I like to make my torso visible. And the reason is that allows me to demonstrate interest by leaning in a little bit, right? If I'm purely out to the camera like this, my learners don't know if I'm leaning in or not because my face is pressed up against the camera the entire time. And so just being back again allows me to see my torso, but it also allows me to use my hands, demonstrate interest, and then when I'm generating sort of facial expressions, I'll just try to be a little bit more demonstrative in comparison to if I was doing this in an in-person environment. So if I'll smile, I'll smile bigger. If I nod, I'll nod a little bit more deliberately. And these little things help to demonstrate sort of validation, communicate validation and and all of this is described in a paper published by Michael in EMJ Simulation Technology Enhancement. So if we come back to the three presences, so cognitive presence will remind you, so how learners think represents their cognitive presence, and it's defined as the extent to which learners critically reflect and construct meaning through reflective discourse. And so indicators of cognitive presence include learners who are able to identify problems, exchange and connect ideas, brainstorm solutions, and apply new concepts to their existing practice. So virtual debriefings, they also benefit from educators who are able to adeptly manage the debriefing process to prompt reflection while both balancing learner and instructor centeredness. And so in particular, learner-centered facilitation approaches, they enhance cognitive presence through reflective discourse that encourages learners to identify and explore problems, exchange knowledge and debate activities, for example, and to apply new concepts and solutions. And so one of the best ways to enhance cognitive presence is to apply a more learner-centered approach to debriefing. There are a few technical things that you can do to enhance cognitive presence. So firstly, we encourage the use of breakout rooms. If you're in a larger group, you can always have the option to have sort of smaller breakout rooms with smaller debriefings, which gives people more of an opportunity to share. Please establish rules for using the chat box. Yes, the chat box is a great tool. However, it can be distracting if there's too much chatter that's going on in parallel with the chat box in conjunction with the live conversation. Please set some guidelines for muting and unmuting. Typically when we're running courses, if we have a smaller group, 4 to 6 people, we'll just have everyone unmuted, and that actually helps to promote conversation. There's sort of less of this turn-taking issue, but of course for that to work, everyone's background needs to be very quiet. Then of course we really like to have everyone on camera, on view, so that you can see people, you can see their facial expressions, you can see their body language. There's nothing more challenging than facilitating a small group conversation where only a fraction of the people are on video. So we really like to encourage everyone to be on video and to use the grid view. And so establishing rules of engagement are really important for promoting and encouraging and optimizing cognitive presence. And so this whole notion of turn taking, hand raising, like how are you going to hand raise? Are you going to actually allow people to raise their hands like this, or do they have to put the yellow hand emoji up? You know, what are you going to do to minimize interruptions? And how can you ensure that people aren't multitasking on their phones the entire time during these sessions? And so setting some ground rules ahead of time help to clarify things. So moving on to educator presence. And so educator presence, it relates to how educators design and implement educational activities, how they facilitate discourse, how they provide instruction. And so the task of the educator is to appropriately structure and deliver content, and define topics, guide discussion, seek consensus, and to summarize key learning points, as you all know. And so while sort of in-person and virtual debriefings may differ in some aspects, the basic tenets of effective debriefing still apply, and using a structured framework is one of these basic tenets. And so we encourage you to sort of use a framework that you're familiar with. Whatever it is, there's a variety of different frameworks out there, but what that will help you do is to provide a consistent structure to the discussion that your learners are familiar with. So as I mentioned, many different debriefing frameworks out there, whether it's debriefing, good judgment, or gas model, 3D model, diamond debriefing, and there are more multi-phase frameworks like the PROS framework, team games, after action military review. Just pick one that you're most comfortable with, pick one that you're most familiar with, or that your learners are most familiar with. And of course, you know, ideally it's a framework that can be applied whether you have one facilitator or whether or not you're co-debriefing as a pair. So there are various different conversational techniques out there in your debriefing toolbox, such as learner self-assessment, plus delta, directed feedback, certain questions, efficacy inquiry, etc., etc. These techniques, what the aim is to engage participants in different manner, with different goals. And so what we want to try to do, as with in-person debriefing, is to pick and choose the conversational strategy and tailor it to your need, your learning goal, learning context, and your learning objectives. Debriefing scripts help novice debriefers achieve that goal, and so we often encourage the use of scripts to help to accelerate the learning curve a bit. They provide sort of structured learning for people to get through a debriefing if they're not as experienced. This is one example of a debriefing script that's on our website, debrief2learn.org. This debriefing script, I think, is now available in 8 or 9 different languages. I believe it is available in Arabic as well, so you can go to the website, download this script for free. You can see on both sides that on one side provides the structure and on the back some details with respect to debriefing approaches. And so I sort of encourage you to think about using these cognitive aids to support faculty development, because I think you'll find that it helps to get your debriefers up to speed much quicker compared to their non-teachers. And just one final word about virtual debriefing. What we found is it's really important to use checklists to ensure we're covering off all the key things before we dive into a virtual session. And so this is an example of a virtual debriefing checklist for learners. We also use one for our faculty to get our faculty on board in advance of sessions. And so with our learners, we'll just go through this checklist with them ahead of time to help to establish ground rules and set expectations. So in the final 5 or 10 minutes today, what I'd like to talk about is a little bit about what we can do to help our debriefers get better at virtual debriefing. How do we train our simulation educators? And so reflecting on this grid, which was presented by Yvonne Steiner and her team in a recent review of faculty development approaches for medical education, She offers sort of 4 different key categories for faculty development approaches. And today I'm going to be talking about sort of 2 key categories, this category of peer coaching with learner or expert feedback, and then also this notion of sort of learning by doing, by observing, and self-assessment. So if you think about the simulation educator, who's there sort of noted in the circle up there at top, there's sort of 4 key sources of feedback for this person. He or she can receive feedback from their learners, from their peers. They can self-reflect, or they can receive feedback from experts. And so first off, how do we go about optimizing peer feedback to enhance our own debriefing skills? So what we found is that it's really difficult often to encourage folks to give feedback to each other within simulation programs. There's obviously challenges with respect to hierarchy. There's challenges with respect to learning needs, right? Some simulation educators are working on one thing while others are working on something else. And then of course there's challenges because some folks just don't have the expertise to be able to deliver effective feedback with respect to debriefing. And so one of the key activities that we like to encourage is this setting the stage conversation. Namely, we encourage educators to get together ahead of time before they deliver the simulation session to chat about how their peer coaching is going to work on that day, what their learning needs are, what they're working on that day, and how they can help each other get better. We find that just by having this conversation, it not only improves the peer coaching conversations that happen later, but also it enhances the likelihood that they'll actually occur. And to support these peer coaching activities, we have a peer coaching checklist, which essentially has all these elements of excellent debriefings with very, very discrete, detailed information to support meaningful feedback. And so when people don't know, what behaviors they're looking for, this checklist helps orient them to the behaviors that they're looking for. Secondly, self-reflection can potentially be, a great opportunity to get better. Let's remind ourselves of the importance of informed self-assessment. And so the more we do self-assessment, the more it helps to promote goal setting and encourages us to commit to getting better. Of course, objective feedback is really important. If we're just basing our self-assessments on our own judgments, that's less effective compared to if we actually have objective external data supporting our own self-assessments. And the more accurate the assessment, more likely that it's going to lead to behavioral change. So what we're looking for is both our internal data, which is our own subjective perception of our performance, coupled with external objective data to support our assessments. And so the way to do that, I think, is you can either have like a peer coaching checklist, as I mentioned before. You can use a DASH tool or an OSAD tool. These are 2 different sort of debriefing assessment tools where you can sort of self-reflect on your own performance using very objective, well-defined criteria with a rating scale. And so you can sort of see how you did on one element versus another from debriefing to debriefing to help yourself understand where you're struggling and how you can get better. And so if you're going to self-assess, use some sort of checklist or debriefing tool to support your self-assessments. And then lastly, there is obviously opportunity to receive feedback from experts. Now, this can be challenging because power differentials and hierarchies within our healthcare system exist, and these are very real, and these must be managed to optimize the feedback experience. And so the way that we've done this within our program is we've set up group feedback sessions that are virtual online in the Zoom environment, where all of our fellows will bring sample videos of their own debriefing performances that are tagged at specific points that they'd like to discuss. And then the facilitators of that feedback conversation, which would include folks like myself, my colleague Vince Grant, and others, we may bring videos of our own debriefings as well. And so what we do is we go around, everyone shares their own videos, we all sort of collectively reflect and give each other feedback. And what we hope is that by Vince and I sharing our own debriefings as well, we're demonstrating some vulnerability there. We're trying to model that, just because we're the directors of the program, we're still open to feedback. And in doing so, we hope to sort of flatten the hierarchy a bit to make it a little bit easier for them to give us feedback, but also for us to give them feedback on their debriefing skills. And so everyone shares. We try to create an environment where it's a level playing field. And in doing so, we found that these sessions are very powerful at helping folks improve their debriefing skills. And so to summarize, I think, we talked about 3 different key presences: social presence amplified by the importance of psychological safety, cognitive presence enabled by optimizing technology, and teacher presence sort of supported by debriefing tools. These 3 key presences helping us deliver optimal virtual debriefings. And then with respect to faculty development, utilizing peer coaching by having a setting the stage conversation, using informed self-assessment to support your own assessments of your own debriefings, and finally, incorporating some expert feedback by helping to flatten the hierarchy. These 3 faculty development strategies to help your faculty get better at virtual debriefings. Hopefully you found a few pearls to support your practice in that talk. Thank you again for the opportunity. Hope to meet you guys soon in real life.
Hopefully, yes, this year. There is one small question because, like you mentioned, that you're doing a course of the Academy of Debriefing and you're doing it with different facility from different parts of the world. And so how can you manage the time among each one of them when you run the simulations, the debriefing course with them from respective time changes and time zone lag? It was very challenging for us to do the conference with the time changing. So what is your experience regarding that point?
Just with respect to time zone differences?
With the time of virtual and debriefing at the same time. The people have to be focusing and concentrating on the people what they're actually seeing, and it's not like easy you're opening a lecture and see it. Debriefing, they need the high mental function to focus on.
Yeah, I mean, it's not easy. I mean, anytime that you're running a virtual session, you're coming into people's homes and our lives are still going on, right? And so part of it is just recognizing and acknowledging that at the outset. And so what we try to do is we try to keep very flexible. We establish ground rules around what we expect of folks, in terms of not being on their phones and not doing their emails while we're engaged in sessions. But at the same time, we acknowledge that there's a good chance that we may meet their kids during the courses.
Exactly.
Maybe my daughter shortly, she's going to be waking up in about 10 minutes and she may come into the office. And so, these things happen. And I think that just by acknowledging them and setting some ground rules, but also acknowledging that life goes on, it creates more of a sense of safety so people aren't as anxious. And if they're not as anxious, they're more likely to share it. So I think that's one of the key things that's important for us.
Thank you, Dr. Cheng. And I think the most important point, creating the safety among the learner and the facilitator, this can make everything go smoothly and easily during the virtual debriefing and platform. We really appreciate you present with us, and thank you for joining us. I think we don't have to have the question and answer at the end, so you can go relax. Thank you so much.
Thanks, everyone.
Bye. I think Dr. Hood now is going to he's on the online zone, on the Zoom line.
Yes, Assalamu alaikum.
Alaikum salam, Dr. Hood.
Ahlan wa sahlan. Yes, it's a pleasure to be with you. And I think because of the time limit, the next presenter is going to present on utilizing healthcare simulation during time of crisis. And we have Dr. Julie Maxworthy, who brings the wealth of clinical and executive experience to her multiple roles, ranging from academic innovators and collaborators in the field of nursing with a background of more than 30 years of experience. And speaking specifically about simulation, she also currently holding the post of the president of International Board of Directors for Society of Simulation in Healthcare. and she led the revisions of the standards in 2 occasions. A lot of information. She is also having a lot of chapters in the well-known textbook in simulation, which is defining the excellence in simulation programs. So without further going into her long, lengthy bio, I think I will keep the floor for her. Welcome, Dr. Jolie, and the floor is yours.
Oh, thank you very much. I'm very excited to have the opportunity to chat with you. I have a presentation which I'm not 100% sure if it has made it to the right places, but I have it here and I was just going to play it through my screen.
Well, at least I can see you. And
so let's see if this works. Can you see my screen now?
We see the video. You like it's a video?
It's trying to come out.
Yes. Yes, we can see it.
Okay, excellent. So I'm going to let it take. I'm going to let the video speak for me, and at the end I can answer any questions anybody might have.
For the Society for Simulation Healthcare, and I'm very pleased to have an opportunity to chat with you today a little about how SSH has played a part in utilizing for the needs of our community practice during these very difficult times. I'm an associate professor at the University of San Francisco, and I've been an accreditation reviewer for SSH for over a decade. I'm one of the editors for Defining Excellence in Healthcare Simulation Programs, and I've been heavily involved with SSH for many, many years, as many of you also have been. And for that, the organization is very appreciative of. So just a quick overview, the mission of SSH is to serve our members by fostering education, professional development, and the advancement of research and innovation. We are here to promote the profession of healthcare sim through standards and ethics, and we are out there championing healthcare simulation through advocacy efforts, sharing, facilitating, and collaborating. And no other time has it been more important during these last couple of years. And the purpose of the society is to serve a global community practice to enhance the quality of healthcare. So some of the areas that SSH has been focusing on, as hopefully you all are aware of, we have sections, interest groups, and affinity groups. In particular, the affinity groups are those that we are seeing a great number of individuals get involved. And the beauty of those is you don't have to be a member of SSH, but you can join and connect with others through the affinity groups and elements of our Sim Connect environment, which people find very helpful and have been very important during these difficult times. Some of our collaborative efforts, in particular accreditation, we have done incredible work linking organizations that are seeking accreditation to have mentorship from already established programs. You know, certification has grown tremendously over the years, and more programs are having an expectation that those who join the organization get certified either as an SE or an SOS within just a couple of years of joining. As you know, we have a journal. Like I said, the certifications we have are the SE and the SOS. We also have the advanced levels. We have IMSH, which is coming up soon, SimOps, and many courses free or need to be paid for that have made a huge difference during these difficult times. As a member of the board, it's a great opportunity for you to network globally. There's chair positions, executive leadership opportunities, and of course, innovation technology, which is really the middle name of SSH. So a little bit, you know, we've all been living this the last almost 2 years. So it was very clear that when COVID was showing that it was not going away, and it was determined that it was a pandemic, healthcare simulation programs were already gearing up, as they had done in previous periods with Ebola and other outbreaks, SARS, you know, the donning and doffing. You know, healthcare simulation really had an opportunity to show what it can do to improve outcomes for staff in preparing for taking care of this very challenging population. You know, we were at the forefront of providing mass education to healthcare providers. You know, SSH leadership, we quickly realized that our members needed just-in-time information and put out a web page on our SSIH website, which was free. What we were really trying to do was get the word out that we had resources and that we could be a hub for this information to be disseminated. We had experts throughout the field providing examples of best practices, and I'd say we were pivoting, which is just kind of what we do in healthcare simulation. So these are just just this couple of snapshots from the SSH web page that we put out and built upon over the course of the last almost 2 years to give people opportunities to go to one place and get to the information they were seeking so they could easily provide education that was so needed as we pivoted from in-person to an online environment in most countries, and in some situations are still doing it a great deal. Social media, and there's a piece here about how to connect on our SimConnect website for affinity groups. We also had a lot of information about how individuals could utilize and should utilize PPE. And so they were donning and doffing videos from all different organizations across the world as we were trying to get our arms around how to best provide the support needed during the initial outbreak and throughout the pandemic. So it's been very clear to those in healthcare that simulation was a modality that would be able to fulfill an incredible void that was needed to assist learners to matriculate to their educational programs. And for established, residencies, schools of nursing, all the disciplines, they all had to quickly shelter in place and then pivot to an online environment. And we were incredibly fortunate that we had access to great systems such as Zoom and what have you. It wasn't the same as in person, but it did give us an opportunity as a community of practice to be able to then provide the support and provide mechanisms by which students could still matriculate and be successful in their pursuit of licensure. And in many countries expanded the ability to count simulation hours for the development of the clinical skills and thereby showing their competency. So I was involved with a group that was formed during this period of time. It was through the Inspire IPPS group, and a group came together that has evolved into what we call now the Healthcare Distance Simulation Collaborative. And I want to give you a little bit of information about this work. It was under the leadership of many people, but in particular Isabel Grove. There was a distance simulation summit, a taxonomy group, and a scoping review team formed this collaborative. And it was Todd Chang, who was in charge of heading up a taxonomy group, to help us understand and define distance simulation. Started talking about what we were trying to do and the way we need to present it. And it started this whole body of work that I want to share with you. So it was a collaborative. We reached out to many of the different affiliates to garner their support in disseminating our survey, which was, we had over 25 groups that volunteered to help us in this. We had a team, we had a core research team that met weekly to do the research, and we also have a steering group who helped guide the development, dissemination, and analysis of the work. I was part of this, the core research group, and it was just a dynamic team that was very interested in asking the right questions to get some information about how COVID was really affecting what's going on in healthcare simulation. What the survey group did was we were going through the IRB process, trying to figure out, well, what is it we actually want to know? And in that process, we came up with essentially a research agenda. Phase 1 is getting a snapshot of what it looks like. Phase 2 is how can we best inform educators? And that's the next step. And then phase 3 is what the hot question for all of us is, what we want to really explore at the end of the day is what is it as effective as in-person education? So in our development process, we had a survey development team. The survey was developed by a core group of 8 experts in healthcare simulation research and practice, identified by their leading roles within the healthcare simulation community. The group also included 2 experts in survey design. And our literature review was conducted by the core research group and via scoping review team within our larger group before developing the survey to ensure that our survey aligned with prior research in the area. The identification of key principles, we held several discussions amongst the research team to identify the aspects of this simulation that would best answer the research question and identify several key themes to explore in the survey. Subsequently, the core research team broke into smaller groups to delineate specific types of questions and topics that would explore each of these themes. And we then had a development of survey items. An expert in survey design on the core research team took the work done in the previous steps and developed the specific survey items and inputted them into a Qualtrics survey software tool. We had expert validation. The core research group reviewed all the survey items for clarity and to ensure that they accurately reflected the concepts identified as important to explore in the survey. We did some pilot testing. The survey was sent to a group of pilot testers from the target population who were recruited by the survey team. These pilot testers were deliberately recruited from multiple countries and roles within simulation education. The pilot testers provided feedback on the survey via an email, and this was incorporated into further edits. The final survey was 44 questions long and estimated to take about 15 minutes to complete. So we had simultaneous efforts. You can see we had some taxonomy going on, addendums to the SSH dictionary nomenclature, Delphi census. We had a consensus on the terminology. We had a scoping review, an extensive systematic review of the literature, a pictogram looking at ways to present distance sim methodologies, and then a survey of distance sim, including unpublished work. So our findings of our survey, which a lot of people were very interested in. So to begin in terms of the product sample distribution, so overall, in terms of the analysis that we were presenting, the overall sample size was 618. In terms of the raw data that were actually collected, we actually reached slightly over 700. But because of missing data, some people came in, and they looked at the first question, so they stopped and what such forth. We actually decided to drop about 5% for the respondents, which is about 12.7%. So it gets us from 708 to the 618 that you see here. So most of the analysis, particularly some of the highlight analyses, are based on 618, but also mention some of the others because people did skip through. It's not going to be at the 600 level. There's going to be some fluctuation in some sample sizes. So I just want to make that point up front. So, there were survey responses across 7 different languages. And the median, and in terms of survey time, because that is a skewed distribution, was around 9 minutes. But it goes on for some people took a long time, and others took a lot shorter time. So we so our total, like I said, our total responses was analysis was 618 in our survey times, whereas I noted. In terms of the respondents were so across 32 countries, and then within the United States, 44 states. And I know we'll spend a little bit more time in terms of responding characteristics later on, but the people who dedicated in terms of the simulation, about 50% or 40 or less than half the time, and then 60%, somewhere between 50 and 75% of the time. And then 41% of the respondents spent the majority of their time, 75% or more in simulation. And then in the bottom, you'll see the breakdown of the different roles of the people that responded. So of course, not all of it will add up to 100 because people added multiple roles. And in terms of educators, we had about 65%, and some of the other items here, but asked whether or not some of them were at the directorship or administrator level. So we combined all that, which is about 45% here. You see highlighted at the bottom of the slide. So one of the key questions that we asked was whether whether they've shifted you or not from distance simulation and whether or not people converted to distance simulation following COVID-19. So you see up there, statistical simulation activities prior to COVID-19 was around 28%. And that went up significantly, as you can see here, to about 70%. So you know that if you're running some statistical analysis, you can easily find that a significant improvement is there. And we'll next find out some of the nuances. There's that went up and down in terms of folks who are actually conducting it. We're currently conducting about 60% distance simulation in those organizations. And it was the first time they really used it. And then for folks who were using distance simulation previously, about 7% stopped using this, which I thought was a very interesting dimension as well. So, oops, here we go, next slide. Apologize. So the questions we were asking about how and whether or not people were thinking about continuing on moving forward, you could see that between March and May of 2020, we were about 50%, and then September, November of 2020, we went to 55%. In hybrid and in-person increased from 16 to 40%, and in-person simulation has increased somewhat, and long-term plan to go hybrid is 82%, which is quite significant. So we also asked what kind of factors have prompted organizations to develop student sims. So you know that what are some of the things that motivate them to develop this. So they're highlighted here in the top 3 factors, which were access to technology, access to personnel, and interest in simulation instructors. So you know the fact that they have to have access to technology and access to personnel, then there's interest from the simulation instructors, were all that drove people to develop distance simulation. So you know, directors and so forth, these results seem to be consistent regardless of the roles, but it seemed like there are needed to have some form of infrastructure as well as personal educators to really begin rolling this out. So I think that might be something important to mention. So participant locations, we looked at where they were happening, where they're administered, and where participants were. So we were looking at procedural simulation, so that's where happening, and there's a lot of numbers here, but just to highlight some of the different trends, you know, if we look at different participant groups, at least for the procedural simulation, it seems like it's still happening in person than being online. And you'll see a majority of whether you're a learner, instructor, so on and so forth, that this is still happening in person rather than being in any other modality online. So that's sort of showing the highlights of that. So we move from procedural now to clinical event based or team-based simulation. And now you see that right now you are seeing a little bit more of the online presence here. So not only were we looking at within in person, the separated and also the non-separated, but the synchronous online interactions begins to see a much heavier modality when it begins, being the clinical veteran team-based simulation. So then we've got our standardized participants, we're looking at here. Contrast that data with the simulated patient settings. So here in the simulated patient settings, it's interesting that you see now, you can see not separated versus synchronized. Depends the difference on where the learning is occurring, which does make sense. So we were asking questions about reasons for developing simulation at your center during the pandemic. You know, early we looked at factors, and now we're looking at the reasons. And the predominant reason was being from the center leadership. About 70 or 50% of the respondents said, you know, that this is something, so leadership is very important. When you restrict the respondents just to the directors or administrators, is actually going to go up to 80%. So leadership is also an important piece. So our objectives and transition from distance simulation during the COVID pandemic, we asked 3 different prompts. Are you continuing the things that you're offering prior? Are you basically considering the same activities, which seems to be the highest? And it was just, like I said, it was just very interesting how continuing their existing simulation offerings was going to be, was still going to be happening. So we look at distance simulation. It's a bit of a busy slide, but still break down that for the first part and the second part of the top. So what is sort of your long-term plan? And that is, as you can see, that they're going to be continuing sim, new distance sim, and continuing what they've been doing since COVID and maintaining a hybrid. But which is great because it looks like it's a very important way people see that there's a lot of value in it. So if you, oh, sorry, I keep jumping forward. There we go. Here we go. Sorry. So we have here just so under 50% is where we see education for this, right? And simulation that's actually happening, and a bit lower simulation text, which is about 32%. So perceived satisfaction of the simulation center. The top 3 groups express the highest level of satisfaction with leaders, the educators, as well as organizational leaders. But they kind of rank down here. And then we have our p-values. And then we restrict this question just to the simulation directors, what we perceived as the most beneficial. They actually were very happy from a leadership perspective, and about 12% greater than what you might see here. So slight difference in terms of those respondents as well. So then we're looking here, types of simulations that were currently done. Types of simulation. So the type of simulations offered using simulations. So there's, of course, a whole lot of variety of different offerings, but a term, the top, I'd say the top 5 is highlighted here. The highest being, you know, orientation and competency training, and that's basic training tasks and continuing ed. It was quite interesting what sessions of utilizing it for. So limitations and challenges. The open survey design means that we cannot calculate the response rate because we don't know the denominator for the population that accesses the survey. However, administering the survey in this way allowed us to reach respondents that may not have otherwise had access to the survey. It is also possible that the relatively significant time commitment required to complete the survey may have led to systematically fewer responses from members of the simulation community who are busier with simulation or clinical work, evidenced by the fact that 12.5% opened the survey but did not complete it in any meaningful way. So in order to protect respondents' privacy, we made all questions on the survey optional, except for the first 2 noted earlier. This meant that some respondents did not have to answer all the questions. This is particularly relevant for demographic questions where we could not always decipher how many respondents came from an individual institution. This may have led to a non-response, to item non-response error. So what factors or issues do you think have driven a rapid engagement with distance simulation? In addition to the stats results, we also asked a specific question for people to articulate a little bit more about where their drivers were, so that the driving factors behind what they're kind of pushing them towards a distance simulation. So I guess we want to pose a question to you. What kinds of things do you feel like have driven the rapid engagement with distance simulation. People can maybe put some notes in the chat if you want. That would be great, but it's just, like I said, it's just something that we were curious about. So some of the qualitative data that were the open text, these are some of the things that we found were some of the drivers. So regulations in so many places were some form of lockdown, where we're working to reduce capacity. It could also be social distancing requirements or reduced capacity requirements for the institution. So that was a very common driver that we just couldn't do face-to-face. As someone mentioned, there was also some missed opportunities because of the urgency of things being needed to be done like yesterday. Those are just some of the drivers we got from the open-ended questions. So here we've got, are the questionnaire regarded on modalities, specifically what kinds of simulations do participants and how they do it. We collected 291 answers. The majority of procedural and mannequin simulations do not take place remotely, while standardized patient simulation and software simulations were more widely used remotely. Note that the software simulation and virtual reality are not used by 33 and 50% of the respondents. This one, when we wanted to compare experiences of preparation and realization that this is simulation by comparing with in-person simulation. Overall, the educational aspects of simulation are more difficult with distance simulation, as we can see on the predominantly darker bars on this graph. But not only teaching, but also for the development of simulation development sessions. Simulations follow a structure that we have summarized in 3 stages: pre-briefing, the simulation, and debriefing. Unlike the educational aspects, we found more variability in the answers, analyzing the ability to carry out the 3 stages of simulation as described above. The distance pre-briefing is not more challenging for 62% of the respondents, while the distance simulation is more challenging for 67%. So, the last questions had to do with the location of different people needed for the simulation. We chose 3 types of simulation: procedure, team-based, and simulation with standardized participation. Standardized participants. For the clarity of the results, percentages of answers for the active learner category is written on top of it. For procedure simulations, active learners and instructors are present at the sim centers, as you can see here. So, some more data. Oh. Okay. So how are simulations technicians and educators prepared for distance simulation, if at all? And how imperative is training? Surprisingly, question 15 and 16 were not statistically significant for training, care session development, or training prior to teaching. It's as if people were just thrown into the distance sim world and winging it for the most part. This is concerning in that we know as an effective method are being used and if teaching is being received as planned. This likely has greater impact on learners or overall patient outcomes. Could this be a curriculum training that is developed, disseminated by a sim work? Potentially. What topics need to be covered for adequate training and how do we ensure it? This was question 18 and 19. Interesting in the fact that 31% were trained for developing distance sim sessions, and this was statistically significant. However, more than 2/3 were not, which is very surprising. Again, did places just wing it or figure it out as they went along? And are there plans to promote training to make distance sim more seamless? So more training was placed on technicians versus faculty educators. It's an interesting finding. The training environment. If we bend over the condition that fostered distance simulation, whereas to continue or to start at the occasion of the COVID-19 pandemic, we observe that access to technology and human resources are an essential element. The knowledge of the necessary resources is a critical point to help spread development and improvement of distance simulation. This, with the support of instructors, organizations, and programs, is probably what they should convey learners and undecided staff to move us all forward. Knowing how resources are important to implement distance simulation, a blind spot, sort of a blind spot still, at what point does the lack of technical and or human resources may prevent or slow distance simulation to happen? So some of the instructors volunteered for distance simulations, others were chosen by leadership or had to convert because of their assignment as faculty. Uncertainty and lack of preparation may scare instructors off. It is likely that training may help in facilitating and reassuring staff. Training characteristics. Even if results are better in pre-existing distance simulation programs, educators and simulation technicians were not enough to undergo a specific training, and among those, hardly 50% got it prior to distance simulation. We couldn't imagine that the training would have been more developed in new distance simulation programs, but that was not the case. That may be a cause for discomfort for instructors, simulation techs, and poor learner experience. Based on this observation, we may want to encourage more formal training for staff, hoping that they may improve distance simulation quality and the experience for everyone. The training content was equally balanced between two major axes: theoretical training, teaching, and learning considerations, and technical skills for platform training for instructors, and more focus on technical side for simulation technicians. Those results give us the when, why, who, what for the training of staff prior to distance simulation. Future directions. We were thinking about, when we were going through the data, one thing occurred, and you heard about that, 60% of the people who were doing distance simulation before the lockdown, and there were many that did not have prior experience. The picture that emerged was one of people that had a lot of experience with simulation, kind of doing what we do and adapting, right? So it's like you've got these experts who took their knowledge and made it work. So how do we convert this scenario from going forward? We took what we knew and made it work, but we've now got a model, so it's the opposite of what we think. Like, we do this all the time, but we've really gotten good and adapted as we've needed to. So we need to make sure that we have a model going forward, so when these things happen again, that we're always prepared, because it's been going on for quite a while, and there's a good chance there may be something else down the road. And we always need to be prepared. And simulation is a model by which we can utilize. So some of the questions that came up is, what competencies would be ideal for implementing distance simulation for faculty and staff? What types of training could be best used for faculty staff development in order to optimize distance simulation? And what outcome measurements would be the most useful for determining future uses directions for distance simulation? So for our future, some of the things that we're looking at the summit, we did the summit, the scoping review of the survey, phase 2, which is happening, scoping review and consensus meeting. And we're going to do more work, and we are planning on getting folks together at the 2023 SSH Research Summit to discuss even more opportunities that have been identified. So speaking of IMSH, hopefully we're going to see you all at as many as we can see under the circumstances, because the recent changes with the Omicron and travel restrictions. Hopefully people who cannot join us in person, we're looking at this point, over 1,500 folks have already signed up. We have, I believe, over 100 people join us virtually for IMSH, which our theme is appropriately reunite, connect, and advance. It's January 15th to the 19th. If you're interested in getting more information, there is a link here for you and like I said, we're so very excited about us having the opportunity to see each other again soon. So remember, this is some of the information you can find on our website, which is SSIH.org. We have our journal, we have our dictionary, and our code of ethics, which have been, as you know, translated in multiple languages. We are incredibly appreciative of all of our affiliates who have helped us along the way to ensure that we have the latest and greatest for our members. So here's my contact information. I very much appreciate you having taken a few minutes, learning a little bit about some of the activities within SSH in the field related to these very challenging times. That's my contact information. And if you have any further questions or comments, feel free to contact me. Thank you again for your time. Take care.
Thank you, Dr. Jolly. That was interesting and eye-opener. I think probably we're moving to the new normal. The findings are telling us that probably, although the COVID has impacted new things, but probably people are adapting very nicely and might adapt this for even without COVID. I'm not sure whether other panel members have any questions, because I don't have any questions. Dr. Amina, do you have anything?
No, we don't have any question. I think Dr. Julie's presentation was very thorough. Thank you, Dr. Julie.
Thank you very much, Dr. Julie. And I think this time is over. Thank you very much.
And now we move the mic to Dr. Abir. Thank you, Dr. Abir, for staying for this time with us. يعطيك العافية يا رب.
Assalamu alaikum. You can hear me well? All right.
Yes.
So I waited 10 years for this moment to be happy to present to you the next keynote speaker. Dr. Michelle Chu is going to speak to us about staying safe, optimizing opportunity, harnessing simulation to weather the pandemic storm. Dr. Michelle Chu is an associate professor at the Department of Anesthesiology and Pain Medicine with a cross appointment with the Department of Innovation of Medical Education at the University of Ottawa. Her academic interest is focused on assessment of competence and faculty development. She is currently the Vice Chair of Education in the Department of Anesthesiology and Pain Medicine. She has been the department simulation director for 9 years, with through those years working with the Clinical Skill Center on developing curriculum that graduated 65 fellows that who have gone to lead the simulation education in Canada, in Saudi Arabia, Australia, United Kingdom, and China. She's also was the director of exam material development at the Royal College of Anesthesiology Examination Board, and she is an educator at the Royal College with interest in integrating simulation in education and healthcare system. So without further ado, I would present to you, Dr. Chu, my 2010 fellowship simulation supervisor.
Thank you, Abir. That's a lovely introduction. Do you hear me okay?
Yes, we can.
Okay, perfect. I'm going to share my screen. And can you tell me that do you see my slides?
Yes, we can see you.
It's loading.
Do you see my slides?
Yes.
It's loading your slide, but we can see you.
Okay, perfect.
So just a moment. We can see you, but yes, now we can see the slides.
Now you can see the slides? Perfect.
Yeah.
Well, thank you again for the kind invitation to speak today. And I'm pleased to be here to speak about some of our successes and challenges in using simulation over the last stormy 21 months of the pandemic. So today I'll be describing a framework for making choices and sacrifices in medical education during a pandemic. I'll explain the application of this framework within the context of simulation-based education. And I probably want to finish off by listing some of the successes and the challenges encountered while delivering sim-based education in the context of these pandemic-induced program modifications. So let me take you back to 2020. The World Health Organization declared the outbreak a public health emergency of international concern on January 30th and a pandemic on March the 11th. That evening, I had been scanning the news from states of emergency in Italy and New York and looking up PPE recommendations. I was thinking I should organize some sim sessions to prepare. I did not think that the very next night on March 12th at 1 o'clock in the morning, I would be intubating the first potentially COVID positive patient in Ottawa, a woman with an acute abdomen coming for an emergency laparotomy who had returned 2 days before from New York City with a fever and a cough. It was a bit of a blur. I knew I needed to glove, gown, wear goggles and N95. I knew we needed to intubate a negative pressure room. I remember reading something about concerns of the neck being unprotected. I had read about doffing and donning, but I couldn't actually remember the last time I'd actually done it. Long story short, I wore far too much PPE. I did not doff before transferring the patient from the emergency room to the operating room. I remember the entire operating room being extremely stressed. We kept our trainees out of the case, and post-operatively, I kept the patient intubated in ICU because we were not sure how to safely extubate the patient. To say we were unprepared was a gross understatement. The practice-changing implications of the pandemic were only just beginning, and the explosion in literature to follow was staggering. In fact, since that date, if you search for simulation and pandemic in PubMed, you get 4,593 results, over 90% published since 2020. And if you search simulation in COVID, you get 6,286 results, all since 2020. We are clearly in the midst of a global public health crisis, but as Albert Einstein said, in the midst of every crisis lies great opportunity. Simulation educators around the world seized this opportunity, and the use of simulation has been integral to the ability of healthcare personnel and healthcare systems to rapidly respond to this crisis, as you can see from the previous two talks. This paper by my colleagues in Alberta, Canada, is one example of what we've learned and what we've gained. But I think you can all agree that our learners have been equally as impacted as our patients and colleagues. For them, all formal educational activities came to a screeching halt when the pandemic was declared, and yet they still needed to learn and progress in their training. So how do we make these choices in education, and what do we choose to sacrifice? This paper was a collaboration between educators in Denmark, Singapore, New Zealand, and Canada, and in it they outlined a framework for making these difficult choices and sacrifices. Now, this table in the paper summarizes the considerations for making these decisions. It's difficult to read, so I've taken the liberty of simplifying it here for you. So first of all, we have to consider what can we continue intact no matter what? What can we postpone, but it still needs to happen as is? What can be adapted, changed, or run in a different way? What can be dropped entirely? And finally, what needs to be added? And for each of these 5 areas, we need to determine how to enact them, the impact of doing so, explore the options, opportunities, constraints in doing it, and consider what worked, what did not work, and what can we learn from this. So what I'd like to focus on next is the impact of using this framework on sim educator responsibilities and obligations in the initial phase 1 of the pandemic in Ottawa, Canada. And this is an overall summary of what we decided to continue: summative assessment. We postponed our formative assessment. We adapted our scenario implementation and debriefing. We dropped our trainee interprofessional simulation, and we added faculty interprofessional in situ simulation to our practice. So I'll outline some of the challenges we faced, some of the surprising opportunities that were presented to us, and how our nimbleness has changed our educational practice. So I'll start first with what we added. So as you all know, at the beginning of the pandemic, there was an onslaught of change in almost every aspect of how we care for patients in the operating room environment. We needed to provide opportunities for our staff to practice, working in different locations, wearing uncomfortable and time-intensive PPE that made it difficult to see the patient, see and hear each other in our monitors. We had to perform a different sequence of actions using brand new surgical safety checklists, a new cognitive airway aid, and nothing was the same as before. And what we needed to focus on were the foundational aspects of our everyday practice. We needed to pull it together fast, we needed to do it well, and since the Ottawa Hospital is one of the largest tertiary care centers in Canada, with over 1,271 beds, we needed mass delivery. The logistics were a massive undertaking, like Mount Everest. Normally, we meet with stakeholders over weeks to months prior to implementation to determine the educational needs, develop the scenarios, ensure we have the proper equipment, and we do a practice run of each scenario with all stakeholders present and work out all the kinks. With the rapid response pandemic readiness training, we created the surgical safety checklist and the airway cognitive aid. We created new operating room standard operating procedures. We developed the scenarios. We did not do a dry run, and we started to deliver the entire initiative within 4 days, which we developed over the weekend after Canada closed its borders in March. And like Everest, it was a massive undertaking that involved a massive amount of people, and it required a big push at the end. The IPAC and PPE training began 3 days after mobilization. Simulation training launched 2 days later, taking into account all of our evolving protocols for infection control, airway management, checklists, and perioperative patient flow. We ran 2 scenarios, a stable COVID positive patient presenting to the operating room for emergency surgery, and an unstable COVID positive patient presenting in the emergency room that required urgent intubation. So our successes, well, we trained 150 staff in PPE donning and doffing procedures over 2 days. We enabled some of them to become PPE champions to continue faculty development over the course of the next few weeks. 239 staff participated in the simulations over 3 days, 99 anesthesiologists and 34 surgeons, all staff, residents, and fellows, and 106 additional healthcare workers, including nurses, anesthesia assistants, and operating room attendants. The feedback from the participants was very positive, and better yet, I was able to generate a list of crowdsourced suggestions for improving the environment and working protocols to feed forward to hospital senior management. And training at both sites of the Ottawa Hospital perioperative staff was done 7 days after our very first group meeting. However, there was a challenge that we did not expect, an unintended consequence of our mass delivery of simulation training to our colleagues. About 4 days after the simulation training, our simulation educators were informed by the hospital occupational health and safety that one of the simulation participants was being tested for COVID. All healthcare workers who came into contact with that individual needed to be risk stratified by the occupational health according to the time spent in close proximity, the type of interaction with the index participant, and they were given instructions on how to proceed, to self-monitor, self-isolate, work or not work. And because of Personal Health Information Protection Act, we were not given any details on the participant, their symptomatology, the reason for testing, or outcomes of contact tracing. And as you can imagine, this created a great deal of distress amongst all of the people affected, in addition to the impact on staffing in the hospital. And as far as I know, the test came back negative and there were no transmissions between individuals. So I just want to point this out because the risk to simulation participants have rarely been reported and generally overlooked. And the usual risk to healthcare workers during training via simulation has really been focused on psychological safety consideration, as Dr. Cheng outlined in his talk. I don't have time to go into some of the details here, but if anyone's interested in our suggestions on mitigating risks of virus transmission during simulation-based pandemic training, we've summarized them in a table in this paper, which you can access via the QR code. So subsequent to this, we pivoted to the creation of 360 spherical videos of these scenarios. And here's an example of a still shot of one of our 360 spherical videos. And this particular clinical situation is the awake tracheostomy on an awake COVID positive patient. So the inset in the top left corner of the screen shows the view of the procedure, while the main screen shows the interactions between the surgeon, the anesthesiologist, and the surgical assist. The arrows on the top corner indicate how you can move the view using the arrow keys on a keyboard. Otherwise, the easier method is to use a mouse. Or if you have a VR headset, you can also watch the videos on a VR headset. And these training videos, along with others that we've created, are freely accessible to anyone who wants to view them. We now have 17 videos on our website, and some of the topics are shown here. You can also access this website via the QR code. So on to some of the other choices and sacrifices we had to make. And I'd like to leave the discussion of what we needed to adapt to the end of our talk. We decided to continue summative assessment and postpone our formative assessment and drop our interprofessional simulation. And you may be asking yourselves, given the sudden absence of clinical exposure for our trainees, as we were on lockdown and doing life and limb surgeries only, why did we choose to continue with our summative assessment simulation and postpone the others? Well, a little bit of this requires a bit of background on our training program. We transitioned to a competency-based residency training program in 2015, 2 years ahead of the rest of the anesthesia programs in Canada. And one of the backbones of CBD, or Staff Competence by Design, is frequent and multimodal assessment. Assessment in CBD can be supplemented by simulation, which, as you know, sits at the shows how level of Miller's pyramid. And we integrated sim-based assessment of competence into our program as a way of providing robust assessment data to our competence committee. And they depend on this data and they use it to make promotion decisions on whether to advance residents to the next stage of training. So put another way, let's review some of the tenets of a robust assessment program, indicated here by the carved mnemonic. So C stands for several things, first of which is cost effectiveness. Any assessment model needs to consider the related costs, practicality, and feasibility. We need to make sure that there's cohesion of different assessment pieces being used in the program. We need to make sure that all the relevant competencies are addressed in a comprehensive way in the program of assessment. The assessment model needs to be acceptable, not only to the learners, but also the specialty, the faculty, the certification body, and the society at large. We need to make sure that the consistency of the decisions being made are high, as well as making sure that the assessment itself is measuring what it intends to measure regarding the validity. And finally, we know that assessment drives learning. So it's important to make the assessment worth learning towards. And learners improve by preparing for the assessment and learning from the feedback we provide. And so from that, there's a subsequent catalytic effect to improve educational systems. So given that this table here, I've modified from Norcini's consensus framework for good assessment, and it shows the relative importance of each of these tenets of good assessment when used for formative versus summative purposes. And in looking at this table, given that we were hoping that the lockdown and pandemic impact would be short term, now remember this was back in 2020, March 2020, it was clear in our eyes at that time that the summative assessments would be prioritized in our program. So what did we postpone? We postponed our formative assessments, and for us this meant our weekly PGY 2 to 5 simulation assessments. We dropped our interprofessional components of our trainee simulations, because normally we have over 2/3 of our simulations run with surgical residents, with operating room nurses, with anesthesia assistants. We decided to continue all of our summative assessments, which accounted for a summative foundations OSCE for our PGY1 and foundations crisis resource management OSCE for our PGY1s, which we use to determine their ability to take independent calls. We also continued our ACLS competency, which we run on a surprise ad hoc basis for all of our residents throughout residency. And we continued with our CANASC, or our Canadian National Anesthesia Simulation Curriculum, for our graduating residents. And this simulation assessment is a component of certification for the Royal College in Canada, and we felt that was obviously a priority to continue. So finally, what did we adapt in our simulation-based educational practice? We adapted our simulation implementation and our debriefing. And so to provide some context to this discussion, I'll just outline the impact that the pandemic had on our Sim Center operations in Ottawa. So in the spring of 2020, our Sim Center closed and went on immediate lockdown. Everything that could go virtual went online, mostly for us, our junior trainee foundations bootcamp lectures and teaching. We had instant adoption of our 360 spherical videos via the VR camera acquisition, as I've already described. And we launched our In Situ pandemic readiness training for our faculty. In the summer and the fall of 2020, we reopened our simulation center, but we were only allowed markedly decreased numbers inside together. And this resulted in an increased number of groups with increased faculty needs, and it highlighted a need in our department for more educators. It forced us to trim down and prioritize our curriculum, as I've described. And we needed so much flexibility in everything that we were doing, especially with respect to the scenario implementation, which I'll describe in a minute. We also switched to virtual teaching of our simulation fellows, and I'll go into that a little bit as well. And I know that Dr. Cheng has already well described virtual debriefing. In the winter of 2020 and the spring of 2021, our simulation center was seconded by public health as Ottawa's only vaccination center, at least until March 2021. And that moved us down to the basement of our simulation center. So we were relegated down to 2 rooms. We had no cameras, no control room, no debrief room. It was a large closet we still had to do our Can Ask and other assessment center sessions in the basement with no recordings. And fortunately, we have very sim experienced and highly adaptable learners. And in doing so, we had to take into account several factors, which I'll be describing. In summer 2021, we actually continued as a simulation center, as a vaccination center until well into the August of 2021. And then we finally got back into our usual space at that point in time. And currently in the fall, winter here, where we're running in our usual space with modified numbers. We've resumed our interprofessional simulation, but unfortunately, due to the clinical burden with ramping up in the operating room, we've had, it's been difficult to have our allied health and nurses participate with us. So let's go into some of the details about the scenario implementation. So due to loss of clinical exposure for our residents, we strongly advocated for simulation-based training in midst of a time when the hospital and public health would not even allow us to gather together in a conference room. So fortunately, we had very strong advocates. But when we did eventually begin to offer formative sim again, the one word that comes to mind is flexibility. We had rapid changes in our staffing with increasing and decreasing numbers due to the need for isolation and self-monitoring that came up depending on whether or not they've been exposed to a COVID exposure. It forced us to write scenarios that could flex with the changes in the participant numbers, in the staffing numbers, in the location that we were running our simulation in. For example, we ran a 2-mannequin trauma simulation with 4 trainees, 6 fellows, 3 staff, and a simulation operator in one large conference room. Not what we're used to by any means, and we'll talk a little bit about the realism issues that came up. We had to implement COVID-related changes to the simulation scenarios, especially regarding AGMPs and cardiac arrest arrangements. We had to include goals of care discussions with our sim scenarios. And we really had a lot of investment by our faculty in adjusting to the scenario implementation on a daily basis. The other thing I wanted to bring everyone's attention to is the pandemic pre-brief, is what I call it these days. And in addition to the usual emphasis on the variety of issues in the pre-brief, we really had to reinforce the fiction contract, asking people to suspend disbelief and previewing a little bit about what could be expected, especially when we were running in the basement of the sim center. We had to make sure that we gave reassurance for IPAC concerns. Physical safety, hand sanitizer was a normal prop in our center. And we addressed all aspects of realism very, very carefully. And by realism, I mean the physical, conceptual, emotional, and sociologic realism. And if you want to read a little bit more about these types of realism, I direct your attention to these 2 papers here. And physical realism was a challenge. We were doing simulation in conference rooms, in basements. There were none of the usual physical props or equipment that we had to try to help with buy-in. We weren't initially allowed any gowns on the mannequin because they were worried about fomite transmission. The emotional realism was extremely heightened in the scenario because everyone was imagining what would happen if this really was a real patient with COVID. And so that was quite profound. And the sociological realism was in jeopardy because we didn't have the interprofessional simulations and we weren't sure, even if they were scheduled to come in with us, if they'd be able to show up. We had an unpredictable loss of participants, and that affected the sociological realism in our scenarios. In our adapting to debriefing, we actually kind of needed to do a little pre-brief of our debrief, again, to acknowledge some of the physical safety requirements and reassurance. So not just the emotional or psychological, but also the physical. We did wellness checks as a regular part of our debriefing, and that's actually a real important part of our debriefing now, and one of the successes that I'll talk about. We switched to virtual teaching of our simulation fellows. And so Dr. Cheng talked a little bit about debriefing virtually, but we ended up figuring out a way to teach our fellows how to debrief virtually, and then we taught them how to debrief their debrief virtually. So we've continued with this online, and we were about to move back to in-person sessions with our learners, but then the Omicron variant. And as you know, just last week, the Omicron variant surface. And in Canada, the first cases were detected in my city of Ottawa. And daily headlines are exploding, and it looks like we may be bracing ourselves for another COVID storm. So it's really critical that we look to our successes and we remember the challenges that we overcame when we're faced with ongoing waves of the pandemic, I think. And so I just want to spend a few minutes to outline some of the successes that we had. So the first was that for the first time, we prioritized faculty-based simulation CPD over trainee education for the first time. And there was huge uptake by our clinicians. We strengthened our community of practice of simulation educators. We had buy-in from skeptics who never would have participated in simulation had they not felt a personal threat by the pandemic. And hospital senior leadership greatly valued our contributions. We empowered our faculty to be PPE champions, to teach each other, to use the 3R videos for continued learning. We were able to justify and continue our high-stakes, high-quality simulation assessments, and we had very little loss in our formative sim program, fortunately. And finally, the wellness checks that we have in our debriefing is now routine, and that's been a really important point of making sure that we boost morale and wellness in our program. Some of the challenges, well, mass delivery of sim leads to physical risks of COVID transmission, and we learned that firsthand. We needed to ensure physical safety, and that's been top of our mind whenever we run our simulation scenarios. We had suffered educator burnout and fatigue. With the constant scenario revisions, the flexibility in implementation and debriefing, on top of everything else that was going on clinically and personally and professionally, it was very, very difficult. And we really, on the flip side of that, I think it really brought us quite much closer together, as I've indicated, as a success. But I think that was the important thing for us to recognize. And finally, it was a challenge to be able to teach how to debrief virtually. Again, we've become quite accustomed to that. So over the last half hour or so, I've described how we've described the framework for making choices and sacrifices in medical education, specifically within the context of a simulation-based environment. And I've listed some of the successes and challenges encountered while we've delivered simulation-based education in the context of pandemic-induced program modifications. The pandemic has really brought into clear focus the underlying rationale and the fundamental advantages of simulation-based education. And seeing as the origins of sim-based education were in crisis resource management, I'll leave you with these words from Bill George, the former CEO of Medtronic, who wrote in his Wall Street Journal article, 7 Lessons for Leading in Crisis. Never waste a good crisis. When things are going well, people resist major changes or try to get by with minor adaptations. A crisis provides the leader with a platform to get things done that were required anyway and offers the sense of urgency to accelerate their implementation. So I'll leave you with those words, and I thank you very much for the opportunity to speak with you today.
Thank you very much, Dr. Chu. While we're waiting for any incoming questions, I would like to thank you first to demonstrate to us how resilient simulation system can help us build a resilient healthcare simulation system. So I see one of your challenges is that developing or delivering mass simulation, and I will training all these people in a very short time in the hospital, because and I'm sure all centers had the same challenge. How about, did you have to do any faculty development on the run, increasing number of simulation tech or support or facilitators? How did you overcome that part?
You're very familiar with our environment here in Ottawa, Abir. We're very fortunate that we were able to lean on each other. So simulation educators from obstetrics and gynecology, from anesthesia, from medicine and critical care. Not so much critical care, they were a little busy. And actually medicine as well, come to think of it, because they were ramping up their COVID wards. We banded together to run this. So the anesthesia team worked over the weekend to develop the scenarios. And then we pulled our surgeon colleagues in to help us deliver. The scheduling was in order to get that many people through, and we actually had to do it within daytime hours. So we did not run past 3:30 due to union considerations. So we double teamed it. So we ran 2 simultaneous in situ simulations at the same time. So we would run a simulation and then run a debrief with 2 teams. So one team running in one operating room with 10 to 20 participants, and then another team running in a separate room. And then we would switch. So the participant group would move from one to another. And so by doing this, we were able to get the volume of people through, and we had all of our simulation educators on board. And the reason for that was because we went into lockdown and we canceled every elective list, and we only did life and limb. So all of a sudden, there were people who were free to attend when normally they would be working. Now, in life and limb, that means that we went from about 20 ORs down to about 5. So we were still running rooms. And it was more of a challenge to get the participants out to come and participate than it was for the simulation educators to run the actual simulations. So we had people scheduled as relieving physicians, relieving nurses, and there was another person in charge of scheduling and making sure that all of that went on clockwork. So it was quite a logistical challenge for sure.
So I believe that some of those fellows in your center who felt sorry for themselves to miss opportunities, that another door of opportunities of learning has opened for them through that time of crisis. So I guess this is what we have. We are reaching the time limit for our session. I'd like to thank all our speakers and moderators, and take it back to Amanish. Is there anything else?
No, thank you, Dr. Abir, and thank you, Dr. Michelle. Thank you for everybody who's attending also on the platform, and for all speakers and moderator, the judges. I think we had a very great day today, waiting for you tomorrow at 9 a.m. And just another reminder that tomorrow we have the appreciation certificate and the answer for all the yes, exactly. We're very excited. I'm very excited. And we're going to announce the winner for the Mulaj and the competition, the briefing, and the Simdori. Thank you so much, and see you tomorrow, inshallah, at 9 a.m. Thank you so much. Thank you, Dr. Abir, for staying late with us, and thank you, Dr. Hood.
Thank you very much.